alphabetical names. So names starting with A will be presenting first, and so on and so forth. And markings will be out of 10. Everyone, all presenters who are crossing 6 minutes will be having -2 deduction of their marks. So be careful for our presentation. If you are crossing the time limit, you will be having deduction of marks.
And now I would like to invite ma'am to the stage for live demonstration of the ultrasound imaging of the shoulder joint. Thank you.
Good afternoon, everyone. We are going to do ultrasound of the shoulder for this gentleman. I'll walk you through the live demonstration of how an ultrasound is done, and we'll talk about some clinical tips and tricks that are important for us radiologists to know, so that we are in sync with what the clinician is asking the ultrasound for. Many times we get lost in doing the ultrasound, but we are not answering the clinical question. So we'll try and look for that. And I'm sure that a lot of you are already doing ultrasounds, right, in your clinics. Let's see a show of hands. How many of you are doing ultrasounds? If I can see a few hands. All right. So what is the most common reason why a patient would come to you for an ultrasound shoulder? That's the first thing. What is the most common reason? Anybody? Yeah? Say louder. Indications for ultrasound? So rotator cuff tear? Yes? Basically there's a patient who comes to you for pain in the shoulder. Okay? The possibilities are patient can have a subacromial subdeltoid bursitis. The patient can have tendinopathy of the cuff. When I say tendinopathy, it can be tendinosis, or it can be a condition where the patient has a partial or full thickness cuff tear. And another reason why patients come to us is for adhesive capsulitis or frozen shoulder. So these are the things that we will first of all try and locate what to do when we do an ultrasound shoulder. So patient Now there are a lot of criteria of how you should go about doing the shoulder. So if you look up, the AIUM has a criteria for shoulder ultrasounds. You can either go by that criteria, or you can have your own system of how to go about ultrasound. So we'll start with the gentleman sitting straight at us, or he can be facing towards the foot end of the bed. Alright? His hands will be in a relaxed position. Remember that this shoulder is in pain, okay, so you don't want to do all sorts of things to the shoulder. So he will be in a relaxed position. If he is not relaxed, one can also put a pillow and ask him to sit like this in a neutral position and be comfortable. When we do any sort of MSK ultrasound, remember that holding the probe is important. Unlike OB/GY ultrasounds, where we are moving the probe like this, we are not moving it when it comes to MSK. In MSK ultrasounds, our fingers, at least two of them, should be touching the patient, and the probe is only moving slightly. So there will be only slight rotations of the probe, either side to side, or we'll heel toe the probe like this, right? So we are not doing major movements of the shoulder, and this is something to first of all remember when you're starting to do ultrasound of the joints. So what we'll do is, this is the easiest way to start an ultrasound, and this is also the best place to come when you get lost, okay? So when you go to a big fair or a shopping mall and you tell your children, right, so if we get lost, you meet me here. So this is the point where if you get lost, you meet here, okay? Okay, so now this is that point. When you see this pointer, when you see this sort of a saucer appearance, this is actually the intertubercular groove of the proximal humerus. And the medial side of this groove is the lesser tuberosity, right? Okay, so this is the groove. Now This groove is formed by the lesser tuberosity. The medial side of the groove, you will see the subscapularis tendon. This is not the right place to examine the subscapularis, but you will see the subscapularis at the medial side of this groove. The lateral side of this groove here is this bony ridge, this bony margin of the lesser tuberosity, to which the subscapularis tendon will attach itself, right? And within this groove, what we see is the biceps tendon. This is the long head of the biceps. Okay, it has a longer part, so it's called the long head. We also have a short head of the biceps, and that originates from the coracoid process. All right, so this is the coracoid process, and this small little black structure is the short head of the biceps. But we are looking at the long head of the biceps. Now, this long head of the biceps has an intra-articular origin on the supraglenoid tubercle. Right, we know that. That is the intra-articular portion, and then it loops around. So this is where it loops around and becomes extra-articular. So that loop or that bend is called the genu. So you want to look at this genu of the LHBT as well. So this is the loop, this is the genu of the LHBT. Why is this important? Now a lot of you may be practicing MRI, and you will see that most bony attritions and irregularities and arthritic change will cause spurring to occur in this region, and these nasty spurs will kind of impinge upon this genu of the LHBT, and it will cause tendinopathy. Okay, so you might see an enlarged tendon, you might see a torn tendon, etc. So what we are doing is basically we are finding ourselves in this position, right, where whenever we get lost, we see when we find ourselves in this position, and we look for the long head of the bicep. So every time I am lost, I come back. Now as you are scrolling down, you will notice that this biceps tendon kind of disappears. And anybody knows why that happens? Right? This is the anisotropic artifact of MSK ultrasound. If your probe is not perfectly perpendicular, at some point of time, you will start to see the structure becoming more hypoechoic. This is not because the structure is abnormal. So see, if I move my probe slightly, if you see the position of my probe, there's just an angle, small angle, okay? So here it becomes hypoechoic. It feels like this is an empty sulcus. And here when I turn it up, you can see the tendon very well. So this is anisotropy, right? As the biceps tendon goes down, there's a 20% tilt in the tendon, and that is why you're going to see this anisotropy. So when this happens, you have to tilt your probe either up or down and find the tendon. So I know that this is my tendon, alright? So this is how much movement you should be doing in any sort of an MSK ultrasound. And then we are going to make the tendon in long axis. So now you are seeing that this is the cortex of the humerus, and this is the tendon that is lying on top of this cortex of the humerus. And if you look in this tendon, you are seeing a fibrillar pattern. You can see the collagen bundles that are arranged in a nice tight fashion. This is type 4 collagen, and this is a normal looking tendon. If you see that this fibrillar pattern is lost and there is haphazard fiber arrangement and the tendon is enlarged, then it is tendinosis. Tendinosis is a degenerative condition of the tendon, whereas if the fibrillar pattern is present, so you can see these fibrils, can we zoom this, can you see this? If the fibrillar pattern is present but the tendon is enlarged with some fluid around it, in fact the fibrillar pattern becomes more conspicuous, more prominent, then that is tendinitis, okay? So that is a tendinitis, and the other concept is a tendinosis. So you can see these small dots in the tendon. So this is the fibrillation or the collagen bundles. Okay, so this is a normal tendon. Now when you're looking at this biceps below, you also want to go up, and this point you should not miss. This is the genu of the intra-articular LHBT, and as I told you, most of the times pathologies occur in this point, alright? And the patient will come to you, the clinician will tell you the patient has anterior shoulder pain. If the patient has anterior shoulder pain, most likely the patient has bicipital tendinitis or tendinosis. If you don't find bicipital tendinitis or tendinosis, then start to go upwards. Go upwards and find the tendon in the the marker. And find the tendon in this groove. So try and see for this genu. So this is one small tip to remember, that every time you look at biceps tendons, don't just look at it in the sulcus. Okay, when you're looking at it in the sulcus, remember that there is an anisotropic artifact. Go up as much as you can and look for this tendon at the genu. So now this brings us to the next part of the shoulder examination, and that is the bicipital pulley. Okay, so this is the region of the anterior rotator cuff interval. Zoom. Yeah. So what we are going to do is, we are going to just spend 2 minutes here, and this is one place which the clinicians are not mostly interested in, but as radiologists we are always interested in looking at the SGHL and the CHL. All right. So here biceps pulley, you can see that the patient's biceps pulley is housed in this groove. This groove is shallow. On top of this pulley, you can see this fiber. This structure is the coracohumeral ligament, the CHL. CHL forms the roof of the pulley, all right? And SGHL is going to form the inferior wall of the pulley. So this is the biceps pulley region, and this is the CHL, and this is the SGHL. Now in certain patients you might find the SGHL and CHL quite prominent, and in some you don't. Another reason why you should look at this region is, if you put Doppler in this region, you will see increased vascularity. If you see increased vascularity, can we put some flow in this? Yeah.
Color, no?
Color. So when you use color, and if you see increased vascularity in this region, then it can be one of two things. Either it can be a bicipital tendinitis, or it can be an adhesive capsulitis. Now adhesive capsulitis is very, very common. If a patient comes to you with pain in the shoulder, difficulty in lifting the arm, and if the patient cannot externally rotate, this patient has a frozen shoulder. Whether or not you see high signals on the Doppler is not important. Frozen shoulder has three phases. One is when it is an acute phase where you will see high vascularity, and then it goes into a state of fibrosis where you will not see high vascularity, but the patient will not have movement at the shoulder. Okay, so this is that. Now if I tell this patient to keep his elbow towards his body, isko bhaiya thoda zoom out kariye please. So if I tell this patient to keep his elbow towards his body, and if I tell him to externally rotate, aap bahar kariye, okay, dheere dheere. So when he is rotating his arm, his forearm, if he cannot rotate the forearm, or if he rotates his whole body to rotate the forearm, this patient has adhesive capsulitis. This is a diagnosis you can make even without an ultrasound. Okay, you don't need an ultrasound for that. The next part of the ultrasound is to look at the subscapularis. Okay, so we are going to come to this point again. This is that point where if we get lost, we are supposed to come back. So we are at this point, and now we will ask the patient to slowly externally rotate. Externally rotate. Okay, when this patient externally rotates, we will start to see the subscapularis tendon coming into view. So this is the subscapularis tendon. Thoda aur. Right. Now once you see the subscapularis, remember that subscapularis is a fleshy muscle. In fact, it makes up 60% of the rotator cuff. Alright? And it has multiple myotendinous slips. So it's important to see the entire muscle. This is the subscapularis here, and the subscapularis starts from this point. As we go down, the muscle finishes at this point. So this entire region is the subscapularis. Similarly, if you are going to externally rotate the shoulder of the patient, place your probe and look at the entire muscle from bottom to up. Okay, look at the entire muscle. Don't just look at one point and say it's over. The entire muscle should be looked at. And this kind of a picture that you see some heterogeneity is normal, because the subscapularis has muscle, and within muscle you have the tendon forming. So this is a common picture of the subscapularis. If we look at the subscapularis in short axis, okay, we will see that this is the muscle, and as we go in towards the medial side of the patient, you will see multiple tendon slips, right? You're seeing multiple tendon slips, then you're seeing muscle fibers, and this is the fleshy muscle belly of the subscapularis. Okay, so this is another way of looking at the subscap, and it's a useful way of looking at it. Usually you will find at least 3 tendons in the subscapularis. This is commonly seen. You'll see at least 3 tendons. So this is a short axis view. Okay, a short axis view. This can be a little confusing to start with, but it's a great view to look at. Otherwise the long axis is in this way, where you see the biceps tendon. So we're going to ask the patient now to go back. Interventions around the biceps tendon can be done in this region. You can have a needle coming in from here. Sometimes there is a transverse humeral vessel here. Can you put some color? And if there is a vein here, like there is in this case, you want to avoid this. This is the transverse humeral vessels from the circumflex humeral artery, and you want to avoid that vessel. So if I see this vessel, and if I am trying to do an injection from this region, I am going to avoid that point where I see the vessel. I'll go a little below it, or I'll go a little above it. So that's the way you would do an injection in this region. So bicipital injections can be done in this region. Okay. So we've seen the long head of the biceps tendon, and we've looked at the groove, intertubercular groove, where every time we get lost we must find ourselves there. And we've seen the subscapularis tendon in long and short axis, and we've seen it because we've asked the patient to externally rotate the shoulder. Now we are going to go to the main part of the rotator cuff, okay, where all the money is, and that is the subscapularis, the supraspinatus. So for the supraspinatus, what you have to understand is the supraspinatus goes from here, it's under the acromion, and it attaches to the humeral head, right? This is where it is going. You can feel the humeral head, you can feel the drop off of the acromion also. So obviously if I put my probe here, I am not going to see the supraspinatus, alright, and I will show you. So this is the AC joint, alright, can be seen very well in the neutral position, and you see that there is some amount of degeneration of the discus of the AC joint. There is a bit of superior capsular hypertrophy, which is alright. There's a bit of bony remodeling at the distal clavicle, which is also okay. This is the acromion process. Now if I start just going laterally, straight up, lateral, the acromion will end, and I am seeing the acromion fibers of the deltoid, right? And I am also seeing the supraspinatus, but look how I am looking at the supraspinatus. This is not a great view. This is not how we will see the tendon. What is lying between the supraspinatus and the deltoid is this bursa, and this is the subacromial subdeltoid bursa. The only time that you should be doing this sort of an ultrasound is if you are looking for subacromial subdeltoid bursa related painful arc syndrome. And what is painful arc syndrome? It is when the patient does an abduction, which is about up to 30 degrees. So when he will abduct his shoulder, he is going to start feeling a snap. There might be some adhesions, and there might be some pooling of fluid in the subacromial subdeltoid bursa. In fact, this patient has a bit of free fluid in the subacromial subdeltoid bursa, but that fluid may not always be symptomatic. So see how the supraspinatus is now gone. I can only see the deltoid. So when I bring him back, I can see the supraspinatus and I can see the bursa above it, but I cannot see the tendon very well because this is the acromion process and it hinders it. So what we are going to do is, instead of this supraspinatus hindered by the acromion and the AC joint, we are going to rotate this forward and we are going to open the tendon. So what we are going to do is we are going to turn this patient's hand. Yep. पीछे ऐसे हाथ रखिए कमर पे, ऐसे हाथ रख लीजिए जैसे जेब में रखते हैं, राइट. So once we have turned this patient's position, what has happened is the humerus has rotated forward and the acromion has gone behind. So now I have a window to see the supraspinatus. A common mistake that is done in this position is I see everyone going straight like this to look at the supraspinatus. But understand that this is not how the supraspinatus is. Now the supraspinatus is here. This is the muscle belly. Okay. The humerus has come here. So your probe has to be in this plane, not in this plane, not coronally. The probe has to be in this plane. So what we are going to do is we are going to put our probe not vertical, not horizontal, but we are going to put it somewhere midway. Okay. So when we put the probe midway like this, in this oblique fashion, is when you will see the supraspinatus. And you see how clearly you can see the supraspinatus footprint. A few things to look at here. Can you freeze? Okay. So a few things to look at. When we see the supraspinatus, the anterior footprint of the supraspinatus, how do you know if you are looking at the supraspinatus, are you anterior or mid or posterior? So a great way to look at it is to look at the footprint. If this footprint is V-shaped, okay, it has a depth, right? If this footprint has a depth, then we are in the anterior supraspinatus. Now this is the articular cartilage of the humeral head, right? And this is the fibrocartilage. So this is hyaline cartilage and this is fibrocartilage. In the fibrocartilage, you'll see how all the fibers of the tendon are attaching to this fibrocartilage and which is snugly attached to the bone. If you want to look for a greater tuberosity avulsion fracture, you would see it here and there would be free fluid. If you want to look at attritional changes or cysts, they would be in this region. And whenever you think that this tendon is not normal, it's not fibrillar, there's tendinosis, remember that there's also going to be bone changes. You can't have tendinosis in a tendon, so many changes, and bone is perfectly normal. That will never happen. So if you're getting a pathology where you are thinking that my tendon is abnormal but the bone is normal, think about anisotropy, think about replacing your probe. Turn your probe around. See, if you look at this tendon and you say, oh, this is a tear. This is a tear of the tendon. But look at the bone. It's so clean. This bone cannot be so clean if there is a tear. These are chronic changes, right? Unless this is a young athlete and has an acute tear. So that means I am not placing my probe correctly. So the trick is here to always look at the bone and place your probe correctly. And when you see this, you will know that you are now in the correct place. See, this is the anisotropy artifact. This occurs because all fibers are not perpendicular to the tendon. So you have to keep changing your tendon position and you have to keep looking at this fibers. And you should be able to see this nice fibrillar pattern of the tendon, and this is a normal supraspinatus. So coming on to the footprint again, I will show you the difference between the anterior and the posterior supraspinatus footprint, and this is a good trick that is used even abroad for making quick injections. So here you have the anterior footprint of the supraspinatus, which is a nice V-shaped deep footprint, right? And you can see all the fibers, they are all actually attaching to it, right? This is the articular fibers, this is the bursal-sided fibers. Now if I go slightly posterior, can you see that the footprint is flattening out? There is a flattening. Anteriorly it is V-shaped, posteriorly it is flattened. So this is the posterior supraspinatus, very easy. And if you go far beyond, you are going to start losing picture of the cuff. When you start losing this picture, this is the infraspinatus. Don't look at the infraspinatus here. Look at the posterior supraspinatus, look at the anterior supraspinatus, and if you come even anterior, you are going to see the bicipital groove. So you need to be in this region. When we are in this region, the question is about, in this patient you can see some cartilage calcification. Can you see that? Can everybody appreciate it? So this is chondrocalcinosis. This patient has some calcification of the cartilage. So he has subacromial subdeltoid bursitis. He also has some chondrocalcinosis, right? This is normal cartilage and here is chondrocalcinosis. So I'm sure in his X-ray, if one of you can do his X-ray, you will find something. Now, some more points to consider. Okay. Now the question is about tears. See, let's understand that MRI, ultrasound and the clinician, they all have to speak the same terms. If you write some other term in your report, MRI person has written something else, the clinician is asking a different question, all of you are in a way not communicating with each other correctly. So what we need to understand is that this is the articular margin. If a tear occurs at the articular margin anywhere, from here to there, anywhere, it's an articular sided tear, okay, or a deep surface tear. When a tear occurs at the bursal margin, so this is the bursa. When a tear occurs at the bursal margin, the tear can be here, the tear can be here, the tear can be here. It is a bursal surface tear. If the tear is extending to more than 50% of the thickness of the tendon, then it's a high grade partial tear. If it's less than 50%, it is a low grade partial tear. If at any point of time the tear goes from bursal to articular margin, then it is a full thickness tear. Full thickness tear does not mean that the entire supraspinatus is torn. Full thickness tear can occur only at the posterior thirds of supraspinatus, or it can occur only at the anterior thirds or anterior 2/3 of the supraspinatus. So try and use these terminologies: articular sided, bursal sided, and partial thickness or full thickness. Partial thickness, you can say articular sided low grade partial, or bursal sided low grade partial, or you can say articular sided high grade partial or bursal sided high grade partial. Now a lot of these tears can either be in the distal tendon or they can be in the footprint. So whenever a tear occurs at the level of the fibrocartilage, here, this is a footprint tear. Okay, so in my patient, supposing we are looking at the anterior supraspinatus here, and we are seeing, see in this case again we have found another thing. He has got a small cyst here at the anterior supraspinatus footprint, okay. So this is a small subchondral cyst. Now if we'll, एक बार हाथ फिर से पीछे करिए, we'll just save this picture and then we will, okay, save it.
Please.
Now, this is the hyaline cartilage. This is the fibrocartilage. This part of the tendon is towards the fibrocartilage. This is the footprint. If a tear occurs here, I will call it a distal tendon, articular sided, low grade partial tear. If a tear occurs here, I will call it a articular sided low grade tear at the footprint. It's also called a rim rent tear. It's also called a pasta lesion, partial articular sided tendinous avulsions. Similarly, if a bursal sided tear occurs here, I'll call it a bursal sided partial tear. But if it occurs here, I will say it is a bursal sided tear at the footprint. So this is important. Then we have something called interstitial tears. Interstitial tears do not go to the bursal side. They do not go to the articular side. They in fact occur in the interstitium. So it can occur here and they can also delaminate medially. So if you tell a surgeon that there is an interstitial tear at the anterior footprint of the supraspinatus, which is delaminating say 10-15 mm, if he goes inside the joint, he will not see the tear. If he goes in the subbursal compartment, he will not see the tear. So these are concealed tears, concealed interstitial tears. When an interstitial tear starts to dissect the bursal surface, that's when the surgeon can see it. When an interstitial tear dissects the articular surface, again the surgeon can see it. And sometimes tears can be very complex. It can have an articular component, bursal component, interstitial component, that's okay, alright. So things to remember in the supraspinatus: anterior footprint looks V-shaped, posterior footprint looks shallow, Remember that you are supposed to mention where the tear is occurring. Is it at the distal tendon or is it at the footprint? Is it articular sided or is it bursal sided? Is it high grade partial or low grade partial? Is it full thickness? And you also want to look at bone changes. If there are no bone changes and you see one hypoechoic focus in the tendon which you are going to write off as a tear, change your probe position. This might just be an isotropy. So we are done with looking at the supraspinatus. Now we will look at the infraspinatus. For the infraspinatus, what we will do is, so what we'll tell the patient to do is, take his hand and put it at the other shoulder. This does is, it gives a stretch to the infraspinatus. Now, always a great idea to change the patient's position and not yours, because otherwise I'm going to be all day in my clinic like this. So it's better to change the patient's position and ergonomically be comfortable. Okay. Now that the patient is here, note that you can feel the spine of the scapula. I want all of you to go back and feel the spine of the bony structure. So obviously, if you are looking in this region on top of the spine of the scapula, you are going to see supraspinatus. Okay. You want to look down. So put your probe down. Do not find the infraspinatus up here, because this is the spine of the scapula. This is the AC joint. What lives here is the supraspinatus. What lives below the spine is the infraspinatus. So what I'm going to do is, I can see the muscle belly of the supraspinatus, but I've already seen the tendon in the modified CRAS showed you. So this is the spine of the scapula. Can you see this bony ridge? This is the spine of the scapula. What is up is the supraspinatus. So if you look at this, you can talk about what is the muscle health. And if you see that there is no depression, okay, there is no caving in. If there is no caving in, it means that the muscle is of decent size. If there is caving in, then you can start to say that there is atrophy. The muscle will look more echogenic if there is fatty infiltration. So this is the supraspinatus. But as we go out, see, I'm going to lose the supraspinatus. I can't see it. Why? Because the AC joint and the acromion have obstructed my view. But thankfully, I've already seen the tendon in another view, so that's fine. From the spine of the scapula, and this you can see with your naked eyes, you don't have to find it on the ultrasound screen. You're going to go down. This is the infraspinatus. So this is the infraspinatus muscle belly. Again, you can see that it's more or less straight. That is the posterior deltoid. You can see that there is no caving in, which would happen if there was an infraspinatus atrophy. Then you just follow it out. So I can see that the humeral head is here. I can see that the spine is here and the infraspinatus should be here. So you should be able to draw the tendon first in your own mind's eye before you put the probe. So I've already drawn the tendon. The tendon is going to be हाथ ऊपर रखिए वहाँ पे नहीं उधर shoulder पे हाँ. Now stretch it. I'm just going to find the spine of the scapula, go to the tendon. This is the infraspinatus, and then I will start to come out. As I come out, I'm following the spine of the scapula. See, I'm not losing the spine. If I go too far down, I have lost the spine. So what I'm going to do is, I'm not going to lose the spine. As I'm seeing the spine in the corner of my eye, I'm just riding top of the spine of the scapula. Is where the infraspinatus tendon is. It's that simple to see the tendon. Just keep riding out. Kind of the corner of your eye and just keep riding out. So here is my infraspinatus tendon, and this is where it will insert. What I will change my to a long axis position. Okay? So in the long axis position, what I will see is spine of scapula. This is the infraspinatus muscle, and as I go out, I am going to see the tendon. Please don't look at this. This is the deltoid. You are looking at this. Okay? So there's a difference. This muscle, there's a plane here. As I go out, I'm going to see the infraspinatus, and I see the infraspinatus inserting again at its footprint. Again, it looks a bit dark here, and I feel like maybe there is a tear. It could be, but then look, the bone is normal. This can't be a high grade articular-sided infraspinatus footprint tear. So I'm going to adjust my probe. When I adjust my probe, I'm going to see that all the fibers are in fact intact and they have a beautiful fibrillar pattern, okay? So this is how you should be adjusting your probe as you go. Keep on adjusting your probe and make small adjustments. Don't make large adjustments, okay? That's not how it works in MSK ultrasound. And you can see the articular cartilage here is anteriorly we have which had some chondrocalcinosis. In fact, if I go a little more anterior, I can start to even see the supraspinatus. So this is the infraspinatus. This is a great way to do injections. If you do ultrasound guided injections, then this is the fastest to get into the shoulder. So what you do is you make your settings to a deeper field of view and you look at the infraspinatus, right? As you go medially, you will start to see the glenoid here. Can you put some color?
Sorry.
Color. And what you are seeing here, something pulsating here, this is the suprascapular artery and nerve in the suprascapular notch. Can we get some pulse there, no? Just put a Doppler. Pulse wave dal do. Yes, yeah. So you are seeing small traces of the suprascapular artery. Maybe we need to optimize a bit of setting, but you can see that small traces of the suprascapular artery. This is the place where the suprascapular nerve lives, and if you see this region, you are going to come with your needle from here and you are going to make the injection here, okay?
Some artifact.
This is some artifact. Actually, he has cartilage calcifications. He has capsular calcifications also. Ask the patient to move his hand out and in. You will see that this is the humerus rotating, and that behind triangular echogenic structure is the glenoid. Can you put the arrow on the glenoid, please? Back to the triangular structure which is stationary. Yeah, this. And if you look at his capsule, it looks a bit thickened and echogenic. Maybe it's calcified. Okay, so this is the region of the shoulder joint. If you want to do a joint injection, all you have to do is take your needle and bring it here. If you touch the humeral head, just retract your needle and push contrast or lignocaine or steroid, whatever you're injecting into the joint, and it will go in. So this is how we look for the infraspinatus, and this is the suprascapular notch, and this is where the suprascapular artery and nerve are present. Okay. In this patient, we are seeing capsular calcification, and this is causing some comet tail artifact. So this would complete the ultrasound of the shoulder. We have seen the biceps, that's the first thing we look at. Then we've seen the subscapularis. Then we've seen the supraspinatus by rotating it forward. We have to look at the tendon differently in the modified Kras position, and then we look at the muscle separately when we turn the patient to see the supraspinous fossa. Then we have looked at the infraspinous fossa and we have traced the tendon to its footprint. All of these, when you are looking at, please remember the bony landmarks on the patient. Don't find the structure on the screen. Find and map it on your patient and then go in. Okay. If you want to do a little more advanced imaging, you can also look at the coracoid process. Now the coracoid process is here, right? Medial to the intertubercular groove. This is the subscapularis, this is the coracoid process. At times you can see, as you roll up, you will see a ligament from the coracoid process extending towards the humerus. This roof is actually the coracohumeral ligament. If you turn the probe down and see the attachments of the coracoid process here, so this is the coracoid process, you will see this thin structure coming out, that is the short head of the biceps, and what you are seeing fleshy underlying is actually the coracobrachialis. So this is a little more advanced if you want to look at the coracoid process and its attachments. This thin structure, very small structure, is actually the short head of biceps, which later on is more fleshy, and this is the coracobrachialis. So if you have any questions, we can take them now. We've talked about frozen shoulder, where the patient cannot externally rotate, so you make the diagnosis clinically. You don't have to find anything on the ultrasound. We've talked about tendinosis, which is a degenerative condition. You will see a non-fibrillar tendon, which is enlarged, which is thickened, heterogeneous, and it's weak. It will tear. You can have different kinds of tears, interstitial, bursal-sided, and articular-sided. These can be high-grade, low-grade, or you can have a full-thickness tear. And we've seen that you can do injections in the suprascapular notch. You can make injections at the bicipital groove, and you can also do an intra-articular injection for whatever the clinical indication may be. Right? So if there's any question, we can answer that. I can show something extra if you wish to see.
Any doubts you can ask.
Thank you.
Ma'am, what is the reporting format for the shoulder joint ultrasound?
So reporting format, very simply put, I usually report the way I see all the structures. So in the report, I talk first about the bicipital groove, the long head of biceps. Then I talk about the anterior rotator cuff interval. Then I write about the subscap, supraspinatus, and infraspinatus. The American guidelines say that teres minor, doing a shoulder ultrasound for teres minor is not necessary. The shoulder ultrasound is completed when you reach the infraspinatus. You don't need to look at the teres minor really, because it has no functional disability that it gives to the patient. Then I will talk about the status of the bone, either at the lesser tuberosity, if there are any spurs, or at the greater tuberosity. I'll talk about degenerative conditions. And then I will end with talking about the bursa, the subcoracoid bursa and the subacromial subdeltoid bursa. When you describe any of these structures, first describe the acute condition, then talk about the chronic condition. So you can, when you're describing the supraspinatus, say that there is a articular-sided footprint tear of partial thickness, and then say there's a chronic subacromial subdeltoid bursitis with thickening of the bursal margins and internal debris. So always try and talk about the acute condition and then the chronic condition, and always ask the patient what his problem is and highlight that first in your impression before you talk about unnecessary details, because the orthopedic surgeon has limited time. He wants to know, this patient cannot comb her hair, what is the problem? So you say features can suggest adhesive capsulitis, there's no evidence of a rotator cuff tear. So he's clear that she cannot lift her hand or she cannot lift her arm is because she has a frozen shoulder rather than a rotator injury. So that's how I would structure my reports.
Another question.
Yes. I should come out.
Good afternoon, ma'am. First of all, thank you for the wonderful presentation.
I should come out.
My question is, often we see in these patients who are referred to us for pain or restriction of movement, they are unable to do these certain maneuvers and positions, especially for the supraspinatus back pocket position or the subscapularis. Are there any alternate views by which we can make a proper assessment without just writing the inadequate study?
You can do a decent shoulder ultrasound in a patient who is lying down also. It's possible to do it. So if a patient is lying straight in ICU, all right, you can look at the anterior structures, and then what you can do is you can hang the hand outside from the bed, so the patient is lying down on a small footstool, or you can ask somebody to put a pillow, and you could be able to see the supraspinatus to some extent. If you turn the patient on the decubitus, okay, a patient who can't move, has knee problems, has had a surgery, if you turn the patient on the decubitus, you will be able to see the infraspinatus. So there's a lot of things that you can do. I don't think you ever need to write this. If you are an aggressive ultrasonologist, you will never write the word inadequate study. You will find ways to do things. Also, if the patient cannot put the hand in the modified CRAS position, which is difficult, you can ask the patient to just put the hand on the hip. Or you can put a bolster, a round pillow, and ask the patient to nicely rest his hand. What will happen is, instead of resting his hand like this, you ask him to rest his hand behind, on the pillow. That will also open the supraspinatus to some extent. You will find ways and means in your department of how you can do a better shoulder ultrasound. It's a good idea to put the patient or make the patient sit on a rotating stool, okay, so that the patient can keep rotating and you are comfortable, okay. It's also a great idea that if you're doing intra-articular injections, keep the patient on decubitus. The last thing you want is that patient seeing you like, opening and the needles, and it's very jarring when you're already in that apprehensive state and you see so many people masked upon you and trays are clanking and needles are falling, and so always keep the patient like this. Do everything you need to do, prepare everything silently, and just tell the patient, I'm going in. So when you do that, the patient is more comfortable, right? So those are the tips and tricks that you will learn once you start practicing, but you will never, I don't think you need to ever write it's inadequate. So you look for a tear, you say, I think that there is a full thickness tear here. If you're not sure, look at the muscle belly. If there's atrophy of the muscle belly, there has to be a full thickness tear. Significant atrophy of a muscle belly cannot occur with a partial thickness tear, because the rest of the rotator cuff, all the cuff is a member, it's a family unit. If there is a full thickness tear, then everything starts to get atrophic. So these are small tricks that you can use and sort of, kind of manipulate your report a bit. But you have to give their clinical query. The clinician is only asking, is there a cuff tear? You say yes. If you see on the X-ray that the subacromial space has reduced, the humerus has migrated superiorly, right, relative to the glenoid equator, there is a cuff tear. If you can't see it on ultrasound and you are struggling to see the cuff, just say there's a full thickness tear. You've seen the X-ray, the patient can't lift, muscle belly is atrophic, X-ray is showing everything, just say there's a cuff tear. Don't say I'm not sure. So sometimes you can put it all together if you're looking at the patient as one single unit. Okay?
Thank you, ma'am.
Yeah, sure. So we'll take that patient again.
Patient just left.
So this is when rotator cuff interval, it's best to. So I'll tell you a trick that you will always find a rotator cuff interval even without a patient. When we put the patient in the modified CRAS position and we put our probe like this, right? Not vertical, not horizontal. We put our probe 45 degrees, like you would wear a crosslink bag. So you're putting your probe like that. If you put the patient in a simple neutral position and if you put your probe like that here, where you are seeing the biceps, short axis to it, you will see the anterior cuff interval. You will always see the anterior cuff interval. Because MSK's ultrasounds is about landmarks. If you have found the landmark, you will find the structure. So because the biceps is more or less like this, going out, it becomes a little more lateral. So just think that this long head of the biceps is going like this. So if you go exactly perpendicular to it, in a neutral position, you will find the interval, right?
The talk was really informative and it has really helped us in having a better understanding of the ultrasound of the shoulder joint. Thank you.
Now we will have Dr. S.N. Sahu and late Dr. G.B. Mahanti sponsored paper presentation competition for PG students which will be judged by Dr. M.V.K. Rao sir, Dr. Basanta Manjari Swami ma'am and Dr. Tara Prasad Tripathi sir.
Judges for the oral paper presentation are BM Swami Madam, Doctor from KIMS, and Dr. Ranjan Patel from AIMS, Dr. Manoranjan Kuntia from some hospital. So we have 3 judges. If anyone from SCB, faculty from SCB can please let us know if to judge the session. Dr. Niranjan sir, please, 4th judge will be Dr. Niranjan sir.
Good afternoon to all of you. My topic for today's paper presentation is role of MRI in evaluation of internal derangement of knee. So internal derangement of knee covers a group of disorders involving disruption of the normal functioning of the ligaments or cartilage of knee joint. MRI is currently the diagnostic procedure of choice for the knee injuries. Arthroscopy, being the gold standard procedure, is invasive and it causes discomfort to patients. So MRI offers certain advantages, that is, it is non-invasive, reliable, safe, provides a superior anatomical and pathological definition of soft tissues, ligament and cartilage. The aims and objectives are to evaluate the clinical efficacy of MRI in internal derangement of knee using arthroscopy as gold standard, to describe the MRI features in various ligament and cartilage pathologies, and to determine how MRI can influence clinicians' diagnosis and management plan of the patients. The study population includes 50 patients who were referred to our department with clinical suspicion of ligament or cartilage or any other related pathology of knee joint. And all patients were subjected to MRI and arthroscopy. My study period was over 10 months. In inclusion criteria, we have patients of knee injury to either one or both knees. And in exclusion criteria, patients with contraindications to MRI, with prior arthroscopy or surgical intervention, with known joint disease, or with history of old significant trauma. In MRI protocol, we use T1, T2, sagittal, axial T2, coronal stir, sagittal PD, fat sat or GRE. The results. This table shows the distribution of age of the patients who are between 19 to 78 years, and majority of the patients belong to the age group of 20 to 40 years. In sex distribution, we have that 80% were males and only 20% were females. The type of the injuries that were sustained by the patients were mostly due to clip injuries followed by the pivot shift. This 2 table shows the MRI versus arthroscopic findings of the ACL, PCL, medial meniscus, lateral meniscus and the composite injuries. And we detected that the ACL tear was the most common injury in both MRI and arthroscopy, followed by medial meniscus injury. Composite injuries were detected about in 62% cases in MRI and were only 56% in arthroscopy. So composite injury, it includes variable combination of the ligament and the menisci injuries, and the predominant pattern that was detected was the medial meniscus with ACL tear followed by ACL and lateral meniscus. The additional, the second table shows the additional MRI findings that were not detected by the arthroscopy, such as MCL tear, LCA tear, bone bruise, fracture, joint effusion and the Baker cyst, and the most common among them was the joint effusion followed by bone bruise. So in the first and the fourth image, we can see this is a MRI versus arthroscopic image. First image showing the ACL tear, and in the last image we can see the medial meniscus posterior horn tear. And in the second image, it shows the coronal T1 weighted image showing second fracture associated with ACL tear. The third image corresponds to the sagittal PD fat set image with double PCL sign associated with the bucket handle tear of the medial meniscus. This table shows the validity of MRI, in which we got that sensitivity and the specificity of MRI is more for ACL tears than that of the menisci. However, MRI has high negative predictive value for menisci. So coming to the discussion, as we know that we have included 50 patients, and most common age group lied between the 20 to 40 years with mean age of 31.6 years. 80% of the patients were males and only 20 were females. Most common type of injury that was sustained by them was due to clip injuries followed by the pivot joint. In ACL tear was the most common in both MRI and arthroscopy, which was followed by medial menisci tear. Composite injuries were better detected in MRI as compared to the arthroscopy, and the predominant pattern was ACL plus medial menisci followed by ACL plus lateral menisci. The predominant additional MR findings that were not detected in arthroscopy but was detected in MRI were bone bruises and joint effusion. This is a comparative study of, this is a comparative analysis of my study compared with the previous studies that were done by the authors, and we have found that we have got similar findings, and the findings were consistent with the previous studies. Though some variations exist, that was due to smaller sample size and the smaller period of studies. Hence, in conclusion, I would like to say that MRI is an accurate, non-invasive technique to evaluate patients with internal derangement of knee. Its accuracy in the diagnosis of especially the ACL tear, meniscal tear, and the composite injuries is very high. Arthroscopy, being the gold standard, is invasive and it causes discomfort to the patients. So MRI, when used in all the patients with high clinical suspicion of the intra-articular knee pathology, can reduce the need for the arthroscopy in up to 42% of the patients. Thank you.
Next presenter, Akshay.
Good evening, everyone. I'm Dr. Akshay R. from KIMS Bhubaneswar. My topic is Imaging of Dyke-Davidoff-Mason Syndrome, a case series. Background: Dyke-Davidoff-Mason syndrome is a rare condition of unknown frequency which is resulting from brain injury due to multitude of causes. Most commonly, it affects the pediatric population, but adult population can also be affected. And characteristics of this syndrome include cerebral hemiatrophy with ipsilateral compensatory osseous hypertrophy, and the patient will present with contralateral hemiparesis and seizures. Left hemisphere is the most commonly involved, and male gender predilection are frequently noted. Aim and objectives was to illustrate the imaging findings revealed in patients with DDMS and to highlight the role of imaging in its diagnosis. Materials and methods. This study was conducted in Department of Radiology, KIMS, over a period of 2 years, and 3 patients clinically diagnosed with DDMS were included in the study population. Coming to the first case, which was a 12-year-old female who came with complaints of facial asymmetry, generalized seizures, and intellectual disability. The patient also had previous history of hypoxic ischemic encephalopathy during neonatal period. Figure 1 is an axial T2 weighted image which is showing left cerebral hemiatrophy with encephalomalacic changes in the left parietal lobe, which is causing ex vacuo dilatation of the left lateral ventricle. And the T1 weighted images, we can see the associated calvarial thickening overlying the encephalomalacic area. The second case was a 20-year-old female who came with a history of partial convulsions and with occasional generalized seizures and also walking difficulties. Figure 3 is an axial T2 weighted MRI which shows left cerebral hemiatrophy with gliotic encephalomalacic changes in the left parieto-occipital lobe. T1 weighted MRI which is showing calvarial thickening on the left side, and the bone window of the CT scan which is also showing the calvarial thickening on the left side. The third case was an 11-year-old male who came with complaints of partial seizure, intellectual disability, and the patient also had previous history of fever at the age of 4, and the patient suffered generalized seizures. Figure 6 is an axial T2 weighted MRI which is showing left cerebral hemiatrophy, which is causing ex vacuo dilatation of the left lateral ventricle with ipsilateral midline shift. And T1 weighted MRI shows prominent left frontal sinus and calvarial thickening. The patient also underwent an MR angiotoph, which is showing narrowing of the left ACA and MCA with paucity of its cortical branches. Discussion: DDMS is a rare neurological condition with clinical characteristics including contralateral hemiplegia, facial asymmetry, recurrent seizures, mental retardation, and delayed developmental milestones. The etiology of this condition can either be due to congenital or acquired causes. Congenital is any in utero vascular insult or infection. Acquired is due to any trauma, tumor, infection, ischemia, or hemorrhage. The differentiating point between the congenital and the acquired types are the presence of an ipsilateral midline shift, and sulcal prominence will be absent on the congenital type. The radiological findings include cerebral hemiatrophy with midline shift, ipsilateral calvarial thickening, hyperpneumatization of the sinuses, mainly the frontal sinus and also the mastoid air cells, and ipsilateral enlarged lateral ventricle. Thalamus and brainstem atrophy can also be seen, but these are uncommon. Treatment includes control of seizures with suitable anticonvulsant, and in children presenting with intractable disabling seizures and hemiplegia, hemispherectomy is the treatment of choice. The main differentials for this condition include Rasmussen encephalitis, Sturge-Weber syndrome, and hemimegalencephaly. Rasmussen, the patient will not have calvarial changes, whereas the other two conditions, calvarial thickening will be seen. Rasmussen encephalitis is a chronic immune-mediated disorder which will present with unilateral cerebral atrophy. Sturge-Weber syndrome, the patient will have distinguishing features of portwine facial nevus, and CT head will also show intracranial transfrac calcification and absence of midline shift. In hemimegalencephaly, there is dysplastic hypertrophy of all or part of the affected cerebral hemisphere. Imaging features include chiral malformation, gray matter heterotopia, and ventriculomegaly. Hemimegalencephaly, the affected part of the brain is the enlarged part of the brain, whereas in the other two conditions, the atrophied part is the affected part. So, in conclusion, due to its rarity, Dyke-Davidoff-Mason syndrome may easily be missed by the majority of treating clinicians, and hence knowledge of its features on imaging enables timely and accurate diagnosis for appropriate management. And prognosis is better if the onset of hemiparesis is after 2 years of age and in the absence of any prolonged or recurrent seizures. These are the references I used. Thank you.
Dr. Anil Kumar Panda. I think the judging will be starting. The judges are ready to give marks, so everyone should upload their posters in the laptop that is kept behind.
Good evening all. My topic is a comparative study of ultrasonography and MRCP for evaluation of obstructive jaundice. Background: jaundice is a yellowish tint to the body tissues including skin, sclera, deeper tissues, and sometimes with darker teak or cola-colored urine and clay-colored stool resulting from deposition of bilirubin due to hyperbilirubinemia. Obstructive jaundice. Jaundice is caused by obstruction of drainage of bile along the intrahepatic or extrahepatic biliary tree. Causes of obstructive jaundice. Benign causes are cholelithiasis, choledocholithiasis, and Carolus disease, choledochal cyst, post-surgical stricture, primary sclerosing cholangitis, and biliary parasites. Malignant cholangiocarcinoma, gallbladder carcinoma, periampullary tumors, metastasis, and involvement of portohepatous lymph nodes. Extrinsic compression like in Merijeri syndrome, pancreatitis, and adenopathy. Methodology: it's a hospital-based cross-sectional study. Inclusion criteria are patients with clinical and laboratory features suggestive of obstructive jaundice, patients willing to enroll in the study. Exclusion criteria: patients having cardiac pacemakers, aneurysmal clips, and electromagnetic implants, patients with claustrophobia, patients not having consent for the study, and no obstructive pathology detected in ultrasonography. My number of patients were 46, and minimum of 6 hours of fasting is required. The imaging in ultrasonography, here we see the stricture in distal CBD, and in MRI, XLT2, curve fiesta, and 3D MRCP shows dilated CSD and CBD with abrupt termination of distal CBD and with shouldering, suggestive of stricture. And in this case, ultrasound is having homogeneous mass of intermediate echogenicity in biliary confluence. In MRI, XLT2 and fat set images, it shows iso to hyperintense intraductal infiltrating mass lesion in primary biliary confluence with moderate ISBR dilatation, suggestive of cholangiocarcinoma. And in this case, ultrasonography shows iso to hypoechoic, it is hypointense written, mass lesion in distal CBD, T2 axial end curve images shows abnormal T2 isointense soft tissue in distal CBD with grossly dilated upstream biliary tree suggestive of periampullary carcinoma. And in this case, in ultrasonography, it shows irregular ill-defined mass with heterogeneous ecotexture in GB, lumen also infiltrating to liver. And in MRI, axial T2 and fat set images shows infiltrating GB mass with infiltration to adjacent liver parenchyma and primary biliary confluence suggestive of carcinoma gallbladder. Results. We have studied 46 number of cases with features of obstructive jaundice and categorized them according to their causes of obstruction and types of lesion. In causes of biliary obstruction, we got gallbladder and CBD calculi, number of cases 16, and it's nearly about 35% of the cases. Cholangiocarcinoma in about 17% of cases, and benign strictures is 10% of cases. Choledochal cyst around 9% of cases, and periampullary carcinoma around 9% of cases, and in pseudocyst around 9% of cases, and carcinoma head of pancreas around 5% of cases, and GB in 5% of cases, and metastatic lymph nodes in 2 to 3% of cases. And benign versus malignant cases, we got benign cases of 63% and malignant cases of around 37% of cases. Discussion. Diagnosis of patients with obstructive jaundice in the early stages is utmost important for patient care and management. Knowledge of advantages and limitations of each technique is needed. With MRCP, correct diagnosis is possible, and invasive procedures like ERCP can be avoided solely for the diagnosis. In this study, we studied 46 number of patients suffering from obstructive jaundice and categorized them according to their cause. Conclusion. USG remains the primary investigating modality as it is widely available and cost effective. MRCP is an accurate, non-invasive and non-ionizing imaging modality. MRCP is the modality of choice for optimal characterization of lesions as it clearly delineates the causes of obstructive jaundice that are missed in the ultrasound also. And it makes MRCP superior than USG ultrasonography in evaluation of patients with obstructive jaundice. Thank you.
Dr. Aryaman, AIIMS Bhubaneswar.
So, good afternoon, everyone. I am Dr. Aryaman Mukherjee from AIIMS Bhubaneswar, and I'll be talking to you about a study, rather my thesis study, which is MRI in epilepsy. And from these chronic neurological conditions, especially the ones where there's been a long-standing history and there's no detectable lesion on MRI, the question is often that whether there is any localizable focus which can be a potential site of cure and relieval of this patient. So that is what we hypothesize, that there are various sequences other than the ones we routinely use, especially some functional parameters which can help us in the localization of this profile. So that was our primary objective, to assess the diagnostic accuracy and usefulness of the MRI, and as a secondary we also looked at the corroboration with EEG wherever it was available, since we most study in the interictal period, and also the clinical semiology of the people. So 62 patients were included over this period of this study, which was around 2.5 years. We had the MRI done at a 3 Tesla machine, GE Discovery 750W, available at our department, and the EEG, for the EEG, the patients were referred to the Department of Neurology. Apart from the routine sequences, the money sequences which we used, the main sequences were an axial diffusion tensor imaging, 3-dimensional reconstructed, inversion, double inversion recovery, as well as FLAIR, and an arterial spin leveling sequence, or ASL. We had pretty much a wide inclusion criteria spanning patients of all ages, sexes, and the contraindications were pretty much the routine ones, anyone who has a general contraindication to MRI like pacemakers, non-compatible implants, and all that, and obviously those who don't consent, that's the most important one. And another problem which we faced that was also included as an exclusion criteria, where many people were lost to follow-up following the neurology referral and EEG report was not available. So image analysis and data collection, the main points was, we had basically two groups, one in which we had found some structural lesion, 26 patients were there, and the other 36 where there were no structural lesions. So the job was pretty simple in the structural lesion group, just place the ROI over the lesion and the contralateral corresponding normal parenchyma and look at the various parameters. And in where the focal abnormalities were not found, we attempted to localize the focus using the semiology of the seizures. And according to studies, that was also found to be pretty accurate according to the EEG, since we could not get EEG in actually majority of the cases. So we had to resort to semiology, but even that was found corroboratory in many cases we are going to see. And we calculate these various parameters, the cerebral blood flow, the mean diffusivity, the fractional anisotropy, these two from the tensor imaging sequences, this from the arterial spin labeling sequences, and the apparent diffusion coefficient from the DWI images. So according to our results, out of the 62, majority was males. And since the referral and workup for the pediatric patients is slightly better at our hospital compared to the adults who are usually lost to follow-up. So majority of our patients were very young. Mean age was around 21 with a lot of in the pediatric age. The first age at first episode was 14.5 years. And as I said before, two major groups appeared. 26 who had some lesion, 36 who did not have some lesion, and which we had to resort to semiology for the basis of their, for getting a workable focus on which we could focus our MRI parameters. So as per the structural anomalies, we got a high number of focal cortical dysplasias, relatively high, 26. We also got a case of Rasmussen encephalitis, as was discussed before, as a differential to the DDMS. And most of the cases were focal gliotic changes, like some ischemia or some HIE sequelae, some small gliotic foci, on which we thought that was the culprit lesion. So coming to the results as a whole, in all patients we could see that on the 3D FLAIR images, fluid attenuated inversion recovery images, and the double inversion recovery sequences, the detection rate was much better than, say, the actual FLAIR sequence or the actual T2 image sequence. T1 Bravo, which is basically a medium inversion recovery sequence. You might be familiar with the name MP-RAGE on Siemens machines. This T1 Bravo is on GE machines. So that was also a pretty good sequence, especially for the gray matter abnormalities such as, gray matter heterotopia. So in the first group, where we found the lesion, the mean CBF was found to be significantly less on the side of the abnormality from the contralateral with a very significant p-value. As we know, p-value less than 0.05 is significant. Mean ADC and the diffusivity were raised on the side of the focus, whereas the mean FA was reduced and it was found significant. And the EEG localized epileptogenic focus in 30.8%. We perform most of the studies in the interictal period, so that's why we get a slightly less percentage, but still it was pretty cooperative. And among these patients, 75% correlated with the epileptogenic zone, and also with the MRI detected abnormality in 76.9%. On the other group, we found pretty much similar findings, and this also corroborated with the semiological focus in 78% cases. And the only difference between the two groups is although the mean FA values were less in the second group in comparison to the first, it was not found to be statistically significant. So these are two representative cases that I've given. This is an example of a structural lesion where we can see this is a focal cortical dysplasia. There's cortical thickening, underlying white matter changes, dysplastic cortex, and there was also on these maps, as you can see, there's an ASL hypoperfusion and diffusivity and FA increase. These are two cases where there was no localizable focus. We localized it based on the semiology, and on the side of the semiological focus, the parameters were altered, as we can see. This is a CBF map, cerebral blood flow map, so there's relative hypoperfusion. So that was our conclusion and part of discussion as well. In most of the studies, they had found these similar findings as compared to us, and we had actually localized, or we had found better corroboration with EEG in comparison to one study where they had found in just 18% patients, whereas we had found in 75% patients. And in conclusion, we can say these two sequences were in which we had 100% detection rates for the seizure focus and for the lesion characterization, the inversion recovery sequences and the flare sequences, and also these imaging functional parameters using the ASL, DTI and ADC maps can aid in further detection of the epileptogenic focus. Thank you.
Dr. Bharat.
Good morning everyone. My name is Dr. Bharat. I am from AIIMS Bhubaneswar. My topic is outcomes of endovascular embolization in GI bleeds due to visceral artery pseudoaneurysms. Introduction. Acute GI bleed is critical condition with high mortality and morbidity. Lower GI bleed occurs above the ligament of traits. Upper GI bleed, lower GI bleed occurs below ligament of trees. Upper GI bleed occurs above ligament of trees. The current treatments are endoscopic hemostasis and pharmacological treatment, surgery. However, surgery has significant mortality rate as high as 10 to 30%. However, despite endoscopic therapy, there is 7 to 16% rebleeding rates. Our aims and objectives are to predict to identify predictive factors of early mortality and rebleeding within 30 days post transarterial embolization in acute GI bleed cases. Materials and methods are, it is a retrospective review from Jan 2021 to 2023. Our inclusion criteria is all GI bleed patients treated by emergency transarterial embolization. Exclusion is patients under 18 years and referred for surgery without transarterial embolization or treated for hemobilia without GI bleeding, isolated mesenteric hematoma or lost to follow-up. Materials and methods are we collected clinical data regarding patient demographics and biological and imaging data and pre-procedure investigations such as endoscopy and CT scan with angiography. Transarterial embolization technique was performed by 2 interventional radiologists with 3 years of experience using microcoils, NVCA glue, gelatin sponge, microparticles, and it depends on depending on clinical and angiographic scenario. The post-procedure follow-up is done by monitoring the clinical signs of ischemic complications or recurrent bleeding, supplemented by laboratory studies, and outcomes recorded are incidence of rebleeding, mortality, and other complications. CTA endoscopy is not done for follow-up. The definitions of outcomes are technical success means there is cessation of angiographic extravasation post-transarterial embolization. A clinical success referring to resolution of bleeding symptoms within 30 days without additional interventions. Statistical analysis is done using routine tools and endpoints identifying the predictors of early death and rebleeding within 30 days post-transarterial embolization and clinical failure. Coming to results, the patient demographic was 68 patients with GI bleed with mean age of 69 years and with 20% on antiplatelet therapy and 27% on anticoagulation with 10% cancer history and 36% with acute cancer. Upper GI bleed was relatively more common than lower GI bleed with upper GI bleed being 90%. Transarterial embolization is 17% are treated empirically without any angiographic abnormalities. Coils are most commonly used, followed by NCBA glue and combination of coils, gelatin and microparticles. The primary artery embolized is gastroduodenal artery and mean procedure time is 60 minutes. And the complications recorded are during procedure, post-operative, and most common being acute renal failure. And hospitalization was median ICU stay for 3 days and median hospital stay for 12 days. Mortality and rebleeding of 17% died during follow-up, with 5.1% within 30 days, and 25% experienced early bleeding. The predictors for early mortality are acute renal failure, lactate levels, and ulcers, lactate being greater than 2 millimoles per liter. And predictors of early rebleeding were higher RBC unit transfusion. Coming to discussion, the lactate level is a known indicator of disease severity in critically ill patients. It emerged as a novel predictor in our study for early mortality within 30 days for transarterial embolization for JA bleed. Early rebleeding rate and predictors. Early rebleeding rate post-transarterial embolization was found to be 25%, aligning to previous studies. Higher volume of RBC transfusion was associated with increased risk of early rebleeding. However, the presence of coagulopathy, contrary to some previous studies, was not found to be a predictor in this study. Empiric versus targeted transarterial embolization. Empiric is performed without active. Empiric TA means it is performed without active bleeding visualization. Showed outcomes comparable to targeted transarterial embolization. This suggests empiric TAE can be effective and possibly due to spontaneous cessation of bleeding. The choice of embolic agents did not significantly affect early rebleeding or mortality rates. However, coils are most commonly used. The transarterial embolization is relatively safe compared to surgery. The main complications noted were acute renal failure due to contrast injection and volume depletion. Ischemic complications were low in upper GI bleed cases attributed to rich collateral supply of gastroduodenal artery. However, lower GI bleed cases showed higher ischemic complication rates. This is a case of pancreatitis with necrosis showing pseudoaneurysm in splenic artery. Sandwich embolization was done with coils and glue. This video is not playing. This is a case of post-Triples procedure now presented with this is a case of post-Triples procedure presented with a superior mesenteric artery aneurysm. Sandwich embolization was done with coils and glue. Sandwich embolization is done usually for splenic artery and gastroduodenal artery which can form adequate collaterals. Okay. Thank you.
Next, Dr. Biba.
Role of MRI in evaluation of posterior cranial fossa mass lesions. So the background is the posterior cranial fossa comprises of all the spaces below the tentorium cerebelli and above the foramen magnum. The posterior fossa is the vital structure which includes the brainstem, cranial nerve from 7 to 12, vertebrobasilar vessels and venous sinuses. Any lesion in the posterior fossa may directly involve these structures, which makes the surgical approach and total excision very difficult, or may even exclude any safe surgical approach. Obstruction to the CSF pathway in this area causes obstructive hydrocephalus, which cannot be corrected without excision of the lesion. For these important reasons, precise radiological evaluation by MRI is a must to visualize all identifiable structures and plan safe surgery for the patient. Although the appearance of CT findings is reasonably characteristic in evaluating posterior fossa space-occupying lesions, MRI is the preferred tool and is investigation of choice as it provides intrinsic tissue contrast and the problem of degradation of images by beam hardening artifact isn't seen. So material and methods, it was a prospective study of 20 patients for a period of 6 months from January to June 2023. The patients who were included were who were suspected clinically to have posterior fossa lesions or already detected to have posterior fossa lesion on any other imaging modalities. And the exclusion criteria included the patients who had vascular etiology like stroke, trauma, metabolic disorders, and general contraindications to MRI were excluded from the study. So the patients were evaluated under 1.5 Tesla MRI machine GE. In many of the cases, gadolinium contrast was also given. So the results of the study was a total patients who were satisfying the inclusion criteria were evaluated. So most common lesion was metastasis, which was like 25%, followed by schwannoma in 20% of the cases. And the overall diagnostic accuracy in detecting the lesions with MRI with contrast was 97%. So the age group which had the highest number of involvement was from 31 to 40, and the pie chart shows the nature of the lesion was mostly malignant. In the bar chart, we see that the highest percentage of the cases were metastasis, followed by schwannoma, and the least number which was encountered was pilocytic astrocytoma. So the most common symptoms which were seen were cerebellar with headache and nausea and vomiting, and few other symptoms like vision abnormality, hearing loss, seizures were also seen. The pie chart on the right hand side, it shows the most common area of involvement was cerebellum, followed by CP angle, then fourth ventricle, and other areas were also involved. So these are few of the cases. The first case shows a solid extraaxial CP angle mass lesion, which is heterogeneous on T1 and T2 hyperintense, and flare also it shows hyperintense. So intense homogeneous contrast enhancement was also seen. So this is a case of meningioma. The second case, it is T1 hypointense, T2 hyperintense with mild diffusion restriction, showing heterogeneous contrast enhancement causing moderate hydrocephalus. It is a case of ependymoma. The third case is a case of T1 iso and T2 heterogeneously hyperintense. Also in flare image, it shows heterogeneously hyperintense. Moderate enhancement on post-contrast study was seen. Typical ice cream cone appearance that shows a larger CP angle component centered around a smaller intracanalicular component. So this is a case of acoustic schwannoma. The fourth case is a well-defined thick ring enhancing lesion, which shows a central portion which appears hypointense on T1 and T2. There is no restricted diffusion, moderate perilesional edema is seen, and mass effect on fourth ventricle and pons is also seen. This is a case of tuberculoma. This is the fifth case, which is there are cystic lesions seen that appear hypointense on T1 and hyper on T2 and shows diffusion restriction and dark on ADC. So this is a case of epidermoid cyst. So to conclude, the golden tool to characterize posterior fossa mass lesions such as morphology, localization, extension, and evaluation of lesions and its complication to adjoining brain parenchyma is MRI. Thus, the MRI has the most potential diagnostic modality to allow complete and accurate diagnosis of such lesions for early detection and management. MRI is not only helpful to better delineate the lesion, but also the secondary effects of the lesion on adjacent neuroparenchyma, cranial nerves, and ventricular system. These mechanical effects and structural deformities are of great importance because the posterior fossa has extremely limited space and compliance to accommodate the increase in intracranial pressure. Thank you.
Dr. Diptanu.
Good morning, everyone. The topic for my paper presentation is a cross-sectional hospital-based study to evaluate the normal anatomical variations and anomalies in the branching patterns of biliary tree using MRCP. So first we need to know why is this study important. So we need to, a surgeon doing a biliary tree intervention or doing any hepatobiliary surgery like liver resection or transplantation, whatever it is, he needs to know about the biliary tree course to avoid any injury to the biliary tree. The conventional methods restrict our vision of the biliary tree branching. So MRCP has done a pretty good role as emerging as a modality of choice now. So that's my aim, and objectives being to classify the variants into various types and to estimate the proportion of each type in the sample population. So this was a cross-sectional hospital-based study, and 80 people were taken as sample size, and all the patients who came for MRCP in our department were taken, but some inclusion and exclusion criteria were followed. The exclusion criteria being the cardiac pacemakers and electromagnetic implants being absolute contraindication for MRI. Also patients who are claustrophobic and not giving consent for MRCP, undergoing biliary procedure, or non-cooperative pediatric patients were also excluded. These are my results, and these results were found to be quite similar to the previous studies. There were some discrepancies, and that was due to the small sample size. So the RHD variants which we got were divided into 5 types, and type 5 we did not get any cases as such in our study, but the normal was the type 1, which is RPSD joining the RHD to form the RHD. Type 2 being the most common variant, triple confluence of RASD, RPSD and LHD to form the CHD. Among the LHD variants, we have got the type A as the normal variant, which is a common trunk of segment 2 and 3 joined by segment 4 duct, whereas the most common variant being again the triple confluence of segment 2, 3, 4 ducts. Cystic duct variants. So previously also there were studies made where there were various variabilities in the anatomy of the cystic duct, and there is no standard classification for this. Similar goes for our study too, and we classified the patients as per the variants we got in our study. So they were divided into 6 types, the lateral insertion being the most common or the normal variant, whereas the most common variant being the medial insertion of the cystic duct into the CHD. As we know the Conrad classification, the liver is divided into 8 segments, and the right hepatic duct has 2 major branches, RPSD draining the segments 6 and 7, and the RASD draining the segments 5 and 8. The left hepatic duct is formed by the segmental tributaries draining the segments 2, 3, 4. The common hepatic duct is formed by the fusion of the right and the left hepatic duct. The bile duct draining the chordate lobe usually joins the origin of the left or right hepatic duct, and the cystic duct classically joins the CHD below the primary confluence. But there are variants which are not uncommon, and in our study approximately 25% variations were found, and but they go underreported for being asymptomatic. So these are the common variants as we have already seen in our results, like the triple confluence of RHD and LHD. In RHD it's found 15% was triple confluence, 7.5 in LHD. Most common variant for cystic duct was medial insertion. Concluding, our study was a hospital-based, small-scale study which cannot be extrapolated to a larger population as such, but performing a similar study on a larger population is mandatory to illustrate the range of variations which are prevalent within the community and which can be extrapolated to the general population. Thank you.
Dr. Gurli Nanda.
Good afternoon, everyone. So my topic for today is a comparative evaluation of carotid ultrasound and coronary angiography in patients with coronary artery disease. So as we all know, atherosclerosis, it's a systemic disease and it can affect almost any vessel in our body. But the carotids and the coronaries are two of the most common to be involved, and it will often lead to a worse clinical outcome if there is coexistence of carotid and the coronary disease. Now, the gold standard for diagnosis of a CAD is coronary angio, but it being an invasive method, it's not preferred as the first line, plus we'll not find a cath lab in every district of the state. So that's why we need to search for a more non-invasive, reliable and accessible method, which is nothing but a carotid ultrasound, and it has been recommended by the American Heart Association as one of the most useful methods to detect atherosclerosis. And that can be by depicting the carotid intima media thickness and the carotid plaques. Now, the aims and objectives of my study, just a minute. The aims and objectives of my study is to find out the relation between CIMT evaluated by ultrasound and CAD evaluated by coronary angio, and to evaluate for the presence of carotid plaques and their characteristics in relation to severity of coronary artery disease. So I have included all those patients who presented to us with coronary artery disease who underwent coronary angio in the age group of 30 to 80, and patients who are unwilling to provide consent for the study, diabetics on pioglitazone therapy, or patients who are having genetic dyslipidemia or on long-term lipid-lowering drugs. They were excluded from the study because most of these drugs, they showed a reduced CIMT that will lead to false negative results. Then certain poor imaging circumstances like a short neck or a high carotid bifurcation, these were also excluded from the study. Now, after taking an informed consent, we performed a carotid ultrasound, and on each side, we took, on the far wall, we took 3 segments, one at the carotid bulb, 1 centimeter proximal to the carotid bulb in the CCA, another 1 centimeter distal to the carotid bulb in the ICA. And in these 3 segments, we searched for the maximum IMT. Now, the average of the maximum IMT on both sides was taken as the mean CIMT, and this was correlated with the coronary angio findings. Now, these are the results. This is a graph that is showing the age and gender distribution of our population. As we can see, out of the 60 subjects that we took, 77% showed a raised CIMT, and maximum of them were in the age group of 56 to 80 years. Now, this is a coronary angio finding that showed a single vessel disease involving the left anterior descending artery. Now, of all those patients who presented to us, 50% showed single vessel disease, 40% double vessel, and 10% showed triple vessel disease. Now, in this graph, we see that as the severity of coronary angio goes on increasing, the median CIMT of our population also is increasing parallelly. Now, this is the method of CIMT evaluation that we talked of earlier at the bulb, 1 centimeter proximal to it and 1 centimeter distal to it. This is the method of plaque evaluation where I'm taking the dimensions of the plaque, and again, according to the echogenicity, they have been divided into 5 different types. Maximum in our population was a type 2 plaque. Type 1 is completely hypoechoic, type 2 more than 50% hypoechoic, type 3 less than 50%, type 4 is an echogenic plaque, and type 3 is a completely calcified plaque. Of all the patients who presented to us, 38% showed the presence of plaque, and this was again correlated with the coronary angio findings, where in single vessel disease 3.3, in double vessel almost 66, and in triple vessel 100% showed the presence of plaque. This is the Nassett method of plaque estimation. Now, this is the main graph of my study that is correlating a CIMT with coronary angio findings. Out of 30 subjects who were having single vessel disease, 53.3% showed a raised CIMT, and all the subjects who presented with a double vessel or a triple vessel disease, 100% of them showed a raised CIMT. This slide is summarizing the findings of my cases. So in our population, 42 were males, of which 71.4% showed a raised CIMT. In contrast to all those females who presented to us, 88.8% showed a raised CIMT. Of the 30 subjects with single vessel disease, 53.3%, and all subjects of DVD and TVD, 100% of them showed a raised CIMT. Then, as the severity of coronary artery disease goes on increasing from SVD to DVD to TVD, we see that there's a parallel increase in the median CIMT, thus indicating that CIMT closely correlates with advancing CAD. A cutoff of 0.8 mm appears to be predictive of coronary artery disease. Now, of all the subjects who presented to us, as we have seen in the earlier slides, incidence of carotid plaques is also going on increasing with increasing severity of coronary artery disease. So coming to the conclusion, the global burden of coronary artery disease is ever rising, and that's why there's an importance in detecting subclinical atherosclerosis and to prevent full-blown coronary artery disease. And here we find out there are two simple methods. One is detecting the carotid intima media thickness, and another is the plaque. And in this study, we are finding that they are not only correlating with the presence of coronary artery disease, but also the extent and severity of coronary artery disease. And these two can be easily depicted by using a simple tool like carotid ultrasound, which apart from being a non-invasive method, it's also reliable, it's an accessible method, and can be put at cheaper than the cath labs. Thank you. So in many of the articles that I looked through on the net, many of them showed that less than 0.8 they have taken as a cutoff for coronary artery disease. More than 0.8. Yes, sir. Presence of a coronary CIMT plus and increasing in CIMT will also, it will correlate with the severity of coronary artery disease. Plaques. The plaques, like I have defined the plaque as 1.5 mm. More than 1.5 mm, I have defined it as plaque. According to Toblo et al. An article, it is 1.5 mm that I have taken as a cutoff for plaque. But CIMT is different than plaque in my study.
One question from my side. Do you have any cutoff window whether this patient will have the coronary angiography after the surgery?
Sir, this was the study that this was conducted on patients with who have already undergone coronary artery disease, and I was just this study is just a correlation study with the coronary atherosclerosis. It's corresponding to carotid atherosclerosis.
Right, but every patient this is a non-invasive method.
Sir.
Magnetic cutoff window.
Yes, sir.
CIMT is 1.1 in the cutoff window that those kind of patients will have the coronary artery disease.
So, because in my population, I'm finding that the median in single vessel disease is 0.8 mm. So that's why, because the median is 0.8 mm, it can predict the presence of a coronary atherosclerosis.
In every patient.
Most of the patients that I took. Now, I have not taken into consideration other risk factors like diabetes and hypertension and all that. They can be other risk factors. In my study, I have correlated with the coronary angio and carotid findings, not taken into consideration the risk factors.
Actually, normal, that Dr. Ranjan told that normal CIMT is 0.08 mm.
0.8 mm, less than 0.8 mm.
How can you conclude now when normal is 0.8? If you are saying more than abnormal means every patient who have a abnormal IMT, you are saying it is predictive of coronary artery disease. That is not right now. How can it be right?
So, because in my study I have seen that the median is coming out to be 0.8. So, maybe if I take a larger population, because the subject is just 60, maybe in a larger population I could have found out the actual cutoff.
This can be just a
correlation study.
It cannot be predictive.
Next presentation is by Dr. Mahabir.
From KIMS Bhubaneswar, I am up here for my oral presentation on the topic imaging of CNS hemangioblastoma. Aims and objectives is, the aim of my study is to evaluate the role of imaging in the diagnosis of hemangioblastoma. to characterize the various morphological types of intracranial hemangioblastoma on MRI in correlation with its histopath examination. Materials and methods, imaging findings of 4 patients in which 3 were female and 1 male with surgically proven hemangioblastoma were retrospectively analyzed in the Department of Radiology, KIMS, Bhubaneswar over a period of 2 years. All the patients underwent MRI by using GE Signa HDXT 1.5 Tesla MRI machine. Case 1, a 46-year-old female presented with complaint of headache and vertigo. MRI showed large lobulated non-enhancing cystic lesion with an enhancing mural nodule in left cerebellar hemisphere with T2 fluids within. Figure 1, which shows a cystic lesion with a mural nodule, and figure 2 shows its enhancement of the mural nodule. Case 2, a 42-year-old male came with complaints of headache, vomiting. The diagnosis of von Hippel-Lindau syndrome was established due to the presence of spinal cord hemangioblastoma in addition to the cerebellar tumors. The figure 1, that is the axial T2, shows the solid cystic lesion with T2 flow voids in the right cerebellum. Figure 2, that is the T1 contrast image showing the enhancing solid nodular lesion in the left cerebellum. And figure 3 shows the similar enhancing lesion in the spinal cord at level C5 vertebra. Case 3 of my case 3 is a 14-year-old female came with complaints of hair drilling, dimness vision in the left eye. The diagnosis of VHL syndrome was established due to the presence of retinal hemangioblastoma in addition to cerebellar tumors. So well-defined peripherally enhancing cystic lesion with multiple peripheral T2 void were noted in the cerebellar vermis. And retinal angiomas near the optic disc associated with the retinal detachment was seen. The case 4, a 40 years old female came with complaints of headache and hair drilling. The diagnosis of VHL syndrome was established due to the presence of multiple hemangioblastoma in cerebellar hemisphere and spinal cord. Non-enhancing cyst with mural nodule in left cerebellar hemisphere with T2 flow voids within were seen. Similar nodular enhancing lesion also seen in the intramedullary spinal cord and bilateral cerebellar hemisphere. So my results were, in cerebellum there were 4 number of lesions, out of which 3 were in the cerebellar hemisphere and 1 was in the vermis. 2 were in the spinal cord and 1 was in the retina. The morphological type, the non-enhancing cyst with an enhancing mural nodule, 2 such cases were there, in 2 such cases. And in one case there was a solid with the internal cyst, and in other case there was cyst with the wall enhancement, showing the wall enhancement. So association with VHL syndrome were 3. All the cases showed T2 flow voids within the lesion. All the cases underwent complete surgical excision of the tumor with duroplasty and cranioplasty, and histopath examination confirmed it to be the hemangioblastoma. So conclusion was that hemangioblastoma are benign WHO grade 1 tumor that appears as solitary or multiple lesions that occur sporadically or may occur in conjunction with other visceral tumors as a part of VHL. The various morphological types seen are non-enhancing cyst with an enhancing mural nodule, solid tumor with flow void, cystic with enhancing wall, and the solid tumor with the internal cyst. These are the 4 morphological types seen in the hemangioblastoma. MRI is the most sensitive imaging modality in the diagnosis of hemangioblastoma, as it can characterize the morphology of lesion and can pick up the T2 flow voids within the lesion. So complete surgical resection remains the most effective management strategy, having a generally favorable prognosis regardless of its location. Most lesions from VHL are treatable and surveillance is recommended, with most common cause of death being the RCC, having 70% of developing in its lifetime risk, and it is seen in more than 67% of the cases with VHL. The diagnosis of VHL may be established by the presence of one of the following. First is more than one CNS, including the retinal hemangioblastoma. Second is one CNS hemangioblastoma with a visceral manifestation of VHL. Like in renal, RCC, cyst, and angiomyolipoma. In adrenal, pheochromocytoma, extra-adrenal pheochromocytoma. Pancreas, cyst, pancreatic neuroendocrine tumors, serous cyst adenoma, adenocarcinoma, liver cyst. In urogenital, epididymal cyst. Head and neck, retinal hemangioblastoma, endolymphatic sac tumor. One manifestation of VHL with a known family history. These 3. These are all my references. Thank you very much.
Next presentation by Dr. Manikam.
Good evening, everyone. My topic for today's presentation is spectrum of MRI imaging findings in various movement disorders. Spectrum of MRI imaging findings in various movement disorders. And introduction is movement disorders are neurologic syndromes that involve progressive neuronal degeneration, injury, or death. They involve subcortical white matter, deep gray nuclei, cortex, brainstem, cerebellum, and spinal cord, along with associated motor pathways in the cortex or extrapyramidal system. They can present either as excess of movement, which are hyperkinesia, which are excessive movements, dyskinesia, unnatural movements, abnormal involuntary movements, or paucity of voluntary and automatic movements unrelated to the weakness or spasticity. So they include hypokinesia, decreased amplitude of movement, bradykinesia, slowness of movement, and akinesia, loss of movement. So a combination of imaging techniques is often needed for complete evaluation and to establish the most likely diagnosis. So initial assessment with structural imaging with MRI is preferred. So classification of movement disorders are like hypokinetic and hyperkinetic disorders. So hypokinetic disorders include Parkinsonian disorders, which are idiopathic Parkinson disease, and atypical Parkinsonian disorders, which include MSA, progressive supranuclear palsy, Lewy body dementia, corticobasal degeneration, corticobasal syndrome, and secondary Parkinsonism includes drug-induced Parkinsonism, vascular Parkinsonism, toxic causes of Parkinsonism, and inflammatory causes. Motor neuron disease includes amyotrophic lateral sclerosis, neurodegeneration with the brain iron accumulation, NBIA. And hyperkinetic disorders include chorea or Huntington's disease, non-ketotic hyperglycemic hemichorea, restless leg syndrome, tardive dyskinesia or dystonia, tics, Wilson disease, tremor, and hereditary ataxia. So the aim of the study is to assess the role of MRI in various movement disorders, and the objective is to identify the spectrum of MRI imaging findings in various movement disorders. So materials and methodology, it's a hospital-based cross-sectional study which includes 30 patients, and Department of Radio Diagnosis, IMS in some hospital, and study duration is 6 months from May to November 2023, and MRI sequence is performed in 1.5 Tesla. A brief general examination was done, and written consent was taken from all the subjects. And inclusion-exclusion criteria of the study. Inclusion criteria is like patients of all age groups came up with the symptoms of hypokinesia, which are akinesia, freezing phenomenon, apraxia, gait, tics, hypothyroid slowness, cataplexy, rigidity, and catatonia are included. And hyperkinesia symptoms like ataxia, synkinesis, athetosis, balism, and sleep disorder, REM sleep behavior disorder, hemifacial spasm, tremor, myoclonus, etc. are included in the study. Exclusion criteria is MRI scan with artifacts and metal implants, then cardiac implantable electronic device, etc. And demographic profile of study population is like total 30 subjects were taken, and mean age group is like 51 plus or minus 2, and male population was 16 and female subjects were 14 in number. And first case, a 55-year-old male with symptoms of white-based and staggering gait, urinary incontinence, broken pursuit, eye movements, and head drilling, showed a cruciform pontine hyperintensity, which is linear transverse and anteroposterior T2 weighted hyperintensities, which is hot cross bun sign in the T2 weighted imaging, axial. And sagittal T2 section showed atrophy of the brainstem and cerebellum, and axial T2 showed prominent folia in bilateral cerebellar hemispheres, and axial T2 showed atrophy of bilateral middle cerebellar peduncle and pons. So the above MRI findings are suggestive of MSA type C. And another case, a 63-year male with complaints of abnormal eye movements, postural instability, and falls. In MRI, the reduced midbrain to pons area ratio less than 0.12 in the midline sagittal plane was shown in the sagittal T2W imaging, and hummingbird sign is seen due to midbrain atrophy, and the reduction of the anteroposterior midbrain diameter at the level of superior colliculi is seen, and the above MRI findings suggestive of progressive supranuclear palsy. And then the next case is a 55-year male with complaints of tremors, frequent falls, myalgia, and rigidity. And in putamenal rim sign is seen in 1.5 Tesla, linear area of high signal in the lateral aspect of the putamen in T2, and bilateral, and in susceptibility weighted imaging SWI, bilateral low SWI signal along with the lateral aspect of the putamen is seen. The following findings suggestive of MSA type P. And a 17-year-old female with complaints of spasticity, ataxia, nystagmus, showed areas of cystic encephalomalacia with surrounding gliosis in bilateral frontal lobes, which showed symmetrical involvement, and diffuse cerebral atrophy with dilated ventricular system is seen. This finding noted in case of hypomyelinating leukodystrophy, and a 44-year-old male with complaints of dystonia, tremors, and behavioral changes showed atrophy of bilateral caudate head and putamen. Frontal horn width to the intercaudate distance ratio is decreased, but intercaudate distance to the inner table width ratio is increased. This is a feature suggestive of Huntington disease. And a 22-year-old female with symptoms of dystonia, tremor, showed widespread hyperintense signal abnormality in the basal ganglia, thalami, midbrain, pons, and middle cerebellar peduncle associated with atrophy in those regions, and face of giant panda sign seen in the midbrain. And susceptibility weighted imaging showed atrophy and iron deposition in the putamen. So this is suggestive of Wilson disease. And a 62-year-old male with symptoms of altered gait, resting tremors, and MRI susceptibility weighted imaging showed posterior third of the substantia nigra of the midbrain showed loss of normal swallowtail sign, which is the loss of bright signal with nigrosome 1. So discussion out of. Thank you.
We'll break for a short tea, then we will start the ultrasound joint session.
Good afternoon, everyone. I'm going to go back. We are going to start with ultrasound of the ankle. Is any of you doing ultrasound of the ankle? Have any of you done Achilles tendon ultrasounds? So that's ankle, right? So all of you are doing, right? Okay. So most common reason why you get ultrasound of the ankle, again, let's be clinical. Let's not try to see everything in the ankle because surgeons don't care. They want clinical questions answered in that patient profile. So patient comes with heel pain, looking at the Achilles. Patient comes with heel pain, looking at the plantar fascia, right? Then the most important reason why young patients would come to us for an ultrasound is for sprains, ankle sprains. How many times have you seen an ankle sprain? So many cases, you would have like 50, 60 ultrasounds a month on just ankle sprain. So you must get used to looking at ankle sprains. The most common ligament to tear in the ankle in an inversion injury is ATFL. So all of you today should go back home with the ability to see the ATFL. And it's not difficult because it starts from the talus and it goes to the fibula as the name suggests. So if you can find it on the surface anatomy, you will find the ligament. So we are going to look at ATFLs. Then we will look at CFL. CFL is a ligament that can be torn with the ATFL. You can never have a CFL tear with an intact ATFL. Okay, so we will see that also in this scan. And then we'll also look at medial sided ligaments. They are not that important. Exorotation injuries occur very little, but still it's a good idea to look at that. And we'll look at nerves because a lot of times you want to do guided injections for anterior ankle impingement, etc. So I'll go back and I'll show you some surface anatomy, and today since you are already doing Achilles, we'll spend less time on Achilles and more time on ligaments. Okay? Yeah, Chelly. So first of all, I think we will spend today least time on the Achilles tendon because all of you are used to looking at this tendon and it's not difficult. We'll start with one of the most common reasons why a surgeon will send an ultrasound to me is a young child or a young athlete or even an adult patient who went to play, has twisted the ankle and has come for a low ankle sprain. Okay, so we have two conditions. We have a low ankle sprain and we have a high ankle sprain. When we talk about low ankle sprain, we are talking about the talofibular ligaments, right? When we have a high ankle sprain, we are talking about the tibiofibular ligaments, which makes up the syndesmosis. So we'll start with the lateral side. This is the most common reason why a patient comes to us. Now, if you look at the lateral side of the ankle, okay, the first thing to do is the patient has come, there's swelling in this side, he is tender, okay, and most of the times your first gut instinct is to take your probe and put it on the lateral side right? And then look at the screen, and then you are trying to find the ATFL, right? Correct? And then we don't find the ATFL because this is no way to find a ATFL, okay? So let's not look at the screen. So Abhijit will switch off the screen, okay? Now we won't look at the screen, it's frozen. Now look at the patient. आप कैमरा यहाँ point कर लो. This is the lateral malleolus. I hope this is showing well. This is the lateral malleolus, okay? This is the tip of the lateral malleolus, right? Now, if I run my hand here, my finger here, this is the tibia, and at some point of time there is a space and there is a tubercle here. So you can see this bump, and this bump can be felt in every patient. So you see this bump, and this is the tuberosity of the talus, all right? So I know where the talar tuberosity is. I can put my finger on it here. I know that the ATFL is attaching here, okay? This is a no-brainer, all right? This is the lateral malleolus. The inferior margin of the malleolus is not where it attaches. The talofibular ligament attaches to the anterior colliculus of the lateral malleolus. So now I know that this is the lateral malleolus, this is the inferior margin, about 1 centimeter up will be the anterior colliculus. I know I can feel the tubercle under my finger. So imaginary line, you start to draw a line that goes like this, correct? This will be the ATFL. That's it. We don't even need to look at the screen, okay? I know that my line is going to be from here to here. Now, ATFL is torn when the ankle inverts, okay, and it plantar flexes. So, if you have an ankle like this, you will not be able to see the ATFL. It's going to get crumpled, okay? If you want to stretch the ATFL, then you have to invert the ankle and slightly plantar flex it. Plantar flex is going down, dorsiflex is going up. Because when the patient had the twisting injury, the ankle went like this, right? It went like this. So you have to do the same movement. So I'm going to do the same movement, okay? And I know this is the tubercle of the talus. I know this is the anterior colliculus of the lateral malleolus. I'm not going to the inferior margin, I'm going to the anterior margin. And now I'm not even going to look at the screen. So let's keep it frozen. What we'll do is we'll take our probe and we'll put lots and lots of jelly. This is where you should be very generous, okay? And there's a big fossa here, it's a skinny ankle. And I will put my probe in this direction because in my mind's eye, I have already made a line. Now I will put my probe exactly where I was thinking the ATFL should be, okay? Then I will look at the screen. Now, when you look at the screen, most likely you will see all this fibrofatty tissue. Yes, this fibrofatty tissue is going to be here. But you can clearly see that I am looking at the end of the fibula here, anterior colliculus, okay? I am looking at the talus, okay? And I am looking at the articular cartilage of the talus here and the articular cartilage of the talus here. And you know that ligament do not attach to an articular cartilage, they will attach to the bone. This is the tuberosity. Now I have to find the ATFL. I am already in the plane where I am expecting the ATFL. I will not move my probe widely, okay? If I move it like I do an OBS ultrasound, I have lost it. So I am going to keep my probe where I thought it would be. And now I will just slightly rotate my probe. Either I will rotate it from the fibular end or I will rotate it from the talar end. And I will just sweep it a bit here and a bit there, okay? And then I will see the talofibular ligament. So this is how you will find the talofibular ligament. So if you see this ligament, it's nice and fibrillar, okay? And again, it has some anisotropy here because there's some refractory artifact from this large vein in this patient. But you can see that the fibers are nice and taut, okay? And this ligament goes all the way here and attaches to the talus. This is the ligament. If I want to straighten it a little more, I can again invert the patient's foot a little more. And now the ligament is becoming more and more straight. The arrow hata do. So here now the ligament is becoming a little more straight. हाँ बस थोड़ा और भैया हाँ ऐसे रख लो. Okay. So this is the straight look of the ligament. Now he is not able to do it. Maybe if we have some help we can. So this is the anterior talofibular ligament. Given that there is some artifact from that vein, that's okay. But if you see, this is the fibular margin, this is the talar margin, and this from here to here is the ligament. So this is the outer surface of the ligament, deep surface of the ligament. You want to tell the surgeon if there is a mid-course tear, if it's a talar-sided tear, if it's a fibular-sided tear, if it's partial deep surface tear, or if it's a superficial tear. And you also want to tell the surgeon if that there is a piece of bone. Sometimes you can have a fleck fracture. So you can have a small avulsion here. So piece of bone also flies off. So you can have this sort of a. So this is the anterior talofibular ligament. And if you have someone to help you out, when you see this ligament, you can do a draw test, okay? So this actually there's a big fossa here and we are missing on the jelly, but that's okay. So we can tighten the ankle a bit and we can see when we tighten the ankle, is the ATFL going apart? See, it is straightening, but it's not going apart. I am not seeing the ATFL breaking. This is an intact ATFL. Okay. So this is where you will look for an ATFL. The ATFL should be seen when you already know in your mind's eye where it's supposed to be. Okay. Once we see the ATFL, now what we are going to do is, we are going to just change the position of this part of the probe. So here, instead of going to the talar tubercle, I am going to start rotating the probe, going towards the tibia. Why? Because I want to look for the tibiofibular ligament. Okay. So the talus, I am going to start rotating only the talar end of the probe. So only from here I am rotating the probe. I am still sticking to the fibula. And then I start to go upwards. And I see that there is a drop off. This drop off is the joint space, tibiotalar. And then what I am seeing here is this fat pad. And now I am starting to see the tibia. So now it has become tibiofibular ligament. Okay? Tibiofibular ligament. This is that thick ligament here, from here to here. And this forms the syndesmotic ligament. If I ask the patient to dorsiflex at the level of the tibiofibular ligament, if I ask the patient to dorsiflex, this ligament can become a little more tight. It can become a little more taut. Okay? But this is if I ask the patient to dorsiflex. Otherwise, I know now where this ligament is. And this is a great way to look at it. And all this time, you should keep the patient in slight inversion. Okay? So this is how we will see the talofibular ligament and the tibiofibular ligament. So this is how we will see both of them. If the anterior talofibular ligament is torn, then this is a low ankle sprain. If the tibiofibular ligament is torn, the syndesmotic ligament, then this is a high ankle sprain. High ankle sprains, if you miss them, if the tear is missed, this patient will go on to have arthritic changes very early. That's the reason why these patients should all be slabbed, okay? Not slapped, slabbed. They have to be put in a slab for 5 to 6 weeks, okay? Then, now comes another ligament, which is the calcaneofibular ligament. This also is injured when the ATFL is injured. So what we'll do is, again, we have to give that position, but in the CFL what happens is, once the ATFL tears, once this ligament tears and the ankle goes in inversion and dorsiflexion, that is when the CFL tears. So in this case you will have to put inversion, but instead of plantar flexion we are going to go for dorsiflexion. And best way to do is to turn the patient to the side. So turn ho jaiye, right. Because the only way to do it is to turn the patient to a side. Now if you look at again landmarks, don't look at the screen, only look at landmarks. This is the inferior margin of the lateral malleolus. From the inferior margin of the lateral malleolus to the retrocalcaneal tuberosity, which we can feel here sometimes in some patients here. So you can feel this retrocalcaneal tuberosity or retrotrochlear eminence. This will be the region of the CFL. So this space will become less if I do a plantar flexion. If I do a dorsiflexion, can you see that this space is automatically widening? I want to widen it, only then I will see that taut ligament, right? And always remember that the end of the ligament under the inner surface of the fibula is neither seen well on MR nor seen well on ultrasound. It is the calcaneal end that you are looking for, because it is the calcaneal end that tears, okay? So it's very simple. ATFL can tear from anywhere, talar end, fibular end, mid-course, have a bone fracture, etc. But CFL always tears from the calcaneal end. So if you can see it at the calcaneal end, that's it. You're done, all right? So don't try to spend time in an already injured patient trying to do everything. Just see for what is important, what you need to tell the clinician. All of you know that the peroneus tendons are riding behind the lateral malleolus here, right? The peroneus tendons are here. So the tendon that is close to the bone is the peroneus brevis, and the tendon that is superficial is the peroneus longus. Anyways, what we are trying to do is in the inframalleolar course of the tendon, we'll have to put lots of jelly here. I now already know where to put my probe. I'm going to put my probe in this direction. What I'm going to do is I'm going to ask the patient to dorsiflex or ask, see, this is a normal patient, but if the patient is injured, you might need an assistant to do this. Okay, so I'm going to ask the patient to dorsiflex. And now what I'm looking for is this peroneal tendon, and I'm looking for a hammock under the peroneal tendon, okay? And here is the hammock that we are looking for. अच्छा थोड़ा सा करिए, छोड़ दो, फिर से करो, छोड़ दीजिए, फिर से करो, ओके, बस एक सेकंड, वेट, छोड़ दीजिए, एक बार फिर से करो, छोड़ दीजिए, फिर से करो, हाँ, नहीं थोड़ा सा इस तरह, ओके, स्टोर, सेव, फ्रीज. So now what you're seeing is, whenever he dorsiflex and releases, you'll see that there is a ligament attaching here to the calcaneum. This ligament here is the CFL. Note how I can see the CFL nice and taut in this region, but then here I'm not seeing it because it's going to dip under the peroneal tendon. So this is the CFL. CFL is important to see only here. And I'll give you another tip. If you can't find the CFL, if you're struggling to find the CFL, it is normal. If there is a torn CFL, it will actually come under your probe. It's actually like that. If you are struggling to see the CFL, it is normal. So this is how we look at this CFL. So we have seen the ATFL, we've seen the AITFL or the syndesmotic anterior ligament, and we've seen the CFL. Now what we look at is the medial ankle. Aap is taraf turn kar jao. Now similarly, so if you're looking at a medial ankle sprain, what are you looking for? Let's have the patient's ankle hanging on an elevation. Medial ankle will sprain when there is a eversion injury, right? eversion. So I don't want the ankle in a neutral position, I want it in an everted position, okay. The main ligament that you are looking at, which you should be looking at, is the deep deltoid ligament, and the deep deltoid ligament has a very large deep tibiotalar component and a very small anterior component. So the entire deep deltoid is made of the posterior ligament. We'll also get a good chance to see the medial ankle tendons, and here you will see the tibialis posterior, right? This is the tibialis posterior, this is the flexor digitorum, and then you see the tibial artery and the two tibial veins, right? Here is the posterior tibial artery, and behind this is the flexor hallucis. So we know the medial ankle tendons. These are the two tendons, then this is the tibial neurovascular bundle with the posterior tibial nerve, and this is the third tendon. So it's Tom, Dick, Nervous, Harry, okay? That's how we remember it, right? Tibialis posterior, flexor digitorum, then you have nervous, the nerve here, and Harry, so flexor hallucis. So this is, and what you are looking at this region is the tarsal tunnel, okay? This little retinaculum is the tarsal tunnel, and this retinaculum actually attaches to the medial malleolus. So you can see this retinaculum attaching to the medial malleolus, and this is, sometimes this retinaculum disrupts from here and you call it the medial facial sleeve injury, but let's stick to basics. So now when you look at the tibialis posterior, remember that when it goes off here, this is the ankle joint line, this is the talus, this is the medial malleolus, right, the tibia. At this point, you should be looking what is underneath it. So what is underneath it? It is the deep deltoid ligament. Now, do I see the ligament? Not really. Do I think it's torn? Maybe. The only way to see this ligament is to stretch it. Again, you must stretch the ligaments in the direction where normally when force is applied, they tear. So I'm going to go here, and now with my probe steady in this position, I am going to dorsiflex. When I dorsiflex, can you see this ligament now? This is a huge ligament, see. When I dorsiflex, this is a big ligament. When I plantar flex, it's gone. It's gone. When I dorsiflex, this ligament comes about, okay? When I plantar flex, it's gone. So remember that stretching the ligaments is important. If you're not going to stretch the ligaments, you are just not going to see them, okay? So here is the ligament. This entire thing is the ligament, okay? And if you see, this ligament looks very heterogeneous, it looks fibrofatty, and that's exactly how it looks in the MR also. It has this scaffolding and you see this laminar pattern of the deep deltoid ligament. So that's exactly how it looks on the ultrasound as well. But remember that ultrasound is dynamic, so you're stretching the ligament here, okay? So now we have seen the deep deltoid ligament, and the only way to see it we know is by dorsiflexing, okay? So here is the dorsiflexion, and now we can see the ligament very well. It's a nice thick ligament, okay? It relaxes when you plantar flex, okay? Then what we'll do is we'll also see the anterior ligament. So this is the tibia, this is the medial malleolus, this is the navicular bone, okay? So I'm just going to put my probe on these surface landmarks. I'm not going to look for ligaments, I'm just going to place my probe here, and then to see this ligament, you will have to plantar flex, okay? So the moment you plantar flex this patient, you will see this ligament. This is a very thin ligament. Okay, freeze karna. This is a very thin ligament. A lot of you may not even appreciate this ligament. It's very, very, very thin, okay? So you can see that this ligament is of really no substance. It adds no strength to the ankle on the medial side at all. But this ligament is seen only if you plantar flex. Again, if I dorsiflex, it's gone. So you can imagine how important it is to stretch the ankle correctly. Now we'll see the superficial ligaments of the deltoid. So we've seen the deep tibiotalar ligaments. We've seen the posterior fleshy one, which we need to dorsiflex to look at. Then we've seen the anterior one, which is a thin one, which we need to plantar flex to look at. And now I'll show you the superficial ones. So just remember that you're looking here at the medial malleolus, you're looking here at the talus. You want to look at the calcaneum because you want to look at the tibiocalcaneal ligament, right? So if we start to come a little more anterior, keeping our eyes focused on the medial malleolus and start to rotate anterior, you will see this ligament going onto the calcaneum. So the talus goes back. This is the talus is gone now. Now what we are seeing is the calcaneum. This ligament here, tibiocalcaneal ligament, okay? It can become more taut. See, it's becoming more taut and straight because I am everting the foot. So this is the ligament, and if I evert it, it becomes nice and taut. If I loosen it, you can't see it, but you can see that ligament well. And it is attaching to the calcaneum. Calcaneum is here, tibia is here, talus is here, this is the tibia. Now what I'll do is, I will start further rotating. So I'll keep myself focused at the medial malleolus. I'll start rotating now a little more further because in front of the calcaneum is the spring ligament. So I'm going to go here and I'm going to rotate. Now what I'm looking at is the tibio-spring ligament. Bijit, just freeze please. So you can see it very beautifully. This is the tibio. This is spring ligament. So this is the tibio-spring ligament. Note how it is not attaching to a bone. In fact, this ligament is attaching onto another ligament. Okay? And this ligament is transverse, and we'll see it again. So this is tibio-spring ligament. So we've seen the tibiocalcaneal ligament, this one, nice and straight. Then we saw the tibio-spring ligament, which is going on to another ligament. Then we'll rotate again a little more and we will see the tibio-navicular ligament. Now this tibio-navicular ligament again is a very thin ligament. If you don't see it, don't bother yourselves. And I'm probably not seeing it very well, but this is the one. This is the tibio, isko freeze karna please. So this ligament here is the tibio-navicular ligament. Remember that articular cartilage, nothing attaches to it. So this is the navicular tuberosity and this is the tibio-navicular ligament. Now this is the tibio-navicular, this was the tibio-spring. So this here is the spring ligament. Now let's look at the patient again. This is the calcaneum, this is the navicular tuberosity, this is the most prominent bone on the medial side here. So if I place my probe from here to here, calcaneo-navicular ligament, so I will see the superior band. So I'm going to place my probe here and then unfreeze the screen, okay? Because I know where to look for it, and this is the ligament. So you see this nice broad ligament. It is such a broad ligament you cannot miss it. And what is on top of it? Isko freeze karna. So we see this nice broad ligament here. Okay, this is the thickness of the ligament. And what is on top of it? It is the tibialis posterior. Remember that just before the tibialis posterior, it's navicular insertion. Just before its navicular insertion, it is superficial to the spring ligament. So you've seen that all these ligaments can be seen very comfortably if you remember the bony landmarks and if you stretch them appropriately. So every time you're confused how to see, just imagine how would this patient have had the injury. And if you turn the ankle like that, you will see that ligament stretching and you can see it very well. ATFL, CFL, anterior syndesmotic ligaments and the posterior tibiotalar ligament you should be able to see in every single patient. Okay. The spring ligament, however, this one can be very thin in flat foot patients, all right, who have a heel valgus. So you can start to see attenuation of the spring ligament. You can even see tears of the spring ligament. And you should also look at the tibialis posterior at its insertion for tendinosis, because such patients, a fat female 40, 50 plus, she's coming with an adult flat foot, she will have tibialis posterior insertional tendinopathy. So this is the tibialis posterior, and you see that tibialis posterior coming on, coming on, coming on. There it is, there it is, there it is. And here is the spring ligament, and you see the tibialis posterior attaching to the navicular tuberosity. It is on top of the spring ligament. Okay, so this is some place where you must see the tibialis posterior as well. So we've seen the major ligaments. भैया आप उल्टा हो जाओ बिल्कुल ऐसे सीधे पेट पे लेट जाओ. Now what's left to do is see the, ये पैर भी नीचे रख दो आराम से, the Achilles, right? And this I think you all are familiar with. I don't need to elaborate so much, so I'll spend very little time on the Achilles tendon. This is the Achilles tendon. Remember, it does not have a tendon sheath, it only has a paratenon. The paratenon is a part of this fibrofatty tissue, and sometimes you need to hydrodissect this place if there's too much inflammation in a patient with Achilles tendinopathy. You want to look at the fibrillar pattern, and you want to look at its footprint on the calcaneum. Remember that the footprint is almost 1.5 centimeters long, so it will start here somewhere and it will end all the way here. It's important to look at it all the way till its end, all right? And you can have some refractory artifacts at the end, but that is normal. And you want to look for tendinopathy, you want to look for calcifications, you want to look for enlargement or tendinosis. You have tears that occur at the Achilles insertion, and you also have tears which occur at the critical zone, which is somewhere here, 2.5 centimeters up, where the tendon can already be affected by tendinosis and can tear for a small reason. And this is the retrocalcaneal fat pad. I don't think I need to go into too much detail on that. If there is a tear and you think it's a partial high grade tear and you are worried if it's a full thickness or a partial high grade, what you do is you ask the patient to plantar flex, and when he plantar flex, can you see that the retrocalcaneal fat is going to get pushed through the tear and it's going to herniate through it if this patient has a tear. So if you're confused between a high grade partial tear and full thickness, then all you have to do is ask the patient to plantar flex and you'll be able to see that. And running across posteriorly in the same plane, you should be able to see the plantar tubercle of the calcaneum and the plantar fascia. So we'll try and look at it. Usually the heel is a thicker structure, and sometimes you can have very thick skin over it. So here is the patient, we'll see this. So you are seeing the plantar tubercle of the calcaneum. You are seeing that there is no spur here, and you are seeing the plantar fascia insertion. There's no edema around it, right? If there's a large spur in this region, most likely under it the first branch of, or the inferior branch of the lateral calcaneal nerve, which is the Baxter's nerve, can get impinged. And this plantar fascia will continue forward, as one part of it will be the central or the medial cord, okay, which will finally break into small facial components, and along with the digitorum brevis they will move, and another part move towards the, and another part of this would be the lateral component. So if we look at the lateral component, this one, now see my probe, I am turning it laterally, okay, I am turning this laterally. This will go and insert, it will be a thin slip, and this will go and insert to the base of the fifth metatarsal. Okay, so the plantar fascia actually has two cords, and when you look at it in axial, you will see that there are two cords. One is the larger medial cord, or the central cord as it called, and one is the lateral cord. So if we go axially, and if you pay attention, you will be able to see that. You just have to get your eyes used to the central or the medial cord and the lateral cord, and these will separate. So there's a lateral cord goes away here, it's a thin slip, and the central cord then becomes thin and it travels as 5 different slips to the phalanges. So I think that would complete looking at the ankle. Remember that you don't have to look for everything. If the patient has come for sprain, please don't look at the Achilles. Just look at the sprain, tell the surgeon what has happened, ATFL is swollen but it's not torn, and that's it. Or tell the surgeon it is torn, and then you can also follow up the patients, because ATFL have beautiful scar remodeling, so you can follow up these patients. When you have this patient in this position, look for the short saphenous vein. Short saphenous vein is in this groove on the lateral side. So you can look for the short saphenous vein in this groove. So this is the Achilles tendon here inserting. And you can look at the short saphenous vein, and with that is the sural nerve. So you can see that small sural nerve. So when you want to do a block or an injection, because the patient has pain, you can have a sural nerve block. Sural nerve can be either medial or lateral to the short saphenous. If you press this region also, the short saphenous does not press because it's in a hammock, and this is the sural nerve. Okay. If you go high up, this is going to ride over the Achilles. The short saphenous vein actually rides over the Achilles, but that's where it goes. But the sural nerve is here, all right? You'll always find the sural nerve. This is a good way to see that. एक बार ऐसे कर लीजिए, उस तरफ turn कर लो. And another thing to look when you are looking at the lateral ankle, and is to look at the lateral malleolus and draw a line on this ridge, okay, on this bony ridge here. Put your probe on this, and you will find on one side is the peroneus muscles. So here is the peroneus muscles, and on the other side you will see the the extensor digitorum muscle belly. So here's the peroneus, here's the extensor, and when you're coming down, what you're seeing here in this small V-shaped groove is actually the superficial peroneal nerve. So this is the superficial peroneal nerve, and as you come down, it's going to come out of this fascia, and then it will travel to the dorsum of the foot, and you can trace that nerve splitting into multiple branches as well. So that completes the ankle ultrasound. I haven't spent too much time on tendons because they're really nothing to it. You just have to trace a tendon. I tried to, in short, explain to you the importance of looking at ligaments and what is important and what's not. Try and stay focused in an ankle ultrasound. Don't try and do everything, because the surgeon is only interested in that clinical burning question. Okay? So we can just see all the images once and see everything. And if there are any questions, while I can show you all the images. जो पहले हमने सीखे.
Any questions from the audience?
ATFL will start. So let's just revise what we saw. First thing we saw was, we saw the ATFL. That's it. So we started to see the ATFL here, right? This is the ATFL. Yeah. So the AITFL, or the tibio-fibular ligament, the anterior one. After that, we've seen the calcaneofibular ligament. Only the calcaneal side is important. The fibular side you will not see neither on MR nor ultrasound. Next. Then we've seen the deep tibio-talar posterior ligament. You must dorsiflex to see it completely. Next. Then we've seen the, so this is when you don't dorsiflex, it looks like this. Next. See, that's what you need to do to see the entire thick ligament band. Next. Then we've seen the tibiocalcaneal. Next. That's the tibiocalcaneal. The tibiospring, because it attaches onto a ligament and not on the bone. And then we've seen this thick spring ligament on top of which is sitting the tibialis posterior. And the tibionavicular ligament, which is a thin slip of a ligament. It's okay if you can't see it. And the anterior tibio-talar ligament, which again you should plantar flex to look at it. Okay, it's okay if you don't see it, it's no big deal. You can go at ease and see them at trade area, okay, if you want to. नहीं ये प्ले किया तो चला जाता है. Okay. So there's a slight glitch. I can't see my presentation on my laptop. So I will be looking at it and I will keep bobbing my head here. Sorry. So we're going to look at the sports groin, and is any of you doing MRI for the sports groin? Have you seen any cases? Do you have any? So I'll tell you what, this is going to be a basic to intermediate level lecture on MRI of the sports groin. So if you have never done a sports groin also, once you see this, you will be able to report them with confidence. The reason being it's a very small region and there's very little that goes wrong. So be confident, it's extremely easy to look at this. So we'll start with the anatomy, which is again the most important thing of radiology. We have the transversus abdominis, which is the deepest portion of the abdominal musculature, right? And the rectus abdominis actually goes into this arcuate line. So posteriorly, there's really no sheath behind the rectus there. And anteriorly, you can see that there's going to be a sheath of the internal and external oblique. And you have these inscriptions on the rectus abdominis, right? Which is called the 6-pack or the 8-pack, which most radiologists don't have because we just sit all the time. So this is the internal oblique, and you can see that now it is decussating a nice strong anterior rectus sheath. You have the linea alba, and then you also have a linea semilunaris. So this is another myotendinous junction. Note the inguinal ligaments. So all of it, everything is going to happen here, okay? This is the deep ring. That is the superficial ring. This is the external oblique, right? So these oblique muscles are in different arrangements. That's how we have the abdominal strength or the core muscle strength. And whatever happens in the sports groin is in this region. The pubic cartilage, pubic symphysis, the pubic tubercle, the lacunar ligament and the slips of the inguinal ligament, the linea alba, the adductor longus and the short adductors. Everything is here. We look at it in a little more detail. Pubic symphysis is a fibrocartilage. It has a pseudocapsule sort of a thing on top of it. And like every fibrocartilage, it can degenerate. Then you have the slips of the inguinal ligament. You also have a small pyramidalis muscle, but we won't go into that today. And we have the adductor longus also that originates from here. Okay? And from here we have the short adductors that are originating. Okay. Now, in front of the pubic symphysis is this plate. This fibrous decussation is actually continuous with the rectus abdominis above and the adductor longus below. This is called the prepubic plate, okay, or the quadrangular plate, or the cara, common adductor rectus aponeurosis. But I'll just call it the prepubic plate today, okay? Everything happens here because the pubic tubercle is connected to so many structures, all right? This is all you need to know in terms of gross anatomy. Now remember that sometimes because of the friction of these nerves among the external oblique and the internal oblique, they can also cause pain, which can look like a sports groin, but it's not. So the nerves that are concerned are basically the genitofemoral, the ilioinguinal and the iliohypogastric nerve. Here is the favorite box, okay? This is the box that you should be looking at. Pectineus, adductor longus, it will be continuous with the prepubic plate, continuous with the rectus abdominis. Behind the adductor longus is the muscular origin of the adductor brevis and then the obturator externus. A lot of people say this is a sports hernia. Remember, there is no hernia. There is no defect, there is no hernia. The whole confusion started because the baseball coach Gary Gilmore had this condition and he got his hernia operated and he felt better. That's because sometimes you cut these nerves, the iliohypogastric and ilioinguinal nerves when you're doing a surgery, and there is anesthesia to that part. So he felt better. But that doesn't mean he had a hernia, all right? So there is no hernia, there is no defect. People have seen it, we have proved it. Now, who gets this? Why would someone get a sports groin? First of all, 9 out of 10 patients are male. Okay, the female pelvis is broader, and while that has other disadvantages, it is advantageous in this condition because the forces dissipate better. Athletes that require rapid change of direction. Okay, 1 minute you're running back, 1 minute you're running front. Repetitive side-to-side ambulation. Athletes where there is forceful twisting of the trunk because they are involving their core muscles. And when they are forcefully kicking. Those are the patients who are going to get a sports groin. We as radiologists might never get one. So here is a beautiful article. I invite you to read this. This is a pure joy reading this article. It will tell you everything you need to know. Okay, this is an article by Omar. Look at the rectus abdominis. If at this leg I am driving a kick, this force is lateral, that force is vertical, right? Supposing there's a prepubic plate and there is one which is continuous here with the pubic symphysis. Sometimes the force going here can go up in this, or this force coming here can go here, or this can go here. So you understand that there is a lot of cross vectoring of forces. And whenever there is imbalance in that cross vectoring, something is going to tear. Okay? That's all. That's all you need to know. This is a continuous area. This is actually not correct. So this is a continuous area. All right? What happens is when a patient will play, and in this case, he's already on an unbalanced pelvis. Then he goes about making a forceful kick here. And when he kicks with that unbalanced pelvis, he suddenly starts to feel a catch. That is a sports groin. This is an adductor tear. You can just see it in a football match and you have the diagnosis, all right? Another patient, you've seen this a lot if any of you follow FIFA, this patient will just fall to the ground. Just one kick he has delivered, nobody has tackled him, he will fall to the ground and he will catch his crotch and he cannot walk. This is a adductor longus tear. This is the most common pathology that occurs at the sports groin. Okay, patients will come showing you a video, this is how I got this injury. There are lots of terms around this. Okay, there's so much alphabetical soup around this condition. All of these terms are insufficient, really speaking, in describing this condition. Even though I'm using the word here and these words are common, core muscle injury, but really speaking, there was a Doha agreement. A lot of intelligent people got together and they said, okay, let's divide this and let's use homogeneous taxonomy around this condition. They said that, think about it like this. Does the patient have pubic related pain? In which case he will have pubic symphysis tenderness. Does the patient have adductor related pain? So he'll have pain which is slightly parasagittal. It's not midline. And it will be increasing on adductor resistance testing. Does he have inguinal related pain? So coughing, Valsalva, abdominal crunch, anything that increases pain. And does he have iliopsoas or hip related pain? So flexing the hip will cause pain. Flexion, adduction, internal rotation, FADER. Flexion, abduction, external rotation, FABER. All these tests will be positive. So when you see these slips, you will see an orthopedic surgeon saying FABER positive, FADER positive. So just try and look at these conditions. You'll get a fair bit of an idea what to expect in the MR. Lots of conditions can cause these pain. But thankfully, in this easy sort of a condition, the patient's history is compelling. Okay? So that laundry list is not necessary. Anatomy, very important, look at the T1 weighted images. You'll see the rectus abdominis, okay, bilaterally, medial, lateral, and they will go down and converge onto the pubic symphysis, right? There is a prepubic plate. This thick plate is the prepubic plate. On the sides of this prepubic plate will come out the adductor longus tendons. What is already here is the muscular origin of the adductor brevis, okay? And what you see here is the pectineus. So when you see this, this is from Rad's source, you can read this as good material. You'll see that there's a small pyramidalis muscle. This is the adductor longus origin. It is a triangular origin. It should be nice and dark like the meniscus. If it's heterogeneous or intermediate, then there is tendinosis. And you'll see it on both the fat images, that is T1, and the fat saturated, which is going to be a PDFS or a STIR. And you must look at this to see for any tears. This is the prepubic plate that I was talking about. Everything converges onto it, and then the adductor longus are fired out through it. So you want to look at the medial and the lateral heads of the rectus. You want to look for any tears that are shooting up into the linea alba. You want to look at any tear that is shooting up into the linea semilunaris, and some of these tears can also go into the pectineus. Either ways, the place is very small, there's very little to look at. In the center, you will see the prepubic plate that is sitting snug on the pubic symphysis. On the sides, you will see the triangle coming out of it. So when there is a tear in the center, you will see a delamination. When the tear goes to the sides, you will start to see a adductor longus avulsion. So the triangle is lost on sagittal images. And the tear can be, as usual, things are not as easy as they seem in the textbooks. It's never a straight line. It can be a little complex as well, but that's all right. Now, there is a little confusion when you start reading literature and people talk about clefts. What is primary? What is secondary? I'll simplify this. When the pubic symphysis is the fibrocartilage, whenever there is instability, there is friction at that region, because the pelvis is a ring, there's going to be mucoid degeneration within that cartilage. And so it starts to become fluid-like, like gelatinous. Okay? So you will see a high signal. The pubic capsule can tear. When that tear occurs, that gelatinous material is going to leak. Now, if it leaks laterally and upwards, it will go into the inguinal ligament, tear it, or it will go into the rectus abdominis. If it leaks sideways, it will go into the adductor longus. If it leaks inferiorly, it will go into the origin of the short adductors, right, which is the adductor brevis. So basically, this is the primary cleft and everything else is the secondary cleft. Okay? That's all. People who have injected the pubic symphysis, they saw that the contrast ran out. So this is the secondary cleft. The commonest cleft, the secondary type of cleft, is the one that loops around the inferior pubic ramus. This is the path of least resistance, and that is why this is the commonest kind of cleft. But you can have clefts going anywhere. Can go like this, going like this, can go anywhere. So this is how we look at a scan. You look at the bone changes. You see that that bone is not normal for a young patient, right? There's some bone changes more on the right side. You look on the PDFS for that fluid signal in the pubic symphysis. And on the axial, you're looking for a cleft that is going back. So this is the most common kind of secondary cleft, all right? This is what a cleft sign is, all right? That's it. T1 weighted images, I personally really like them. This is T2 though, but the fact is that you can see the fat and that really helps. So here's the rectus abdominis, this is the pubic symphysis, and this is the prepubic plate, okay? It's dark, it's almost merged with the cortex unless it strips. And when you start to look at the scan, this is an orthogonal axial. You look at both heads of the rectus abdominis bilaterally. You look at the inguinal ligaments. You look at the prepubic plate. Look at the status of the bone. Look for any kind of tears. Look at the adductor longus, adductor brevis, obturator externus, iliopsoas. Maybe some pathology going on here, and look at the pectineus. So you can see everything if you look at the T1 weighted image. Don't always go running for the PDFS. I know it's a great image, VAT is saturated, all hot spots are looking bright, but a T1 weighted image or a T2 weighted image is a great place to get grounded. So what we do here is when a patient comes to us with a groin pain, first of all the surgeon rules out a hernia. If there is no hernia, then we are thinking that this is a sports groin. So we want to ask the patient how this happened because history helps big time. We want to know what kind of pain is it. If the pain is radiating, then it's a neural pain. Ilioinguinal, genitofemoral, iliohypogastric, think neural. If the pain is in one spot, it is definitely a nociceptive pain. All right. Then we see the clinical examination, what the surgeon has written, is it pubic related, adductor related, etc. And then we give our radiology findings, and that's how treatment is instituted to that patient. This is how it's followed, okay, in sports injury centers. X-rays are not the way to look at sports groin, but I'm bringing you some X-rays because it's interesting. Look at this patient. He's a footballer, okay? I'm already seeing that there is a sartorius avulsion, right? There is a iliac spine avulsion here. So there is going to be imbalance at this pelvis. I know that already. and see his pubic bones. There's some bone flecks, some avulsions occurring, bone looks all abnormal. And one great thing to look at, and which you will not find in literature, and someday maybe I will sit down to write this, is the instability. If there is a one level up down, there is a macro instability at this pubic symphysis. His pubic cartilage is completely degenerated. You can say that on the x-ray and you confidently tell your surgeon, get an MRI done. I'm going to show you a cleft. Okay? So this is macro instability. That's there. Look at this patient. The hamstrings have avulsed long back. So there's chronic changes there. Clearly he's going to have some instability. If he's come with groin pain, it has to be. Something has got to give. It's a ring, right? The pelvis is a ring. So here you look at, there's already some changes. And again, this is a centralized almost x-ray, but there is a level. I'm thinking macro instability. This is a patient, 18-year-old track and field athlete. Okay? Pelvis looks okay, but there are some changes. This is not okay for an 18-year-old. And there is no level. So I'm thinking micro instability. All right? So it's just something, it's fun to look at these patients because most of them are carrying an x-ray, so why not? Ultrasound is a great modality, as you have already seen. One of my favorite things to do. This is the pubic symphysis. This is where the adductor longus insertion, the triangle should be. And here it's gone. There's a fluid cleft. The adductor has tore from the pubic tubercle. So that's a hematoma. You can go ahead and even aspirate it, or you can inject PRP or what have you, whatever the surgeon tells you. Here's a 15-year-old footballer. This is the prepubic plate. I'm seeing that maybe this side is more thickened than this side, but it's normal, right? This patient has come with left-sided pain. And this is just like you would see on the MR. See, that's the bone, that's the symphysis, that's the prepubic plate, just like you would see it on the MR. And we went to do an MR, and you see that there is osteitis pubis, marrow edema bilaterally, more on the left side, and there's some soft tissue edema. So you have to understand that even though ultrasound and x-rays are great modalities to look at, ultrasound is good for, because of its dynamic properties, ultrasound is good for follow-ups, it's great for interventions, but the modality of choice is MR. Here's a footballer, you can see all this bony changes. So all this ultrasound can show, but remember that MR is the way to go. On MR, it's very easy to look at these findings. Now you are already aware of it. There's very few things to look at. So this is how I start an MR, with a non-fat saturated image. Okay, so this is a T1. And you see the linea alba, you see the linea semilunaris. And when you look at this, do you see something in the rectus abdominis? Medial heads of bilateral rectus are normal. Lateral heads of the rectus, one is atrophic. So I know something is cooking in this region. Whenever there is some sort of an imbalance, this patient is going to go outside and play, and he is going to disrupt something. So here you will see that very well on the axial also. These are 1.5 Tesla images. These are not great. Some are shaken and stirred. And clearly you can see that something else is also happening at the adductor longus. Here's a patient where you can just see thickening of the prepubic plate and there was no tear. That's fine. Here's a patient where prepubic plate is okay and there's some osteitis pubis. So there's just edema and that's all you will call it. This patient has pubic related pain. Here's a patient where there are more bone changes which are chronic. You can see on the merge. Symmetrical heads of the rectus, normal inguinal ligaments. As we go down, we are seeing that the prepubic plate is also looking all right, but we'll see it on the PDFS. And then there's more stuff happening here, okay? So we'll look at the PDFS in this patient. So sagittally, you can see that there is delamination here in the central margin. So the prepubic plate delamination. And on the axial, you are going to see that this muscle is now becoming the prepubic plate, which is okay. But here you can see that there's a cleft. So there's that fluid signal that is tracking posteriorly. So there's a secondary cleft in this patient. A great way to do MR is that it's okay if you just have regular pelvis MRs with you, but if you want to, You can also try and be parallel or perpendicular to the iliopectineal line. This gives you more real estate. You can see these, better. They're all separated. It's nice. So this is orthogonal axial is when you just go straight down. But oblique axial is when you start taking sections like this. Okay, so see the difference. This is orthogonal axial. Okay, you're not seeing much of edema or any pathology here. We're just going up to down. And the other side, we are doing an oblique axial. Oh, sorry, I can't see anything, so yeah. On the other side, we are going to do an oblique axial. So here's this patient. So this is an oblique axial. This is going like this. Can you see that this is much better seen? You have more real estate. You can see these muscles better. You can see the prepubic plate better. You can see the adductor longus better. And you can see that pathology better. We would have totally missed it if we just went for an orthogonal axial. You can also go perpendicular and to see it like this, a coronal oblique. It looks very nice. You can see a lot of things in a coronal oblique. See how big and stretched out the pubic symphysis looks, and see that edema in this region. So you can. 1.5T protocol at Thomas Jefferson University, we have tweaked our protocol close to this. What I do is basically I look at stir images, large FOV images, 25, 26 centimeters. Look at the coronal stir, look at the axial T1, and if you can, look at the axial PDFS. After that, I acquire an axial oblique and a sagittal PDFS in a small FOV, so 9 to 10 centimeters. That's all. In 5 sequences, my scan is complete. Very rarely I will go in for a coronal oblique. Maybe if I want to show in a presentation like I wanted today, I'll do oblique, otherwise I won't do it. This is how you should start, coronal stir. Okay, so all the hot spots you identify. Here you start anteriorly. You look at the epididymis, the testes, the inguinal canal. You're going to look at this later on, so it's okay. Look at the muscles, any strain pattern edema, any stress fractures of the pubic rami. Look for effusions, AVNs, CAM morphology, femoroacetabular impingements. Look at the trochanteric bursa, this looks a little inflamed. Look at stress fractures of the ilium, sacrum, SI joints, piriformis, and even the hamstring origin. So when you scroll coronal stir, just like that, you get so much information. Then you look at the T1. Why? Because you can see fat separating all these structures. All these muscles are well seen. You want to look at the bones, and you also get some sense of this is going to go wrong here, isn't it? This is incomplete here. After that, you look at the PDFS. So symmetrical rectus abdominis, and then as we go down, we start to see that there is pubic symphysis, there is osteitis pubis, and there is that secondary cleft, okay? So there's stuff going on here. There's some tendinosis of the adductor longus origin as well. That cleft is going all the way back into the short adductors, tearing it. If a GRE is available, you can look for these bone fragments. Sometimes there can be a bony avulsion. So here's a patient, footballer, 19-year-old, right groin pain. Okay, so just look at the scan like you would look at it in your department. Rectus abdominis sort of looks okay. Maybe this one is more atrophic, but he has pain on the right side. And you start to see that the pathology is both-sided, really speaking. When you go down, you see the adductor longus, and this looks a bit thickened, but what we were seeing is this patient also had ossification within a previous tear. And this ossification was not seen except for in the T1 and the GRE. Here this patient has acute condition in the groin, so osteitis pubis and a secondary cleft. But if you see in this PDFS, because there's a chronic change, you're not going to see this at all. There's no edema in this region. So sometimes you need to put both of them together to know exactly what is happening. 31-year-old male, he's got a right groin pain. Now, when you look at this patient, and he's giving a history, the adductor longus, so this is the prepubic plate, the adductor longus has flown off, very clear. Now, it's okay to say that there's an adductor longus tear and all this. This is the retraction, and maybe there's a bone avulsion with it. But it's also important to look at any chronic condition. The other adductor also has tendinosis. It's also going to tear someday. Also, there are some bone changes, there are cysts, there's bony irregularity. That means there's stuff going on for a while, it's been brewing for a while, and now the patient has come with a weakened tendon tearing. And there's strain pattern edema, and the tear is also extending to the pectineus muscle. So you want to give that information to the surgeon, but you also want to talk about the chronic condition. The same patient, if you see this is the prepubic plate that is torn, and then as you go more parasagittally, there's a hematoma, and here is the adductor longus which is torn. And in fact, this tear also went into the pyramidalis, but that was more complex. Here's a 22-year-old cricketer, and you'll see that pubic symphysis is showing changes, that's fine. But we are looking at the asymmetry in the adductor longus origin and see this tendon, so small. That one is big, this one is small. Something's happened. The tendon is there, sitting, torn, retracted, right? So look at this T1. You can now see the asymmetry so well. That rectus was so atrophic to start with. No surprise that this patient has come with a adductor tear, because where are the forces of the pelvis going to go, right? So here is that scene 1 on the T1, and the same can be seen on this coronal. You see the distance that it has flown off from, and maybe if there's a bone fragment you want to tell the surgeon, and these kind of acute ones the surgeon can go back and fix it with a suture anchor, it's not difficult. A 47-year-old cricket coach, rectus abdominis, you can see the asymmetry, and then this weakness, there is a tear into the inguinal fold, and so he has an inguinal hernia. So you would call it a sports hernia, but really speaking, it's not started as a hernia. And there is some stuff happening at the adductor longus as well. Look at it on the coronal. So you can see the asymmetry. You can see the widening of the linea semilunaris. That's the inguinal hernia. That's because there was a tear of the groin. And we look at it on the fat saturated images. The adductor longus is completely torn from this region and completely avulsed from its pubic bone origin. There's also edema in the other tendons and the other muscles. But if you look at this in the sagittal plane, you look at this fluid and this tear that is running through the inguinal canal. This fluid is continuous with the prepubic plate delamination, is continuous with the adductor longus avulsion. So the entire adductor longus, the entire thing from the fibrocartilage is avulsed. So this is a plaque type 4, pyramidalis adductor longus complex avulsion. And this gives credence to the fact that all this is one unit. It's not separate units. And here's that prepubic plate delamination as well. And on the other side, the adductor longus was okay, but there was some tendinosis in this patient. So 21-year-old groin pain. These are chronic injuries. You can just see some asymmetry of the rectus abdominis. There was nothing else in this patient, but I would still like to write this because maybe some sort of muscle conditioning or some therapy can be instituted for this patient. Here's a patient who actually had a varicose heel, that's why he had pain. Here's a patient who had just strain pattern edema, and there was nothing. There was some chronic changes in the adductor longus, and there was no other pathology. So you want to look at acute and chronic pathologies. You want to look at everything: pubic bone, common aponeurosis, prepubic plate, rectus abdominis, adductor longus, inguinal ring. MR protocols, start adding an axial oblique, it really helps. And stick to simple nomenclature. There's a heterogeneous soup of words here, but try and stick to something more simple. And if you don't find the pathology in that region, then find something out of the box, okay? This is a patient who came with groin pain, female patient, so I know that sports groin are uncommon. I felt that there was a stress fracture. But MRI helped us to also see the superior pubic ramus fracture. So not only was there an inferior one, but there was also a superior pubic ramus fracture in this patient. Here's a patient, she had a bony avulsion of the pyramidalis muscle, okay? Here's a patient who had left-sided groin pain, and the groin was normal, and there was iliopsoas tendinitis. Okay, so you can look at all these conditions. If you don't see something in that pubic box, then start to think that there would be something else. Here's a patient whose groin was normal. He clearly says, I have a lump in my thigh. I have pain on the right side. So my technician went about to take a long FOV image. And he saw that even though the groin was normal, the adductor longus had torn from its distal insertion on the linea aspera of the femur. And that is the reason why he was having pain. You look at it, he has edema here. In fact, if you just looked at the axial PDFS, this adductor longus looks thicker than the muscle belly of the left side. But actually because it's retracted and it's edematous and it's completely torn and 10 centimeters retracted from where it should be inserting. So reporting formats, keep them simple. Keep a single format so that you don't miss out on things. There are a few things to describe when you see them. Patient's history is usually very compelling. Look at the adductors and the short adductors and the pectineus. Look for symmetry. This helps big time. And look for other associated pathology as well. So describe acute injuries first and then chronic injuries. Okay? And for advanced learning, you can look at this article. It's a fun article to go through. So I hope that you have all benefited from this lecture. And I invite you to attend the Musculoskeletal Society annual meets if you are interested to take your MSK knowledge to another level. So it's very rewarding to come to these meets. You'll get a lot of information from national and international speakers. Any questions?
Any questions from the audience? Thank you, ma'am, for your very intellectual talk. It was very informative and it will definitely help us in broadening our knowledge in field of MSK. Thank you, ma'am. Now the next speaker is Dr. Swati Das, ma'am, Associate Professor, KIMS Medical College and Hospital, and she will talk on topic radiofrequency ablation of surface hepatic lesion. Ma'am, please.
Sorry, so it was a little hardware problem. A very good evening to all. After listening so many informative talks on musculoskeletal ultrasound and MRI from Dr. Nafisa ma'am, let's move towards the era of micro-invasive surgery. So this is the era of micro-invasive surgery, and people are preferring micro-invasive surgery over the open ones. So I have chosen such a topic, that is radiofrequency ablation. More or less we all know about radiofrequency ablation. I will be focusing more on the radiofrequency ablation of surface hepatic lesions, the technical difficulties or the precautions which we should take. So let's start my talk with a case discussion. This is a 49 years female patient who presented with a breast lump, and it was diagnosed as a CA breast, which was HER2 positive, and there was associated right axillary lymph node and also a lesion in the segment, single lesion in the segment 8 of liver. The patient was diagnosed with oligometastatic CA breast. The patient performance status was 0, means she was well oriented and she was in a good condition apart from CA breast, and the lab findings were within normal limits. So the treatment options available are the local resection or ablation followed by chemotherapy. So among resection and ablation, which one to choose? When the lesion is peripherally located, larger in size, and the patient is suitable for surgery, in those cases we choose metastectomy or resection. But when the lesion is smaller in size, centrally located, and the patient is not fit for surgery, in that case we choose RFA ablation. So this is an article which shows the treatment strategies on oligometastatic CA breast, in which it is mentioned that around 87 lesions they were treated with RFA, and we showed only 25% of local tumor progression, and when the tumor size is less than 2.5 centimeter, the outcome is even better. So RFA ablation can be a treatment modality for oligometastatic CA breast. Our tumor board team, they decided to go for RFA ablation of the lesion. So this is the pre-procedure PET CT scan. Here we can see there is a breast lump, FDG breast lump, and there is a right axillary lymph node, and also in the liver there is a single lesion which is subcapsular in location. So this is the ultrasound finding. Here we can see a hypoechoic lesion in the segment 8 of liver. This is subcapsular in location, and here is the rib shadow coming this side and the lung base shadow coming this side. So however, we went for RFA ablation. So we took ultrasound as a modality. This is the RFA electrode, this linear echogenic line, and this is the tumor. It is well placed within the tumor, and this procedure was done under general anesthesia. The lesion appears to be echogenic because of formation of gas bubbles within it, and the technical detail how it is done I will cover in my next slides. So this is the follow-up of that patient after 1 month. This is non-contrast CT. This is the arterial phase, and this is the portal venous phase. Here we can see the hypodense lesion, and there is no enhancement in the arterial phase as well as portal venous phase. And here the size is 5 mm more than the original size, because we include 5 mm to 1 centimeter normal liver tissue in ablation. So this appears to be a technical successful RFA ablation of the lesion. So now we'll revise the literature. These are different types of percutaneous ablation techniques, among which radio frequency ablation is a thermal based ablation, in which heat energy is supplied to the tissue to burn it. So this is some basic slides on RFA. It uses electromagnetic waves that is in the range of 3 Hz to 300 gigahertz, and how the assembly looks like this. This is the generator which supplies an alternating current into the electrode. This electrode will be placed inside the lesion of in the patient, and this alternating current will set a electromagnetic wave, and that will give rise to heat energy, and it will ablate the lesion. Then it is transmitted to the grounding pads, and the grounding pads will be again connected to the generator. So this is the basic assembly of the RFA system. So in our mind, question will be coming, why the maximum damage occurs here but why not here? So it is because the surface area of tip of electrode is very less. So the intensity of energy in that site is very high. That's why the heat energy damages the tissue. However, in the grounding pad, the surface area is very large, and these are more in number, so the heat gets dispersed. So there will be no damage to the tissue. In that way, the radiofrequency ablation occurs. So here, as I already mentioned, the radiofrequency waves, they do not directly cause heat energy production. Rather, at the tip of the electrode in the surrounding tissue, it will cause vibration of the molecules. The immediately adjacent to the tip of the electrode, there will be vibration of the tissue, and that will give rise to heat energy production, and that will be conducted through the adjacent tissue to surrounding area. So as the distance from the tip of the electrode increases, the heat energy intensity decreases. That's why we need to increase the temperature slowly. If we increase the temperature of ablation faster, then what will happen? It will char the tissue, or it will that charring of the tissue or burning of the tissue surrounding adjacent to the electrode, it will cause increase in resistance. That's why the heat conduction to the adjacent structures will not be much. So the zone of ablation will decrease. So we need to rise the temperature slowly. That's why there will be no burning, no like charring of the tissue immediate to the electrode, and that will give rise to better conduction of the tissue with reduction in impedance. So here there can be larger zone of ablation. So the different types of electrodes available are single needle electrode, in which there will be no tines. So in these electrode, the zone of ablation will be less. In the multi-tined expandable electrode, from the electrode there will be multiple tines coming, so definitely the zone of ablation will be more. And in the perfusion electrode, this is a special type of electrode in which the cell line will be perfused through the electrode into the target tissue. In that way, it will increase the temperature in the, it will increase the rate of ablation of the tissue. And this is cool tip electrode. This is also a modification of electrode in which cell line will be perfused into the shaft of the electrode, and in that way it will decrease the faster rise of temperature. So it will increase the zone of ablation. And this bipolar RFA ablation electrode, that is a newer technique which is still I think not available in India, and in that there is no requirement of grounding pad. In this one there will be two electrodes placed simultaneously within the target tissue. So in that there will be no loss of heat energy, because the energy will be exchanged between the two electrodes placed in the target tissue. So this is about electrode, and there are three RFA systems available in India. They are the Rita system of RFA, this is Boston Scientific RFA, another is Covidian RFA. So these three systems are depending upon the endpoint indicator. In the this Rita system, the endpoint indicator is the increase in temperature. There will be one temperature set, that is around 105 degrees Celsius. In that the burning occurs. So here when the temperature is reached, that shows the completion of ablation, and it uses the multi-tined expandable array of electrode, and this is the Boston Scientific RFA system, in which the indicator is not the temperature rise, it is the resistance or the impedance. This is impedance based system. When there occurs burning of the tissue resistance increases. Initially when it is placed into the target tissue, there it will conduct the heat. But when there will be burning or charring of the tissue, the resistance gradually increases. So when it will initially it will be lesser, and when it will increase up to 10 times of its initial value, then automatically the ablation gets completed and it gets off. So in that way, this is a impedance based RFA system. This is Covidian system. This is impedance based, but it uses internally cooled single electrode. I already mentioned internally cooled electrode means the cell line will be perfused inside the shaft of the electrode. That will give rise to increase in ablation zone and decrease in the heating of the electrode. So here this uses usually single electrode, and it will be internally cooled. So in this way there are three systems available, and depending upon the availability you can use either of the three. In that ablation I used the impedance based Boston Scientific system. So how to do the procedure? So before doing any procedure, we should look for the coagulopathy, if any, the coagulation parameters. Then we will see for the lesion, where it is, what is the location, whether it is subdiaphragmatic, whether adjacent to any major vessels, bile duct or any organ. So we have to look for the lesion and its size to choose the path. path, like we should go for ultrasound guidance or CT guidance, and the size, depending upon the size we have to take the electrode diameter. If it is 2 centimeter, we have to take a 3 centimeter diameter of electrode. If it is less than 2 centimeter, we can take a 2 centimeter diameter. So in that way we have to look for the initial imaging. Then we will plan the procedure. So usually the procedure is, as it is painful, so it is done under deep sedation. So after anesthesia, the assembly has to be created. As I already shown the RFA system, how the assembly is done. The patient lying down with the RFA system to the generator, the grounding pad. The grounding pad will be connected, and after the grounding pad connection, the system will be started. If it is a temperature based system, the temperature will be set, and if it is impedance based system, after switching on the RFA machine, it will automatically get switch off after the impedance is reached. So after the completion of ablation, we have to properly ablate the tract. The tract in which the electrode was introduced, we have to ablate the tract. So, which is the lesion fitting for RFA, that is less than 3 centimeter of lesion, it can be up to 3 in number. So, up to 3 in number, less than 3 centimeter lesion are suitable, or if 5 centimeter lesion, it should be single one. So, this is the criteria for RFA eligibility. If we do any procedure, it is more important to know about the complications we may meet. So, according to the literature available, the complication rate is only 2 to 5.7%, and mortality is less than 1%. So, it is a relatively safer procedure. We can go for it, and the complications, most common complication is the intraperitoneal bleeding. It ranges from 0.5 to 0.7%, so it is not that common, but among the complications, it is the most common complication. Here we can see a bleeding area. So how to avoid this? By checking for coagulopathy. If coagulation parameter is okay or not, first we have to check that, and after doing the procedure, we have to ablate the tract. Here is hepatic infarction. It is, to prevent that one, we have to carefully place the electrode. This is hepatic congestion. This is because the lesion is located adjacent to the hepatic vein. That's why the during ablation it got injured. That's why it gave rise to congestion. So this is unavoidable, and it has to be managed conservatively. Here there is a diaphragmatic defect. It is adjacent to the diaphragm, so it gave rise to diaphragmatic injury. So we have to be careful and try to create artificial ascites. And here also there is diaphragmatic injury. Here we are seeing thickening of the diaphragm. So again we have to be careful to place the electrode. And this is some subhepatic collection, and here there is breach in the wall of the colonic flexure. So here is colonic perforation. This is a delayed complication, that is biliary stricture. It occurs in case of centrally located tumors. If it is to avoid surrounding organ damage, we have to take a margin of 1 centimeter, safer margin of 1 centimeter to ablate the tissue. And this is needle tract seeding. So this, to avoid the needle tract seeding, we have to properly ablate the ablation tract, as well as we should avoid multiple punctures. And this is the burn, skin burn. It is because of use of defective old electrode that can give rise to skin burn. This is grounding pad burn. It is because of the use of smaller grounding pads. So we have to use more number, at least 4 grounding pads, and larger in size. So we have to take into account these complications and how to avoid that. So specifically for subcapsular lesion, the complications can be because it can be either they are in the surface, so it can be adjacent to diaphragm, so diaphragmatic injury. If adjacent to colon, stomach, or duodenum, so hollow viscous injury. And as there will be lacking of any normal liver tissue, so there is chance of intraperitoneal bleeding or needle needle tract seeding. So these things how to avoid those things in case of subcapsular lesions. So first and foremost is we should avoid direct ablation, direct placement of the electrode into the tumor. We have to take a ream of normal liver parenchyma. So we have to place the electrode obliquely, taking normal liver tissue. And second thing is if possible, we should create artificial ascites. So how to create artificial ascites, I will discuss in my next slides. So this is a lesion in the segment 8 of liver adjacent to IVC, and it is surrounded by lungs. So in ultrasound it will not be visible because of this lung shadow. So this case we we took CT guidance to ablate that tissue, and this is also another lesion. We took CT guidance for ablate the tissue, and this is the way we can create artificial ascites. Here we can see the dark triangle, it obscures the lesions in the segment 7 by the lung shadow and the rib shadow. Here by creation of the artificial ascites there is good window. So in that way we can better visualize the lesion and place the electrode. So this is the way in which we can create artificial ascites by putting a sheathed needle in the perihepatic space under inspiration, followed by removal of the stylet, and here the stylet has been removed, and ask the patient to expire. So in that way the sheath will be in the peritoneal space. Now we can change it into a angio sheath, and we can instill dextrose. That will provide a good thermal barrier. So how to post RFA, how to assess the liver? Immediately after RFA we should do ultrasound to look for any collection or hematoma. After 1 day we have to check for hemoglobin, TLC, etc. for any infection or bleeding. And after 1 month we have to image with CT or MRI to look for the response, and then we have to image quarterly and then 6 monthly after 1 year. So this is the strategy for follow-up, and mostly on after post RFA we have to take this modified RECIST criteria to look for the we all must be knowing what is modified RECIST criteria to look for response. So how the ablated tissue will look on MRI, it will be uniformly T2 hypointense, and on T1 it will be hyperintense, and there should be no contrast enhancement. That is your complete response. So outcome measures are mostly the technical success. After 1 month means there should be complete response. If there is local tumor progression rate, recurrence rate, and major complication rate. So these 4 are the outcome measures. So there are various studies which compare the outcome measures among the intraparenchymal and subcapsular lesions following RFA. So this is a study which show that the local tumor recurrence, technical success, recurrence rate, and major complication rate, they are almost similar as we can see, and the p-value is more than 0.01. That means there is no difference between the outcome measures in the 2 groups. So it shows that these are also many studies which also show that there is no difference between the technical success and major complication rate between these 2 groups. So these studies so that we can the subcapsular ablation is also equally safe, and we should be a little careful, but we can ablate the subcapsular lesions as well. So these are my take home message, that intraparenchymal lesions are also as common as the subcapsular lesion. So we should go for its ablation, but taking in mind that we should do a meticulous planning. We should place the electrode carefully, and if needed we can create artificial ascites, and after the procedure we should ablate the tract properly to avoid many complications. So I think this was informative. Thank you.
Any questions from the audience? Thank you, ma'am, for the wonderful talk. It was really informative. Next, I would like to invite on stage Dr. Manoj Nayak, Assistant Professor AIMS, to give a talk on neural crest disorders. Sir.
Good evening to all, respected teachers and my dear colleagues. Thank you to the organizing team for giving me the opportunity to present before you. Today I will show some of the cases of this rare kind of disorder and discuss with the embryology and pathogenesis of this disease. This is about a 15-year-old male who presented with tingling sensation in right hand, and the flare sequences shows the multiple sulcal hyperintensities in the bilateral cerebral parenchyma, predominantly in the left side. The ASL image shows the arterial transit artifact due to slow flow collaterals on the arterial spleen labeling images. On DS images, there is narrowing of the bilateral supracrinoid ICAs with multiple leptomeningeal and pial collaterals appearing as the pop-up smoke appearance described typically in the Moyamoya disease. This is about another case with similar finding of Moyamoya disease, and this patient has the capeolate macules. So this is a case of Moyamoya syndrome in a patient with neurofibromatosis type 1. This is a 5-year-old female who presented with left side hemiparesis. The axial flare images showed the gliotic changes in the right external watershed in region, likely due to the watershed impact, as well as the indentation of the basilar artery over the pons and the V-shaped genu of the corpus callosum, and on top angio the intracranial vessels to the showed the straightened course throughout its distribution, and the DS images showed the similar kind of appearance, the supraclinoid, bilateral supraclinoid ICA narrowing, as well as the straightened vessels, particularly described as the broomstick appearance in a patient with ACTA2 mutation. The ACTA2 is the gene which helps in the regulation of the smooth muscle cells in the intracranial vessels. This is about a 48-year-old male who presents with headache and Wernicke aphasia. The axial T2 image showed the dilated tortuous vessels in the suprasellar system, and the flare image showed the pachygyric cortex over the bilateral frontal lobe, and the top angio and the DS image showed the dilated tortuous appearance of the supraclinoid vessels, as well as the complete absent of the left ICA after its origin. There is a dilated pericallosal artery without early draining band, typically described as a pure arterial malformation. This is about a 15-year-old male who presented with headache and one episode of loss of consciousness. The axial T2 image showed the multiple dilated collaterals in the quadrigeminal and the ambient cistern region. That is the only clue in this case, and the top angio and the DS image showed the segmental dysgenesis of the ICA, because the supraclinoid ICA looks normal at the level of bifurcation, which is typically described in the Moyamoya disease, but in this case the ICA beyond the ophthalmic artery appears to be degenetic, as the ICA develops from the different segments like 7 segment during the embryology, and it will fuse into one ICA. One segment can be absent, and this is known as the segmental dysgenesis of the ICA. This is a case I borrowed from the book, Barkovich book. This is a classical neuroradiology, pediatric neuroradiology book, where the 10-year child who presented with periorbital swelling, there is hemangioma in the periorbital region as well as the intracranial region which showed the enhancement, and there is persistent trigeminal artery and dysplastic middle cerebral artery. So this is a case of Face syndrome, which stands for the posterior malformation, hemangioma, arterial anomalies, coarctation of aorta, and the eye abnormalities. And this is about a 40-year-old male who presented with progressive weakness in all four limbs. The T1 on the T1 images is the lesion appears to be completely hyperintense, and SWI only there is peripheral blooming, and on subtraction images there is mild enhancement of the lesion. This is a case of actually we gave the diagnosis of carbonoma, but it found out to be pontine melanocytoma. Only clue for differentiating from the carbonoma is the only peripheral part of the blooming. Carbonoma will show the more of the lesion, most of the lesion will show the amount of blooming. This is about a 25-year-old female presented with a reddish discoloration in the neck region. There is ABM sitting behind the over the navi, and this is about a ABM with pigmented nidus. And this is a newborn child who presented with pigmented nevi in all over his body, and there is T1 hyperintensity in the bilateral amygdala, hippocampus, pons, midbrain, as well as the cerebellum. And gradually the T1 hyperintensity has decreased over the time due to increase in myelination of the brain. This is a case of neurocutaneous melanosis. This is a 1-year child who presented with developmental delay and abnormal skull shape. This is previously known as the, we know that is a holoprosencephaly. This is about a craniosynostosis child with a Crouzon syndrome. There is midfacial hypoplasia as well as the abnormal skull shape and the exophthalmos. A 15-year-old male child who presented with a seizure and abnormal skin pigmentation. There is hemimegalencephaly in the right side with the underlying white matter changes. And there is hypopigmented lines along the line of Blasco, typically described as the hypomelanosis of A2. This is a 12-year-old male child with gradual progressing atrophy of the left side of face, and there is on CT and MRI there is atrophy of the facial musculature, and the left cerebral parenchyma appears to be mildly reduced in volume as compared to the right side. This is a perirhombus disease. As you know, this is a classical case of Sturgeon syndrome, where there is a tram-track calcification as well as the pyelangiomas, enlarged choroid plexus, and the port-wine stain over the trigeminal distribution. And close differential of the Sturgeon syndrome, one of the other syndrome is there, where there will be non-scarring alopecia, choristoma of the eyes, and intracranial lipoma, tram-track calcification, as well as the pyelangioma. This is typically described in Fishman syndrome, otherwise known as encephalocraniocutaneous lipomatous syndrome. This is a 40-year-old male who presented with recurrent neurologic deficit. There is multiple chronic lacunar impacts and white matter changes, particularly in the external capsule and anterior temporal region. Minimal amount of signal loss on SWI in bilateral basal ganglia, no enhancement on post-contrast study. This is known as the cerebral autosomal dominant arteriopathy, subcortical impact, and leukoencephalopathies. In short, it is known as the CADASIL. NOS3 is the gene responsible for this kind of disease. And this is a 10-month-old male who presented with gradual swelling in the right side of the forehead. The T1 is the clue which showed the hyperintensity, and there is intense post-contrast enhancement. On biopsy, it is come to be congenital melanotic tumor of infancy. This is about a 20-year-old male who presented with decreased vision and the pituitary insufficiency. There is dolichoectatic vessels as well as the persistent craniopharyngeal canal. What I mean to say that we have the dermal component, skull and brain component, vascular component, as well as the face and neck component. Combining this entity into a single group of disorder, that is known as the neurocristopathy. Actually, it was first described in 1868 by but in Robert Bolande in 1974, they postulated that all these kind of diseases have a similar developmental origin, and in 1995, Duband et al. Showed that it's a fourth germ cell layer after ectoderm, mesoderm, and endoderm. And most of the published articles are beyond 2010 and 2015. Coming to the anatomy days, in our basic embryology, there is neural plate formation and neural crest and the surface ectoderm. After the induction from the notochord, the neural tube will form around 5th weeks of the gestational age, and the neural crest will migrate from the junction of the surface ectoderm and the neural plate into the different locations of the body. Different genes are responsible for this kind of migration. It may follow the lateral pathway into the skin, will form the dermatomyotomes and the melanocytes, and medial pathway into the different ganglia, adrenal medulla and enteric plexus. These are the pathway of migration of the neural crest cells. In embryo, different segments of the neural crest may be there, like cephalic, cardiac, trunk NCC and the sacral NCC, and these type of NCC will form the different components of the body, like in the cephalic will mostly cover the brain and the face part, cardiac will form the heart and the great vessels, and the trunk NCC like dorsal root ganglia, adrenal medulla, and sacral NCC the enteric nervous system. The complex anatomy in the neck region is the pharyngeal pouches and arches. These neural crests migrate and shift into the different pharyngeal arch and pouch, and in aberration any development will cause the defective type of disorder, which are most of the cases I have described. These are the first arch, second arch, third arch and fourth arch derivatives, as well as the pouches, and one cleft is there, that is from the external auditory canal. These are the cells and tissues derived from the neural crest cells, from the cranial neural crest, cartilage and bones of the skull and face. Adenohypophysis in pituitary will form the neural crest cell. Vascular smooth muscles, cranial meninges, these are from the cranial NCC. Vagal NCC will form the autopulmonary septum, melanocytes, thyroid C cells, parathyroid gland, thymus, all those are the vagal NCC derivatives. Truncal NCC will form the Schwann cells and the melanocytes, neurons of the enteric system, and the sacral NCC will form the enteric ganglia, sympathetic ganglia and the genital tract innervation. This is a schematic diagram where the neural crest cells are distributed all over the body. Different type of classifications are there. Previously, literature described the neoplastic, degenerative and mixed degenerative and neoplastic cause, but we have added the vascular cause into it. Multiple vascular diseases are there. Like the CAMS, Moyamoya disease, ACTA2 mutation and the Face syndrome. This is a published article in AJNR of ACTA2 syndrome, where there is straightened course of the vessels, B-shaped genu of the corpus callosum and deficient anterior cingulate cortex, and the twin peak sign due to indentation of the basilar artery over the pons, and there is increased diameter of the anterior posterior brainstem. This is a cardiocephalic neural crest syndrome, where there is coarctation of aorta and agenesis of the bilateral ICA. The ICAs are developed from the cranial NCCs, and the brachiocephalic artery and the arch of aorta are developed from the vagal NCC. Both are related. We can correlate after the discovery of the neural crest diseases. This is about a cerebrofacial arteriovenous metamorphic syndrome, which stands for the CAMS. Three types of are there, like CAMS1 and CAMS2 and CAMS3. During the embryology, the prosencephalon, the forebrain, prosencephalon will have the similar appearance of the nose and orbit. The mesencephalon will have the similar picture of the maxilla and the retina, and CAMS3, which forms the rhombencephalon, have the lesion in the mandible. When we have any lesion in the corresponding region, and we have to search for any corresponding structural lesion in the face. This is a CAMS2 patient where the AVM in the right parieto-temporal region with bleed with a retinal AVM. This is a CAMS2 patient. The cranial NCC, some of the diseases are like craniosynostosis, holoprosencephaly, Treacher-Collins syndrome, and hemifacial microsomia. And the craniosynostosis, the neural crest cells will form the bones and the membranes over the skull bone. A defective genetic development of the neural crest cell will form the abnormal fusion of the cranial bones, will form the craniosynostosis. The cleavage of the brain parenchyma is associated with the JIG2 gene and the SHA gene, and these genes are helps in migration of the neural crest cells. It is believed that the due to defective migration of the neural crest cells will form the holoprosencephaly. And this is about a Treacher-Collins syndrome where there is midfacial hypoplasia as well as the external auditory canal and the middle ear cavity and the ear ossicle abnormality in a case of Treacher-Collins syndrome. The inner ear is typically spared most of the cases because it has a separate origin from the endoderm, not from the pharyngeal pouches. When there is one side of the face is affected, that is known as the hemifacial microsomia, otherwise known as the golden arch spectrum. In this case, the left ICA is absent as well as the facial hypoplasia, middle ear and the external ear abnormality. Vagal NCCs are like the Hirschsprung disease, Char syndrome, and the Diger syndrome because the different parts of the pouches like third pharyngeal arch, fourth pharyngeal arch, and the pouch form the different types of tissues, and that will form the different type of diseases. This is about a Char syndrome where there is coloboma of the iris, choanal atresia, and the ear abnormality. This is due to CHD7 gene mutation that helps in migration of the cranial and vagal NCCs. Hirschsprung disease is one of the spectrum in the neural crest cell where there is absence of the ganglion cells in the Auerbach plexus and the Meissner's plexus. When the migration of the neural crest cells about to complete before 6 weeks of age, when there is arrest below 8 weeks of age, their entire colon may be aganglionic, and the arrest occurs around 10 to 12 weeks of the gestational age, then we can the classical Hirschsprung disease can occur. Different genes like RET genes and SOX10 genes are responsible for this kind of migration. Neoplastic like medullary carcinoma, thyroid, melanoma, pheochromocytoma, and paraangioma and neuroblastomas are the neoplastic variety of the neurokystopathy, where there is twin presented with the bilateral neuroblastoma and other child have left side neuroblastoma with mets near the craniovertebral junction. And this is the pheochromocytoma and paraangioma. And as we know that MEN syndrome has association of pituitary and parathyroid and pancreatic neuroendocrine tumors. Previously, I was wondering how these are connected, but after discover of these neural crest cells, because the adenohypophysis, parathyroid cells, and the neuroendocrine cells have a common origin of neural crest cells. Now, these diseases have combinedly known as the MEN syndrome, where we can see different type of neuroendocrine tumors and mucosal neuromas. And then the C cells of the thyroid will produce the medullary carcinoma of thyroid, mostly occurs in the lateral part of the thyroid gland. This is about a schwannoma in the cysternal segment of the right trigeminal nerve in the Meckel's-Cave region. T1 hyperintensity is there. That is the clue for the melanotic schwannoma. Coming to the mixed degenetic and neoplastic variety, there may be dermal component like in capillate macules in the neurofibromatosis, or may be tumors of the neural crest origin, or may be vascular origin. These are seemingly similar type of diseases with aberration in neural crest development. These are the neurocutaneous syndrome associated with neural crest cells, like pigmented anomalies are mostly associated with neural crest cells, and some of the tumors are associated with the neural crest cell migration, and some are also non-neural crest migration. It is a recently described entity, and gene therapy and gene editing may be required for preventing these kind of disorders, and due to nature of multipotent nature of the neural crest cells, cell programming and stem cell manipulation can be done, and till now more than 50 diseases has already been published in the literature, and many are yet to come, so stay tuned. This is a nice article in Radiographics. You can go through it for the basics of the neurokystopathies. This is one of the article we have published, and it will come online soon. It is accepted in Journal of Clinical Imaging Science. Thank you. Happy to answer any questions.
Any questions from the audience? Thank you, sir, for sharing your knowledge with us. the so much of neural crest disorders with so much of images and examples and cases. It was really informative. Now we'll heading towards the rest of the paper presentation by the PG students, and it will be coordinated by Dr. Tara sir.
Just to come over to the front. We had finished with Dr. Manikam. Next is Dr. Manoj Kumar, Dr. Nikhil, Dr. Pragyan, laptop बंद हो गया. हाँ बेटे क्लोज करेंगे. Using the fetal sacral length measurement as a new parameter for assessment of gestational age. Introduction. As we know, we usually take fetal biometry, BPD and HC, femoral length and abdominal circumference. Usually not measured accurately in condition like in third trimester in deeply engaged head or multiple pregnancy. Also in skull deformity, achondroplasia, also in femur length deformity. So alternate biometry can be used to estimate the gestational age. So we are assessing, correlating the fetal sacral length for the gestational measurement and comparing with the usual biometry. Methodology: in the 80 cases of pregnant women, a singleton pregnancy is taken with no usual abnormality. In single setting, we take the usual fetal biometry and sacral length as a additional parameter, and correlation and mean was applied to for analysis. And the aim is to prove the fetal sacral length can be a reliable parameter, and the objective is also to correlate with gestational age, and it can comparing with the usual biometry profile. Inclusion criteria: 16 to 40 week of gestational age, single pregnancy, and known LMP, and fundal height corresponding to the LMP. Exclusion includes the IUGR, multiple pregnancy and other complications. And these are the samples we taken, age corresponding to the most commonly 21 to 30 years, and mostly are primary and second gravida. Most common gestational age was 26 to 30 weeks was taken, and age is most common in 21 to 30. This is the measurement value and correlation of sacral length. Sacral length in 80 cases ranged from 12 to 39 mm. Average mean value is 25.79. The standard deviation is 6.8. Corresponding to 95% confidence interval. Sacral length gradually increased from 13.6 at 16 weeks to 39 mm at 40 weeks. It was lower by 1 to 3 mm. Corresponding gestational age from 16 to 30 weeks, therefore it will increase. So we are getting the R value 0.98 and P value was less than 0.001. So this is the equation we derived. Gestational age equal to 0.87 into sacral length in mm plus 4.699. These are line diagrams of usual biometry, BPD, head circumference, femoral length and abdominal circumference with standard nomogram. Linear correlation derived. And this is the data of sacral length distribution. We can see here starting from 16 week to 40 week and from 12 mm to 35 mm, plus or minus with including mean maximum up to 38 mm derived. And so the value showing the scatter diagram showing the positive correlation between the gestational age and fetal sacral length. And correlating with the other usual biometry, coefficient of correlation is
done here, and mean error is 0.8 weeks. Maximum is 2.6 weeks, which is lesser than the abdominal circumference. So this current study showing the positive linear positive correlation between the gestational and fetal sacral length. So the trimester biometric value in local population were lower than the standard nomogram. So the reduction value may be due to the influence of race, genetics and environmental factor. This should be kept in mind. And in femoral length is the most significant parameter in third trimester. And after that, femoral length is more accurate. When other parameter measured lower than standard in our local population, maximum mean error in predicting gestational with the abdominal circumference is 1.066. And results up to 30 weeks there was sacral length is lower by 1 to 3 mm. Therefore, after 30 weeks to 40 weeks it will improve. It is corresponding to the similar gestational age. So it is showing the linear correlation, and according to the linear regression model, the equation we got is this one. And maximum mean error is predicting gestational velocity was found with abdominal circumference is 1 week. Conclusion: relation between sacral length and gestational age is strong and linear and statistically significant. So it can be used as alternate parameter, and routine parameter can lower than the standard nomogram in local population. This should be kept in mind to avoid clinical decision. Thank you.
Next presenter, Dr. Nikhil.
Good evening to one and all. Today I am going to present about examining the role of CT enterography score as the indicator for evaluating the severity of active ulcerative colitis. Ulcerative colitis is an inflammatory bowel disease characterized by diffuse inflammation of bowel mucosa. It mainly affects the rectum, sigmoid colon, but may also involve the entire colon and the terminal ileum. It is a chronic disease and it needs follow-up, proper diagnosis. For the assessment of ulcerative colitis, presently modified Mayo score is used, which is based on the clinical symptoms and the colonoscopy. However, it does not provide information on complications and extraintestinal manifestations. And in severe cases, colonoscopy is contraindicated as there is risk of perforation or exacerbation. Due to non-specificity of the symptoms, so there is need of supplementing colonoscopy with radiological and histopathological examination. My major aim is to examine the role of CT enterography score as the indicator for evaluating the severity of ulcerative colitis. I have taken 32 patients with active ulcerative colitis with colonoscopy and CT enterography. Based on the modified Mayo score, the patients were divided into 3 groups: mild, moderate and severe. And then cumulative CT enterography score was calculated in each patient. And then the correlation between the Mayo score and the CT enterography score was done. In the modified Mayo score, the parameters were stool frequency, rectal bleeding, mucosal appearance at the endoscopy, and the physician rating of the disease activity. Based on the modified Mayo score, if the score is between 3 to 5, it is categorized as mild. If it is between 6 to 10, it is moderate. If it is greater than 10, it is severe disease. The procedure of CT enterography: first, the patients were asked to fast for 8 to 12 hours before the CT scan. Then the enema was performed on the night before the examination. And prior to the scan, patients ingested a total of 1.5 to 2 liters of 2.5% mannitol solution in 400 to 500 ml aliquots every 15 minutes. And for proper achievement of colonic distension, colonic retention enema was performed. Around 300 to 500 ml of 2.5% mannitol was given for enema purpose. Then the patients were scanned in United Imaging 160 slice using the parameters. Then 3 phases were obtained. One pre-contrast image, non-contrast image was obtained. Then iohexol Omnipac was injected, and one scan was taken at 23 to 25 seconds and another at 50 to 60 seconds. Then the parameters of CT enterograph score included the extent of the ulcerative colitis, which is based on the Montreal classification. E1 is defined as proctitis, that is the lesions until the rectosigmoid junctions. E2 is left-sided colitis under the splenic flexure. E3 is extensive colitis above the splenic flexure. For bowel wall thickening, if it is less than 3 mm, a 0 score was given. For 4 to 6 mm, 1, 7 to 9 mm, 2, and 10 mm, 3. Then coming to mural stratification. Mural stratification is circular intestinal wall and submucosal widening with decreased attenuation. Then mural hyperenhancement and mesenteric hyperemia. There is increased mural density and engorgement of the mesenteric vessels post-contrast. And perirectal stranding is defined as increased attenuation, that is 10 to 20 HU more as compared to the normal fat. This is due to edema and inflammatory cell infiltrates. Then for lymph node enlargement, any mesenteric lymph node with short axis diameter greater than 5 mm were defined as enlarged, and 1 point was given. For mucosal bubbles represent ulcers, which are round small bubbles in interrupted mucosal layers of intestinal wall. If they are found, 1 point was allotted. And in cases of ulcerative colitis, there is also luminal narrowing. In cases of luminal narrowing, 1 point was allotted. And in severe cases, there is loss of hostrations, lead pipe colon, it is known as, and we allotted 1 point. And in cases of intestinal pseudopolyps, we allotted 1 point. And coming to results, according to modified Mayo score, the patients were first graded into mild, moderate, and severe groups, and then the cumulative CT enterography score was calculated. These are the spectrum of CT enterography features. We found that between mild and moderate patients, there was significant difference in the spectrum of mucosal bubbles. Between the moderate and severe groups, we found mural stratification, loss of hostrations, and enlarged mesenteric lymph nodes were significant. And in mild and severe groups, we found mucosal bubbles, loss of hostrations, engorged mesenteric vessels, and enlarged mesenteric nodes were significant. But there was no significance between the bowel wall thickening and mural hyperenhancement. We found that in CT cumulative scores in mild cases was 4.9 plus or 2.3, moderate cases 7.6 plus or minus 2.6, and severe cases 10.9 plus or minus 2.0. We found a positive linear correlation between the CT severity, modified Mayo score and CT enterography score. Depending on the symptoms alone, we cannot diagnose ulcerative colitis, so there is need of supplementing the Mayo score with CT enterography and histopathology. Thank you.
अच्छा नेक्स्ट डॉक्टर प्रज्ञा.
Good evening everyone. My presentation topic is role of MR imaging in evaluation of non-traumatic hip pathology. So coming to introduction, the hip is a stable major weight bearing joint with significant mobility. So it can be involved by numerous pathological conditions like congenital, developmental, infective, arthritic and neoplastic. Hence early diagnosis and characterization of the lesion play a vital role in proper management and follow-up of the disease. Then our aims and objectives are the study of MR imaging picture of various non-traumatic hip pathology and its further characterization. For material method, we included the patient coming to the department with non-traumatic acute or chronic hip pain. The study is a type of observational study of sample size of 50 patient and over a period of 1 year. Then the inclusion criteria were patient presenting with acute or chronic hip pain, patient referred with clinical suspicion of hip pathologies. And exclusion criteria are patient contraindication to MRI like claustrophobic patient and patient having ferromagnetic implant, and other patients like patient having history of acute trauma or previous history of hip surgery, and age less than 18 years. Then the protocol, the examination is performed by a 1.5 Tesla scanner with a dedicated body coils in the following sequences: axial and sagittal T1 and T2 weighted images, the star coronal images, and axial and coronal PD images, and gadolinium contrast is given whenever it is necessary. Then coming to the result part, among the 50 study patient, the 32-year male in a male is to female ratio of 1.7:1. And the age of the most of the patient, the age range vary from 80 to 70 year, and most of the patient in the age group of 30 to 40 year. Then the coming to the symptom, most common symptom in our study is bilateral hip pain seen in approximately 19 number of patients, then followed by left hip pain, then right hip pain. And the other associated symptoms are restricted movement, ipsilateral knee pain, and less commonly fever and weight loss. Then the distribution of the patient according to MRI finding in painful hip joint. The most common MRI finding in our study is articular cartilage thinning, seen in 56% of the patient, followed by bone marrow edema, sclerosis, subchondral cyst, subchondral erosion, joint effusion. The less common finding here is femoral head deformity or collapse, synovial thickening, synovial enhancement, double line sign, and soft tissue swelling or edema. Then the distribution of the patient according to diagnosis by MRI, the most common diagnosis in our study is avascular necrosis, seen in 19 number of a patient, constituting 38% of the study, followed by osteoarthritis seen in 22% patient, then infective causes like septic and tubercular arthritis consisting of 20% of the patient, then inflammatory arthritis 10% of the patient, tumor both primary and metastasis each consisting of 2% of the patient, then femoroacetabular impingement in 2% of the patient, and acetabular labral tear due to repeated motion in 2% of the patient. Here the imaging of a coronal T2 weighted imaging of a 43-year male with bilateral hip avascular necrosis showing patchy areas of geographical marrow altered marrow intensity denoted by the red arrow, and the double line sign denoted by the yellow arrow with mild joint effusion on the left side. The second image, here a coronal T2 weighted image of a 50-year male with left hip osteoarthritis showing marked joint space narrowing with eroded articular cartilage, and the femoral head is also deformed here with subchondral cyst denoted by the yellow arrow, and the bone marrow edema denoted by the asterisk. Coming to discussion, in our study, maximum number of the patient of the painful hip joint falling in the age group of 30 to 40 year with a male is to female ratio approximately 1.7:1. Similarly to Conditi et al., they also find that their common age group is 30 to 40 year with a male to female ratio 2.8:1. Then the common complaint in our study population is unilateral hip pain seen in approximately 31 number of patients, followed by bilateral hip pain seen in 19 number of patients. Similar to the Datta et al. Also observed the similar finding in their study. Then the most common underlying pathology in our study is avascular necrosis, followed by osteoarthritis and septic arthritis, then inflammatory arthritis. The similar finding is seen by Kalekar and Reddy et al. In their study. That is the first common finding is avascular necrosis, second one is non-traumatic hip pain, that is osteoarthritis. So in conclusion, MRI is an informative, non-invasive, rapid, accurate, sufficient imaging modality to be the modality for delineation of the hip pathology and its further characterization because of its good resolution, improved differentiation of the tissue contrast, and capacity of multiplanar imaging. So these are my reference. Thank you.
Dr. Rabin Kumar Behra.
Namaskar. Today I am presenting my topic on independent predictors of mortality in intracerebral hemorrhage, a retrospective study. Primary intracerebral hemorrhage. In today's world, it accounts for the approximately 10 to 15% cases worldwide it is presented with patients with come with OPD or else casualty, present with symptoms of slurring of speech, hemiparesis, severe headache, altered sensorium, and altered hypertension. This case, till we are advancing in our treatment lines since till now, but there is not much reduction in the mortality rate shown in India and also over the world. It is distributed in equally all over the world. For this, the objective of my study is to analyze and evaluate the different in-hospital determinant to predict the prognosis early mortality in intracerebral hemorrhage patients using my CT modality. In my method, I have taken 150 patients. In my ICU and OPD case, ward cases of the neurosurgery and neurologic OPD, we have included the cases of the patients more and equal or more than 12 years and patients of non-traumatic origin, and we excluded the cases less than 12 years and other like ischemic stroke cases or any venous thrombosis. Like for the calculation of our study, I am using here the volume analysis, calculate the volume and the ICS score. In the ICS score, I mean the components of the ICS score are GCS score, ICS volume, and interventricular hemorrhage, presence of interventricular hemorrhage, and supra or infraventricular location, and the age. Total score, as per the total score, we add them, and as per the total, we measure and analysis on a chart. The different population in those patients, in that those we calculate the volume, in analyze how much the mortality rate, and the location where the most commonly usually we face, most commonly it is basal ganglia, thalamus, in infratemporal region, cerebellum, brainstem, all these locations we calculated, and also the cerebellum, lobar location, and the interventricular extension. All the data is formulated in a tabular form. From the table, we come to know that these are the locations. From the table, we come to that the mortality rate. The mortality is higher in the age. As the age progresses, it is more incidence. Incidence also increases. The mortality rate also increases. It is found in more in male patients in my study, and it is mostly common in basal ganglia, thalamus. But in my study, thalamus predominates the mortality rate above the basal ganglia, and more the intraventricular presence of intraventricular hemorrhage, the more the mortality rate. Then also there are, if the systolic blood pressure, as per the systolic blood pressure, more less than 140, 140 to 200, more than 200. The cases those are presented with more than 200 blood pressure, they have a high mortality rate. Then also the highest mortality also recur in the patient's volume, as per the volume. As per there is less than 30 ml volume, more than 30 ml volume. I have taken less than 30, 30 to 60, more than 60. But in my case, the more the volume increases, the mortality rate also increases. Among these, there is a 30 to 60 ml cases, more incidences are there, more cases are found. But as compared to in that cases, 60%, more than 60 ml, more than 60 ml volume, the more mortality rate among them, more is there. If there is midline shifting is there, then also mortality also increases. As per then summarize all this, the ICS score we compare, as the ICS score increases, the mortality also increases. The GCS also, the lower the GCS, the more is the mortality. But all my study has been that I have studied, I compared with other studies, reference studies, that they are all near about my study, they are matching to my study. Some variations may be there because it is less interval is there, and also I have taken less number of cases. That's why. In my conclusion, we come to know that as the age, ICS score is a more sensitive, simple, and bedside tool we can assess, and bedside also we can assess how much prognosis will be there, how much the 30-day mortality. So we can assess so that we can take as early as we can intervention take place, we can take intervention steps to the decrease the mortality. That's why we come to a conclusion that the age, as the age increases, the age more than 80, the mortality rate is high. The systolic blood pressure more than 200, and the location by more is the brainstem and thalamic location, and infratemporal location cerebellum. If that is more high, is the volume more than 30, there is also mortality rate increases, and a midline shifting or intraventricular extension. These all things come to more mortality rate. That's why, in conclusion, hematoma, in my study, I have taken the more considering the hematoma volume and ICS score as the earliest. That's why hematoma volume is an easy bedside tool to assess the mortality in first 30 days. The use of such scale can improvise the standardization treatment in future. That's all. Thank you.
The evaluation for posters has been done, and the order of names is not the rank order, but these names have to prepare for a short interview, viva tomorrow. Dr. Shruti from AIMS, Dr. Gudli Nanda from SCB, Dr. Amrit Prasudas, SAM, Dr. Saurav Agarwal, SAM, Dr. Mahavir Yadav, KIMS, Dr. Jayaswari Amri, Dr. Ruban Bansal, SAM, Dr. Sitwar, SAM, Dr. Sitra, Dr. Sumeda Sirohi, KIMS, Dr. Lipi Puspa, MKCG, Dr. Riya Dubey, KIMS, Dr. Dhirendra, AIMS. So 12 of you should be ready with your poster, revise your posters today, and tomorrow there will be a short interview and final ranks will be announced tomorrow at 5 p.m. So next presenter, Salini Chaturvedi.
Good evening, everyone. I'll be talking about role of ultrasonography in the assessment of adhesive capsulitis of the shoulder. As adhesive capsulitis of the shoulder is also known as frozen shoulder, is a condition characterized by thickening and contraction of the shoulder joint capsule. It is most commonly seen in women of 5th to 6th decade and is commonly associated with diabetes. Adhesive capsulitis of the shoulder has been diagnosis of exclusion on sonography due to lack of specific diagnostic criteria. The study prospectively assessed the efficacy of sonography using static and dynamic parameters. In this study, we studied total 90 subjects, 60 symptomatics, 30 controls, divided into 3 groups, adhesive capsulitis, painful shoulders, and control groups. And the parameters studied sonographically were coracohumeral ligament thickness, increased soft tissue in the rotator interval, and restriction of abduction. The coracohumeral ligament was scanned in the sitting position with the shoulder in neutral position and the forearm extended. Coracohumeral ligament evaluated in the axial oblique plane and was visualized as a thin hypoechoic structure arising from the coracoid process surrounded by a triangular echogenic fat and reaching up to the rotator interval. And it was measured while the arm being in external rotation. The rotator interval is a triangular space in the anterior superior aspect of the rotator cuff, bounded above by the supraspinatus tendon and below by the superior edge of the subscapularis tendon. The rotator interval was optimally visualized in oblique plane, and the gray scale and the color Doppler characteristics were assessed. There was restriction of abduction, which is evaluated for the supraspinatus tendons during the abduction. The transducer was placed oblique coronal plane with its medial margin at the anterolateral edge of the acromion. The shoulder was abducted anterolaterally, that is while being abducted, having in flexion position, while the thumb being down, that is in internal rotation. Limitation of continuous smooth sliding movement of supraspinatus tendon underneath the acromion was noted, or the buckling of the soft tissue lateral to the acromion edge described was indicative of restricted abduction. In the study, the sonographic visualization of coracohumeral ligament and its mean thickness, which came out to be 1.2 mm, were highest in the patient group of adhesive capsulitis, and a cutoff value of 0.7 to 0.8 mm was found to be accurate to diagnose adhesive capsulitis. Increased soft tissue in the rotator interval was also quite diagnostic. Hypoincreased soft tissue in the rotator interval was found to be 90% specific in the patients of adhesive capsulitis. On dynamic scanning, also external rotation was studied, although it was not, the findings were not quite specific, so that's why it's not mentioned here, and the restriction of abduction was quite specific. So here we can see, here we can see the long axis ultrasound scan of the proximal portion of the coracohumeral ligament. In a patient with adhesive capsulitis, the ligament appears hypoechoic and thickened. And the same patient having MR images, and the first one is the sagittal T1 image showing thickened coracohumeral ligament, and here is the coronal proton density fat saturated image, and the T1 images showing thickening of the joint capsule in the axillary recesses. Here we can see the subscapularis tendon and supraspinatus deltoid, and this is the long head of the biceps, which ma'am had demonstrated earlier, and there is increased soft tissue and increased vascularity. Same here, we can see hypointensity of the rotator cuff interval in the patient and the similar patient. Here is the demonstration is the normal, here the subscapularis, it's the acromion, here is the smooth sliding, there is no buckling, but here in the patient with adhesive capsulitis, we can see there is some amount of buckling is seen, which is suggestive of not such a smooth sliding of the tendon under the acromion. So, to conclude, sonography revealed a high accuracy for diagnosing adhesive capsulitis of shoulder and in differentiating it from other causes of painful shoulder, and thus can be it has the potential to be adopted as a preferred imaging modality. Thank you.
Good evening to all. Today the topic of my presentation is CT evaluation of preoperative sarcopenia and its impact on postoperative complications of hepatopancreatobiliary surgeries. Despite surgical advances, postoperative complications persist, having an impact on oncologic outcomes and treatment cost of hepatopancreatobiliary surgeries. Assessment of risk factors is of prime importance to improve the post-surgical outcomes. An important risk factor among them is sarcopenia. Sarcopenia is assessed by using the skeletal muscle index at the third lumbar vertebra on computed tomography. Skeletal muscle index emerged as an objective, non-invasive, precise approach to calculate whole body mass muscle. Aim of my study is to see the association of preoperative sarcopenia with immediate and delayed postoperative complications in patients undergoing surgeries for hepatopancreatobiliary malignancies. Objectives are primary and secondary. Primary objective is to compare postoperative outcomes in sarcopenic and non-sarcopenic patients undergoing surgeries for HPV malignancies. Secondary objectives are to compare the postoperative infection rates in sarcopenic and non-sarcopenic patients and to assess the prevalence of sarcopenia in HPV malignancy patients. All patients suspected of having HPV malignancies who attended OPD or casualty of IMS in some hospital underwent required investigation to establish the diagnosis. Patients who underwent CT abdomen and pelvis, the skeletal muscle index was calculated to evaluate sarcopenia. Skeletal muscle area in centimeter square was defined as the sum of paraspinal psoas transversus abdominis, interior external oblique and rectus abdominis muscle at the level of L3 end plate, and total cross-sectional area at the level of L3 of abdominal skeletal muscle was normalized to height and calculated as skeletal muscle index at L3 level. The image depicts the muscles that has to be included in the calculation of skeletal muscle index. The green represents the psoas major muscle, blue represents the quadratus lumborum, red represents the erectus spinae muscle, yellow represents transverse abdominis, internal external oblique muscles, and purple represents the rectus abdominis muscle. Cutoff for sarcopenia is less than 36.5 centimeter square per meter square for males and less than 30.2 centimeter square per meter square for females. Cutoff was taken from an Indian study from Tertiary Care Center. All sarcopenia and non-sarcopenia patients underwent required surgical procedure according to respective malignancies. After the surgery, patients were assessed for 30 days for post-operative outcomes. Post-operative complications were compared between sarcopenic and non-sarcopenic patients having HPB malignancies. Here is a case of a male patient whose height is 167 centimeter. The cross-sectional area at the level of L3 came out to be 92.07 centimeter square, and the skeletal muscle index came out to be 33 centimeter square per millimeter square, which is under the category of sarcopenia according to the cutoff. Here's another case of a female patient whose height is 148 centimeter. Cross-sectional area at the level of L3 came out to be 85.42 centimeter square, and skeletal muscle index came out to be 38.9 centimeter square per millimeter square, which is normal for this patient. Here are the results. Sample size is 53 patients. This table represents the distribution of sarcopenia and non-sarcopenic patients. Non-sarcopenic patients came out to be 58.5% of the total, and sarcopenic patients came out to be 41.5% of the total. This table represents the distribution of post-operative complications, which included pancreatic leak, bile leak, delayed gastric emptying, and post-pancreatectomy hemorrhage, which came out to be slightly more in non-sarcopenic patients, which is 51.61% of the total, and in sarcopenic it came out to be 50% of the total. And the post-operative infective complications like surgical site infection, pneumonia, intra-abdominal abscess came out to be more in sarcopenic patient, approximately 45.45%, and in non-sarcopenic patient it came out to be 16.12% of the total. And the total post-operative complications were seen more in sarcopenic patients, which came out to be 95.45%, and in non-sarcopenic patients it came out to be 67.76%. Coming to the conclusion, the study highlights the importance of assessing sarcopenia in patients undergoing HPB cancer surgery. Sarcopenia was associated with adverse post-operative outcomes, including higher rates of total post-operative complications and post-operative infections. These findings showed that identifying sarcopenia patients before surgery may enable healthcare providers to implement prehabilitation strategies, targeted interventions to optimize patients' muscle mass and strength, and enhance the surgical outcomes and overall well-being of the patients. These are my references, and thank you.
Dr. Sugyani Mahapatra. 1, 2, 3, 4, 5.
Welcome all. Today the topic of my paper presentation is role of MRI in evaluation and characterization of degenerative compressive myelopathy. So compressive myelopathy, these are the neurological manifestations due to compression of spinal cord, which can be of varied etiology like degenerative, infective, neoplastic, and some miscellaneous causes like vascular malformations. It can be traumatic and non-traumatic. Here in our study, we studied the role of MRI in non-traumatic compressive myelopathy with focusing on etiological distribution and degenerative compressive myelopathy. So aims and objective: to evaluate the frequency distribution of various causes of non-traumatic compressive myelopathy based on age, gender, and spinal level, and to evaluate the frequency distribution of various types of degenerative compressive myelopathy based on gender and the different characteristic findings. Materials and method. Type of study: it is a cross-sectional study taking 100 patients as sample. Inclusion criteria: patients of more than 16 years of age with clinical suspicion of compressive myelopathy like complaining of neck pain, back pain, paraparesis, quadriparesis, sensory deficits, bladder dysfunction, inability to walk, tingling and numbness over limbs. And exclusion criteria: patients with history of trauma or surgery, especially spinal surgery, and patients with metallic implants, patient with non-compressive myelopathy. Routine sequences like T1 non-contrast, T1 axial, T2 axial, T1 sagittal, T2 sagittal, and coronal star sequences were taken. And post-contrast fat set, T1 axial, T1 sagittal, and T1 coronal images were taken. And slice thickness of 4 mm was used. So my results are In etiological distribution, from 100 patients, degenerative causes found to be 47, infectious 28, neoplastic 22, and others 3 patients. So coming to the age distribution of the individual causes, in the age distribution, we have divided the age groups as per 16 to 30, 31 to 45, 46 to 60, 61 to 75, and 76 to 90. So we found the degenerative etiology is most commonly found in the 61 to 75 age group with a percentage of 38%, and infectious etiology is found mostly in 46 to 60 per age group with 32%. And neoplastic causes mostly in 31 to 45 age group with a 27% percentage. Then coming to the gender distribution, in gender distribution, except the neoplastic causes, the others degenerative infectious are mostly predominantly affecting the males than females, but in neoplastic, the ratio of male is to female is 0.6:1, affecting the females more. Then coming to the level of spine involvement, in individual causes, it was found that in degenerative causes, the lumbosacral region is most commonly involved with a percentage of 46%, and in infectious, thoracic level is involved with 50% percentage. In neoplastic etiology, it was found that cervical level is most commonly involved, that is 45%. And then coming to the gender distribution of degenerative compressive myelopathy across various age groups. So among all age groups, it was found that the degenerative causes mostly affect male more than female, but in 76 to 90 years of age group, females are most commonly affected with a percentage of 80%. Then coming to the characterization of degenerative compressive myelopathy on MRI, we have found multiple findings that suggest the degenerative compressive myelopathy like osteophytes, ligamentum flavum hypertrophy, modic changes, facet joint arthropathy, disc bulge, disc protrusion, disc extrusion, disc sequestration, and disc migration. Among all these findings, we found that the disc protrusion is the most common finding with a percentage of almost 62%, followed by osteophytes with 55%, and followed by modic changes in 53%. So these are the images, first 2 images showing disc protrusion, the third image showing spinal cord compression due to spondylodiscitis, fourth image showing cord compression due to TB spine, and the last image showing cord compression due to MEDS. Then coming to the discussion, most common cause of non-traumatic compressive myelopathy is degenerative, which affects mostly the age group of 6th to 7th decade and the lumbosacral level. And infectious causes predominantly affect 40 to 60 years of age group with thoracic level of involvement. Neoplastic etiology affects the age group of 30 to 45 years with cervical level most commonly. Among all etiology, the neoplastic causes affects females more than males, rest all affects predominantly males. In degenerative category, males are more affected in all age groups except the 76 to 90 years of age group where females are more affected. And disc protrusion, osteophytes, modic changes are the most common finding in degenerative compressive myelopathy. Then coming to the conclusion, MRI is an excellent modality for investigation of this non-traumatic compressive myelopathy because of its superior soft tissue contrast resolution and multiplanar capacity. It is this non-compressive myelopathy, compressive myelopathy is a major cause of morbidity and disability in our population. Hence, early detection and timely diagnosis can vastly reduce the disease burden. There is considerable overlap between the presenting symptoms of compressive and non-compressive myelopathy. So the management varies accordingly. So it is of immense importance that MRI should be routinely advised as the part of the preliminary investigation. Thank you.
Next presentation is by Dr. Sumant.
Good evening everyone. My study is about use of vessel wall MR imaging in diagnosis of intracranial inflammatory vasculopathies. Conventional CT angio and MR angio are frequently used in investigation of intracranial vasculopathies. These techniques are helpful in analyzing vessel lumen and diagnosing vascular stenosis, occlusion and vessel irregularities. However, evaluation of vessel wall abnormalities using CTA and MRA is limited. Some disorders of the intracranial arteries, such as intracranial atherosclerotic diseases or vasculitis, arise within the vessel wall without always narrowing the lumen, particularly in the initial phase. MR sequences with high spatial resolution and blood black effect has made it possible to image the vessel wall in 3 dimensions and to detect pathological changes in the wall. Development of intracranial vessel wall MR enables diagnosis of vessel wall abnormalities like vasculitis, atherosclerotic disease, intracranial aneurysms, intracranial dissections, reversible cerebral vasoconstriction syndrome, and Moya-Moya disease. Vessel wall MR can also be used to follow disease progression and monitor treatment effects such as for vasculitis or ICAD. The main aim of this study is use of vessel wall MR imaging in diagnosis of intracranial inflammatory vasculopathies. It's a hospital-based cross-sectional study with a sample size of 10 patients with a duration of 6 months. These are the inclusion and exclusion criteria. Vessel wall MR sequence was performed on 1.5 Tesla MR scanner equipped with head and neck neurovascular coil. T1 weighted 3D cube sequence where specific parameters modifications have been optimized to achieve sufficient signal to noise ratio and contrast to noise ratio for vessel wall imaging. Parameters was set to reach isotropic 3D imaging, good CSF and blood suppression, and to reduce scan time. The demographic profile of the study is the total number of patients are 10 with a mean age of this, and 6 of them were male and 4 of them were female. Out of 10 patients, 3 patients showed vasculitis without luminal narrowing and 1 patient showed vasculitis with luminal narrowing, and rest 6 showed normal vessel wall study. In the current study, 3 patients out of 10 showed diffuse enhancement of wall of long segment of cervical petrous and cavernous segment of internal carotid artery without any luminal narrowing. One of the patients showed diffuse enhancement of long segment of cervical petrous, cavernous segment of right common carotid artery and internal carotid artery with complete luminal stenosis and segmental wall enhancement of M1 segment of right middle cerebral artery and inferior division within the right sylvian fissure with complete luminal stenosis. All the above findings were suggestive of inflammatory vasculitis. Rest 6 patients showed normal vessel wall study. This is a comparison between vessel wall imaging C-cube sequence and 3D top sequence where the vessel wall enhancement can be clearly depicted. Similar studies have been done in the literature, and our findings are consistent with the findings of the literature. Conclusion: intracranial vessel wall imaging has become a part of MR imaging protocol in detecting vasculitis. It also shows vessel wall changes in patients with Moya-Moya disease, aneurysm, dissection, and intracranial atherosclerosis. Field strength of at least 1.5 Tesla enables vessel wall imaging sequence with high CNR and spatial resolution to assess the thin intracranial atherosclerotic vessel wall and characterize vessel wall lesions. Radiologists should be aware of normal appearance of vessel wall, the main characteristics of the vessel wall lesion in different wall pathologic conditions, and the technical limitations in the assessment of intracranial vessel wall imaging. Thank you.
Good evening, everyone. The topic of my paper is Unraveling the Radiological Tapestry, a case series of non-vestibular schwannomas. Schwannomas are benign, slow-growing, encapsulated nerve sheath tumors composed of Schwann cells in a collagenous matrix. They can arise from any cranial, peripheral, or autonomic nerves in the body, making them quite versatile in location. Schwannomas constitute 8.5% of all intracranial tumors, with over 90% of them originating from the 8th cranial nerve itself. The vestibulocochlear nerve is followed by trigeminal, facial nerve in frequency, but the lower cranial nerves including glossopharyngeal, vagus, accessory and hypoglossal rarely play host to them. For the methodology, the source of my data was from KIMS Bhubaneswar and included clinical profile, CT and MR findings, which was followed by surgical management findings and histopathological correlation. The type of study is retrospective with a duration of 1 year, and 4 cases were taken as my sample size. The tools which included were NCCT head, which was done using 64 slice GE Optima CT660 with 1.25 mm slice thickness, and MRI was done using GE Signa HDXT 1.5 Tesla MRI and studied in different sequences. For the case 1, a 43-year-old male came with the complaints of facial pain over the right side since about 15 days, which was also associated with tingling sensation. On examination, there was pain and numbness over the right side of face, extending over the malar prominence. Here we can see axial T1, T2 and flare images. There was a well-defined T1 ISO, T2 flare heterogeneously hyperintense lesion, which was seen causing compression of the adjacent right hemipons and right medial temporal lobe. In the sagittal T2 and coronal T2 images, we can see the lesion compressing the right cavernous sinus, and in the DWI, the lesion did not show any restriction, and ADC, it was heterointense. Surgical treatment was done, and the biopsy findings were consistent with that of schwannoma with degenerative changes. So the final diagnosis of right trigeminal schwannoma was made. For the case 2, a 58-year-old female came with the chief complaints of left eye proptosis and loss of vision since 1.5 years. There was also associated right eye diminution vision since 2 months. On examination, cranial nerve 2 on the left side, the visual acuity was lost to perception to light, while on right it was 6/24. Cranial nerves 3, 4 and 6 on the left side were paralyzed, while the rest of the nerves were normal. So here in the NCCT, this is sagittal and coronal images. We see a well-defined extraaxial hypotense lesion with multiple septations in the left temporal lobe and also seen compressing the lobe. In the next sagittal and NCCT axial images, we can see the extension of this hypotense lesion into the left temporal lobe, causing the widening of optic canal and the notching over the left side of clivus, sella and sphenoid sinus. This is also post-op CT of the same patient. Similarly, surgical treatment was done and the biopsy schwannoma was found. Final diagnosis of left 6th cranial nerve or the abduction of schwannoma was made. For the third case, a 37-year-old male came with the complaints of decreased vision in the right eye for 6 months, left eye since 2 months and tingling sensation on the left side since 1 month. On examination, cranial nerve 2 showed decreased vision bilaterally, while cranial nerve 5 showed decreased sensation on the left side. Here we see the axial T1, T2 and swan images. We can see a well-defined T1 ISO to hypointense, T2 heterogeneously hyperintense lesion on the left CP angle, and also multiple centrally cystic areas can be seen. The swan imaging showed blooming within. These are the coronal contrast and axial CT images. Here we saw lesion showing heterogeneous enhancement with multiple non-enhancing areas and also seeing them extending into the Meckel's cave as can be seen in the axial image. Surgical treatment was done and the biopsy we found out ancient schwannoma, which is a very rare type of schwannoma, and final diagnosis of trigeminal schwannoma was made. For the fourth case, a 19-year-old male came with the complaints of left-sided hearing loss since 1 month and also decreased sensation on the left side of face since 20 days. On examination, cranial nerve, we found out pain and numbness on the left side of face. Here we can see axial T1, T2 and flare images where an ill-defined T1 ISO and T2 hyperintense lesion can be seen. On FISTA image, we can see left trigeminal nerve being involved. On the axial T1 contrast and coronal images, we can see lesion having a heterogeneous enhancement and also involving Meckel's cave. In the image B, we can see superior-inferior extension of the lesion. In the image C, we can see the encasement of the left internal carotid artery, while in the image D, we can see it involving the left parapharyngeal space. Similarly, surgical treatment was done and the biopsy finding showed features of schwannoma and the final diagnosis of trigeminal schwannoma was made. For the discussion and conclusion, among the cases examined, varied locations and sizes of tumors were observed, with 3 being trigeminal in origin and 1 involving the abducens nerve. In our study, one of the lesions was completely cystic, 2 were solid cystic and one was completely solid. Out of them, 2 were showing hemorrhage within. In all the cases, surgical excision was done and the diagnosis with histopathology was confirmed. In conclusion, non-vestibular schwannomas are far less common but curable benign lesions. Their characteristic anatomical location, extent and signal characteristics make the diagnosis almost certain. Thank you.
Good evening, everyone. The title of my presentation today is Spectrum of Imaging Findings in Congenital Encephaloceles, a Case Series. Background: Congenital encephalocele refers to extracranial extension of intracranial structures through a persistent opening in the calvaria and dura. This occurs due to a rare post-neurulation event that causes defective cranial mesoderm development. The occipital bone is the most common site for cephaloceles in Europe and North America, while the frontoethmoid region is most common in Southeastern Asia. Methodology. 4 patients with encephaloceles were prospectively identified at the Department of Radiodiagnosis in KIMS Bhubaneswar during a 9-month period. Imaging modalities including CT and MRI were employed to evaluate the size, content, location and status of the herniated neuroparenchyma. The patients underwent CT head on 64-slice GE Optima CT scanner and MRI brain on Cigna HTXT 1.5 Tesla MRI. One patient also underwent screening of the spine. So case 1 was a 7-month-old infant who presented with gradually increasing swelling over the nasal bridge since birth, which was non-compressible and irreducible. CT head was done in an outside facility. CE MRI brain was done in our department, in which we saw a clear-cut defect at the level of the foramen cecum in the sagittal T2 weighted images, which is also noted in the flare cube images here. On post-contrast images, we could see enhancement, and the appearance was of a soft tissue intensity lesion, which was seen very clearly in axial T1 and T2 weighted images. The soft tissue intensity was similar in appearance to the brain parenchyma. So this was the defect at the level of foramen cecum, and it was seen herniating behind the nasal bone and in front of the nasal septum, and from underneath the nasal bone up to the subcutaneous plane. So a diagnosis of nasoethmoidal syncypial type of anterior meningoencephalocele was made. The patient underwent bifrontal craniotomy with duroplasty and repair of anterior cranial fossa in encephalocele. Intraoperative findings showed the defect anterior to the cribriform plates with herniated dura and fibrous tissue. On histopathology, the cut section showed a homogeneously grey-white tissue, and microscopy confirmed the presence of skin, intervening collagen, brain tissue as well as proliferative capillaries. Case 2 was a 29-year-old female who came with left-sided blood-tinged rhinorrhea, left hemicranial headache, blurring of left-sided eye vision since 2 months, and history of irregular menstrual cycles, along with amenorrhea and increased serum prolactin levels. There was no past history of trauma. This was a sagittal CT image, bone window, showing a large osseous defect in the floor of the sella turcica with soft tissue density within the sphenoid sinus. The patient also went on to have an MRI. This was the sagittal T2 weighted image which showed herniation of the meninges and CSF into the sphenoid sinus. Anterior pituitary was not visualized in the pituitary fossa and suggested herniation into the sphenoid sinus. This was a coronal T2 weighted image which showed that optic chiasma was also seen to be pulled into the pituitary fossa. So based on these findings, the diagnosis of intersphenoidal basal type of meningoencephalocele was made, which was causing hyperprolactinemia due to stalk effect. The patient went on to have an endoscopic transnasal transsphenoidal closure of the defect, which was packed with fat and fascia and enforced with tissel glue. Intraoperatively, they found a large bony sphenoidal defect with pituitary descending through it. These were the post-op soft tissue and bone density windows, which showed some hyperdensity within the sella, which was suggestive of repositioned pituitary. Case 3 was a 72-year-old diabetic and hypertensive female who was admitted due to unrelated complaints of altered sensorium, dyselectrolytemia, unstable gait and lower limb weakness, but she also had a right-sided eye swelling since birth and decrease in vision. She had a CT scan in our department. These were the axial images, bone and soft tissue window, which showed a large defect in the greater wing of right sphenoid bone, that is superior orbital fissure, through which gliotic brain parenchyma was seen herniating through the orbit into the subcutaneous plane. This is the sagittal soft tissue window, which shows proptosis and downward displacement of the right globe, causing orbital expansion. And this is a coronal bone window, which shows right temporal bone scalloping, which is also noted in the axial bone window, suggesting chronicity. The patient underwent an MRI. These were the axial and sagittal T2 weighted images and axial and sagittal flare images, which showed herniation of gliotic and encephalomalacic right frontotemporal lobe into the right orbital canal, causing proptosis of the right globe. There was also ex-vasodilatation of the right lateral ventricle, along with mild herniation of the proximal part of the right lateral ventricle through the defect. Coronal T2 weighted images from anterior to posterior showed inferiorly displaced, thinned and hyperintense right optic nerve compared to the left side. So a diagnosis of spheno-orbital basal type of meningoencephalocystocele was made based on the above findings. Case 4 was a 5-month-old female who presented with gradually increasing fluctuant swelling over the nape of the neck since birth. These were the axial and sagittal bone window CT images, which showed a left-sided occipital bone defect with herniation of a portion of the cerebellum surrounded by CSF density fluid through it. There was also bilateral lateral ventricular and third ventricular dilatation. On MRI, these were the sagittal T2 cube image, which showed herniation of cerebellum through the defect, forming a large multi-septated cystic structure measuring almost 11 centimeters. The fourth ventricle was distorted with aqueductal stenosis causing hydrocephalus and atrophy of bilateral cerebral hemispheres, midbrain and pons. We also did a screening of the spine, which showed production or formation of syrinx from the level of C3 to D4 vertebral levels, and hence a diagnosis of Chiari 3 malformation with occipital meningoencephalocele was made. The patient also underwent excision and repair, and histopath was consistent with encephalocele. There are two broad categories of encephaloceles, which are posterior and anterior. Amongst posterior, occipital is the most common type, and amongst anterior, frontoethmoidal. We also encountered the rarer basal varieties in our department. To conclude, an adequate understanding of the imaging protocol, relevant anatomy and classification is required to provide a complete report in these cases. Demonstration of continuity of cephalocele with underlying leptomeninges and protrusion of brain tissue is critical for surgeons. CT is useful for identifying the osseous defect, while MRI with its anatomic and soft tissue resolution is superior to characterize the hernia sac, detect abnormal signal in dysplastic brain, evaluate the cartilaginous nasofrontal region and identify other associated malformations. Additionally, an MR or CT angio or venogram can provide more detailed evaluation of vascular anatomy and their relation to the cephalocele. Thank you.
ये क्या हो गया सर? नहीं हो रहा सर.
ఇప్పుడు కంట్రోల్ దిందు.
Good evening everyone. The topic of my presentation today is a prospective study of the utility of CT perfusion imaging in the differentiation of HCC from other hepatic neoplasms. So liver cancer is the third most common cause of cancer mortality worldwide and the sixth most frequent cause of cancer incidence. HCC and cholangiocarcinoma constitute most of these tumors. The CT perfusion imaging parameters act like non-invasive biomarkers, enabling the non-invasive evaluation of tumor characters. They also can monitor the tumor response to treatment like TACE, chemotherapy and immunotherapy over the entire 3D volume of the tumor. Although few similar studies are there in literature, there are yet to be standardized cutoff values for perfusion parameters. And there is a need for more extensive research on CT perfusion imaging. With this background, our study aimed to analyze the efficacy of various perfusion parameters like hepatic arterial perfusion, portal venous perfusion, hepatic perfusion index, blood flow, blood volume, time to peak and mean transit time in differentiating HCC from other hepatic neoplasms. So the primary objective of the study was to determine the efficacy of CT perfusion imaging in differentiating HCC from other hepatic neoplasms. The secondary objectives were to compare the perfusion characteristics of HCC in a cirrhotic liver with that of HCCs in non-cirrhotic liver. Also, the other objective was to compare the perfusion characteristics of HCC with individual tumor varieties like hypervascular metastasis, and intrahepatic cholangio. So this was a prospective hospital-based observational study, and the study period was from May 2021 to April 23, and patients with suspicious liver lesions on ultrasound or any other imaging were included in the study criteria, and a total of 48 cases were evaluated. So results: the mean age of the participants was 55 plus minus 12 years and the median age was 15 years. Male patients were more common in the study compared to the female patients, and out of the 48 cases, 28 cases were HCC, 13 were metastasis, 5 were cholangiocarcinoma and 1 was epithelioid hemangioendothelioma. The mean diameter of HCC lesions were about 8 plus minus 4.6 centimeter, and the non-HCC lesions mean diameter was 10 plus minus 3.5 centimeter. Right lobe lesions were more common in HCC, whereas multifocal lesions involving both lobes were common in the non-HCC group. On comparison of perfusion parameters, the parameters like HAP, HPI, BF and BV were higher in HCCs, and the parameters like PVP, MTT and TTP were lower in HCCs when compared to the non-HCC group. With cutoff values of 84.2 ml per 100 ml per minute and 88.3 ml per 100 ml, BF and BV were the most significant parameters in differentiating between the two groups. On comparison of parameters of HCC and hypervascular metastasis, parameters like HPI, BF and BV were higher and TTP was lower in HCC when compared to the hypervascular metastasis. So with cutoff values of 90.1% for HPI and 9.8 ml per 100 ml for blood volume, they had a maximum sensitivity and specificity. Also, in differentiating HCC from hypovascular metastasis, the parameters like HAP, HPI, BF, BV and TTP were significant, and the cutoff values were 55.67 ml per 100 ml per minute and 6.19 ml per 100 ml for BF and BV, which yielded the maximum sensitivity and specificity. the parameters like HAP, PVP, BF, BV and TTP were significant in differentiating HCC from IHCCs. So cutoff values were 80.8% for HPI and 68.74 ml per 100 ml for BF, and these were significant in differentiating them. Also, the perfusion parameters of epithelial hemangioendothelium was compared, and this was lower in compared to the HCCs. On comparison between the perfusion parameters of HCC in cirrhotics and non-cirrhotics, there was no significant difference. So this is one of the case showing a large heterogeneous mass in the left lobe of the liver, showing arterial hyperenhancement, and these are the perfusion, color-coded perfusion maps showing hyperperfusion in the tumor, and homogeneous hypoperfusion was seen in the portal venous pressure color-coded maps, and biopsy confirmed the diagnosis of HCC. This is another case showing a ill-defined predominantly peripherally enhancing lesion in the left lobe with focal areas of capsular retraction, and perfusion images mainly showed predominant peripheral hyperperfusion of the tumor with heterogeneous areas of hypoperfusion, and biopsy confirmed the diagnosis of IHCC with so by establishing cutoffs for various perfusion parameters, we successfully distinguished HCC from other hepatic lesions. So we also compared the perfusion parameters of hypovascular metastasis with cholangio, but no statistical significance was there. And on comparison of parameters with epithelial hemangioendothelioma, they had lower perfusion values, but no previous literature was there to compare these values for these parameters. No significant difference were there between the perfusion parameters of HCC in cirrhotics and non-cirrhotics, which was consistent with the study by Hatzidakis. So our study concluded there was a significant difference in the perfusion parameters of HCC and non-HCC with a p-value of less than 0.1. And HCC and hypervascular metastasis displayed distinct perfusion parameters which aided in the differential diagnosis. Our perfusion parameters were higher for HCC than hypervascular metastasis. This was contrast with the study by Hayano et al., where the higher blood flow values and blood volume values were there for hypervascular metastasis. This discrepancy could be due to various reasons like varied population, technical and algorithms were different in ours. We used the deconvolutional method, whereas the Hayano study used maximum slope method for analysis. So larger lesions were there in our study, which could be one of the reasons for higher perfusion in HCC. But the sensitivity and specificities were comparable with Hayano et al. And this was also comparable with the study by Sushima et al., where the perfusion was higher in HCC. HCC also showed higher perfusion than hypovascular metastasis, which was similar to previous established studies. And on comparing with hypervascular and hypovascular metastasis, the perfusion was identical between them. And our study was also comparable with Guyanan et al., where the blood flow and blood volume were higher in hypervascular metastasis. Our studies results were also comparable with Zhou et al., where the hypovascular nature of IHCC when compared to HCC was found. So on conclusion, CT perfusion imaging, in addition to conventional imaging, provided a quantitative non-invasive method to differentiate HCC from other hepatic neoplasms. It can be a problem-solving tool when a conventional CT scan cannot characterize a lesion, especially in cases of multifocal lesions in cirrhotics with ascites, or when an invasive biopsy is contraindicated. But since a smaller sample size was used, a larger multicentric study with larger sample size is needed to further validate these results. Thank you.
Halo, udah juga?
Wishing everyone a wonderful morning. Today I welcome you to the second day of the 49th Annual State Conference of Oria. Our first speaker of today's event is Dr. Nafisa Sakir Batta ma'am. Ma'am, I welcome you to the stage. She has been a national faculty in USG shoulder joint and USG guided joint procedures since 2015. Today is her second day, and let's welcome ma'am to the stage. She will speak on the topic knee trauma, intermediate to advanced case-based MRI learning. Welcome, ma'am.
So some of you may want to get on this side of the room because you might lose some information in this part of the screen. So in case you all are interested, students or anyone who wants to just get on this, because I'm using a lot of real estate on the screen. So I tend to go all over the place. So today's talk is going to be about MRI knee, and I'm sure that all of you have reported MRI knee, right? It's a very staple, it's the bread and butter of MRI, right? So I have a few people to thank because they helped me in this presentation. And I want you to know what not to expect in this talk, okay? We are not going to talk about routine stuff. I'm not going to be talking about mundane knee injuries. I'm not going to be explaining to you cruciate ligament and meniscal tears because I'm understanding that all of you would know that working in a radiology department. So we are not going to have lots of slides with text and classification because all this the surgeons don't need. They don't care if we say 2A or 2B. What you need to expect from this talk is the tips and tricks of reporting MRI knee, how to get it right, okay? How to impress your surgeon, how to report clinically valid and clinically significant findings in the MR knee, okay? So knee trauma, all of you know, those of you who do night duties, I'm sure you're not happy about it, but still you have a knee trauma case. What happens is you get an X-ray done, right? AP lateral cross table, right? You look at fat planes and everything, and you look for suprapatellar effusions, the prefemoral fat plane, the tendon intactness, the Hoffa's plane, you look for fractures, etc. Today we're going to look for things that are routinely missed, okay? So fractures, the bigger and bolder fractures, all of you will see, it's a no-brainer. We're going to talk about these lesions. So this is the kind of patellar fracture you come up with. Even if you're sleeping, you will report it. But what about something like this? You have to get your eye sensitive. So if you see suprapatellar effusion and you see a small lucency, you're thinking, okay, bipartite maybe, but that's usually supralateral. So this is a fracture. Some of these fractures are missed in the setting of emergency radiology, and they come back for an MRI a few days later because the patient has persistent pain. So these are the kind of fractures that you will see on MR, and when you see the X-rays, you can in retrospect look for it, but at that time they were missed. So this is a patient who had a trauma 3 months ago. He got an X-ray which was reported as normal, and then he comes for an MR and you see that there was a fracture. Thankfully, the fracture was not a displaced one, and because of that fracture and this patient continued to walk, he has developed a lot of tendinopathy of the infrapatellar tendon, right? This patient also had a parameniscal cyst and a complex tear of the lateral meniscus, all right? Now, if you see a fracture case, first of all, you have to see it. Only then you can classify it. Surgeons don't care about classification. Surgeons want to know, have you seen the fracture? Can you tell me what it is? The rest of it they can do. They can get a CT done and they can further classify the injury. When you look at knee joint injuries with unseeming sort of trauma, you can still pick up fractures like the arcuate sign, right? This is the fibular avulsion of the lateral collateral ligament. You can look for a Segond fracture, which is the tibial avulsion of the anterolateral ligament. You can look for a reverse Segond fracture, and this is also something we see often, which is basically the meniscotibial component of the deep MCL, also called the coronary ligament. So when that avulses, and especially in children, it avulses with the bone. Now, osteochondral injuries, when you see an osteochondral injury, the first thing we do is, again, we classify, okay? But remember that osteochondral injuries are common around the knee, and only chondral injuries are far more common. So let's not look at this classification. Look at these chondral injuries. Do you pick them up routinely? Do you mention them in your reports? This is a delamination. If you see, the superficial cartilage is intact, but there was a shearing force which separated the subchondral bone plate from the bone. And that is why at the tide mark zone of the cartilage, you have that fluid cleft. This is a grave injury. These usually do not heal. So if you see something like this is important. So you look for intrachondral delaminations. Then you look for chondral blistering. This was a patient who had a direct impact. Okay, so you can see that there are fluid pockets inside the cartilage with a superficial intact rim, and there is some hemosiderin deposition here, which is why it is looking dark. These should be reported. Chondral blistering is a type 4 sort of a chondral injury. Then of course you can have a fissure, and then you can have a delamination along the tide mark zone. This is also important. Why? Because this area is loose. It's a chondral flap. It will keep rubbing against the trochlear cartilage, and this patient will land up with patellofemoral arthritis. So in a case like this, in an MR, you will see that there is a chondral delamination. The moment you see a delamination, you should be alert. Now you see that this has become a fissure here. So this was a flap. You want to tell the surgeon, look, there is a flap. Why you want to tell him? Because when he goes in to do a repair, he can also do a repair of that flap. This is a patient who had an ACL injury. Okay, the ACL is torn. That I think all of you know how to identify. But importantly, look here. There is a piece of cartilage floating in the suprapatellar fossa. Are you seeing these in your routine scans? You will see them. They are there. And this is exactly the same intensity as cartilage everywhere else. Okay? These are my 1.5 Tesla images, and any of you who's using a 1.5 Tesla, it's enough to pick these pathologies. You don't need a fancy MR machine. This cartilage came off from the non-weight bearing posterior tibial lateral condyle cartilage. This is where the impaction occurs in a translational injury, because this will translate here, and this part of the cartilage is floating there. That cartilage may get absorbed completely, or it may ossify. Either ways, you are supposed to tell the surgeon that that small piece of cartilage is lying there. This is a patient who had a meniscal tear with a flip of the meniscus in the same position, and you can see that there is a partial chondral avulsion. While you may report the meniscal tear and the ACL tear accurately, are you reporting this? The reason is the surgeon needs to go in, just do a micro puncture there, multiple punctures, and this area will heal with fibrocartilage formation. But for that, you have to be sensitive in your reporting. This is important because these are young people, they are children. You want to tell the surgeon that this is important. 15-year-old patient with locking. This was an X-ray done for this patient. He plays football, and somebody said that there is calcification in the suprapatellar bursa. An MR was done for this patient. In the MR, you see this massive osteo and chondral loose body. So there's osseous component and chondral component. So this is a large osseous loose body. This is going to grind down the cartilage in a 15-year-old boy. So we can't be missing these things, not in today's age, okay? Now, where did this come from? Such a big cartilage. And the thing is, this is also bone. But why didn't we see such a big piece of bone on the X-ray? Because in a younger individual, this can demineralize. And they can demineralize completely, and the bone cannot be seen on the X-ray. Or it might leave a small sliver of bone on the X-ray. This has flown off from the medial femoral condyle. This was seen on the X-ray, but it was not reported. So you see this here, and you see this large gap here. Be sensitive to this. It's not so prominent on X-ray, but start looking at this in a young individual who has come with trauma. If you see this sort of a thing, this is a medial condylar osteochondral injury. This is the most common place to find an osteochondral injury, on the femoral condyles in a child. Another place where you can find osteochondral injuries, and very commonly, would be in a patellofemoral dislocation. So we all know that these dislocations occur either because there is an inherent patellofemoral instability, or because of the morphology of the trochlea or patella, or because the force of trauma was that massive. But in these cases, What is the important thing to look for? Now you see this female footballer, she's a 22-year-old. She's come with a patellofemoral contusion. You know that there has been a patellofemoral dislocation. That's fine. And you would like to see the MPFL and see if it's torn, not torn, attenuated, etc. But what is the important thing to look for? A lot of you may start to make congruence angles. Dijou type A trochlear dysplasia, Weiberg-C patella, Caton-Deschamps ratios, and Insel-Salvati ratios, congruous angles. But remember that in the setting of patellofemoral trauma, if you feel that there has been an injury because of which you can have an osteochondral flap, a fragment somewhere, start to look for it. Most likely, it is in the posterolateral recess. Okay? Again, because there is an acute injury, you're always looking at PDFS. You may not find the bone looking dark. Why? Because it's edematous. So you want to look for these small fragments. If they're very small, it's okay. But if it's this large, like in this case, it can go into a joint, and every time the patient goes back to play, it will grind down the cartilage. So you want to tell the surgeon, when he goes to do an MPFL repair, or when he does a tibial tuberosity transfer, or an MPFL reconstruction with a gracilis graft, he is not going to go all the way back to remove this body, unless the radiologist has told him that. Right? So you want to be able to be sensitive to looking at fragments in a case of patellofemoral dislocation. And a lot of times we park our attention on MPFL and MCL injuries, but let me tell you, even if you miss it, it's okay. This is my friend, avid badminton player, complete rupture of the MPR, medial patellar retinaculum, MPFL, MPTL, right? Complete rupture. And look at him after 3 months. So he was put on a brace. He has a mild trochlear dysplasia and otherwise it's okay. He didn't have any fragment anywhere. So he was put on a brace. The MPFL is still sort of stripped. But you look at the MCL, it's scarred, it's thickened, but it's now becoming intact. MPFL at the knee and ATFL ligament, which I showed you at the ankle, these two tend to scar beautifully, even if they are ruptured. Like if one is lying on this side of the Indian Ocean and the other is this side, it is still going to heal in a lot of people. If you miss an MCL tear, trust me, you're not missing anything. But if you miss that osteochondral fragment, you might cause trouble to the patient, which would be of lifetime significance. Okay, so remember that these kind of injuries can heal. Then, of course, the setting of translational injuries. So, anterior translation, posterior translation, you are expecting an ACL injury, a PCL injury. But what are you not looking at? We are not looking at the arteries. We are just not. Even after 3 months of a patient having an ACL injury, he has popliteal thrombosis that nobody is looking at. The knee and the foot are slightly swollen, which is okay. Everybody is attributing it to the ACL tear. MR has been reported. Nobody has looked at the popliteal artery. Nobody has looked at the popliteal vein. In younger patients, they do very well. Even if the popliteal artery is thrombosed, they have collaterals. They'll just have some swelling. So are we looking at this enough? I think we all need to be sensitive about looking at the popliteal artery and vein, and also looking at the anterior tibial artery and vein, because this is very close to the bone. Usually the trauma occurs at this level, okay? So usually it is popliteal artery injury that is important. But if the branching has occurred superiorly, if this branch of the ATA is superior, then expect to see an ATA thrombosis or an ATV thrombosis. Okay, so if you see in this patient, there was definitely in this patient there was popliteal artery thrombosis, this popliteal vein thrombosis. We must pick these up. In fact, first thing is one should look for the pulses in the acute setting of trauma, and later on collaterals can form. But in the acute setting, if the pulses are absent, the patient is going to go in for a CT angiography, right? But in a chronic trauma, when the patient comes to you after, say, 10 days of injury, everybody has missed everything else, collaterals have formed, patient just has swelling, he's a young patient, and the distal pulses are okay, and there's a popliteal artery thrombosis, okay? So please, when you look at a case of ACL or PCL injury, first look at the popliteal artery and vein, okay? Then of course tendon ruptures, all right? You can describe them partial, full thickness. You can describe if at the footprint the tendon is torn at the medial or central or lateral footprint, etc., etc. All right? So these are more simple. This is a high grade partial tear of the infrapatellar tendon. That's fine. This patient also had an isolated bundle tear of the PL bundle. This is the AM bundle of the ACL and this is the PL bundle of the ACL. So you can have isolated bundle tears as well. Here's a patient who had a complete quadriceps tendon tear and it's from the footprint. And you want to tell the surgeon that the bone is not avulsed, the bone is of good quality so that the surgeon can go back and reposit the quadriceps tendon. In fact, in this child, it was unfortunate because he fell on both flexed knees and he actually tore both the quadriceps tendons, right? These are more gross injuries and you'll see it. Then comes the Osgood-Schlatter disease. This is also pretty common. You've seen these. You want to look for rupture. You want to look at fluid pockets. So there could be a tendinous rupture or an osteotendinous rupture. There might be some Hoffer's effusion. There may be Hoffitis. And usually these patella are high positioned. So can we keep the slide? Thank you. So these patella are high positioned. Sometimes they can be, in chronic cases, there can be scarring which will pull the patella down. Okay, so you can have a patella baja or you can have a patella alta. But don't mistake Osgood-Schlatter disease for the more grievous kind of tibial tuberosity avulsions. That's a different animal altogether. This is a tibial tuberosity avulsion in a case of trauma. This patient, the tibial tuberosity has completely avulsed and there is a subperiosteal hematoma. And that injury has gone through the physis, the growth plate. So there's a Salter-Harris injury. These injuries need to be treated separately. These injuries need to be reported separately. So the history will be different. This guy has come with an accidental injury, right? He's come with a motor vehicle injury, hyperflexion injury. Whereas that child would have come with a history of playing basketball for 6 months. He has pain at the tibial tuberosity for many months. So the history is different, but this is the more sinister kind of a, do not give this as an Osgood-Schlatter disease, okay? These are the, you can go and see the Ogden-Matson classification. If you want to use the classification, that's fine, but you need to tell the surgeon that, look, this is a grave tibial tuberosity avulsion injury, which will have bearing on the patient's growth, okay? Morale-Lavely lesions, all of you have seen, these look like bursitis. But they're not bursal, they are adventitial bursas because of a degloving injuries. A new bursa is formed, which is basically serosanguinous material, may or may not show blood products. So you will see a dark rim around these because of that hemosidrin. So this is a Morale-Lavely lesion, and usually the patient will give you a history that there was a rubbing sort of a degloving injury at that part of the knee. And this occurs usually at bony prominences because there's a bone here and the skin degloves. So there's a shearing between the bone and the subcutaneous fat, and that's how this comes along. Then of course the quintessential cruciate ligament injuries, okay? So look at the posterolateral impingement or the impaction at the posterolateral tibia. Look at the sulcus terminalis deepening. So this is where the translation has occurred. You will see Segond fractures, which is basically tibial avulsion of the anterolateral ligament or the ALL. And in most cases of ACL, you should be able to see both the bundles. So ACL is more or less a wide ligament. It has a synovial scaffolding in it. So you can see heterogeneous fibrofatty material between the ligament fibers, just like you could see in the tibiotalar deep ligament of the deltoid in the ankle. And you could identify both the bundles separately. Some amount of high signal at the tibial footprint is normal. It is not abnormal. So you can go about saying there's a translation, MR drawer sign positive, sulcus terminalis deep notch sign positive. Remember that ACLs will either tear at mid-course or they will tear at distal femoral course in an adult. If they tear at the tibial margin, then there is a piece of bone with it. Usually they are ACL bony avulsions from the tibial margin. It's not soft tissue. If you can't see the bone, look for it. Blemmensan's line, inversion of the Blemmensan's angle, laying down sign, all of these just are signs, they are fun. One of the signs, octopus sign, which is described, where the ACL tears and some of the ACL is posterior and some of it gets moving anteriorly. This sign is important is because the surgeon will say the Latchman test is not positive, or he is doing a draw test and there's a firm endpoint. And he'll say, see, review the scan again. I don't think the ACL is completely torn. You tell him the octopus sign is positive. There is pseudo entrapment of the ACL when you do a Lachman or an anterior translation test, and that is why you are finding a firm endpoint. And sir, that is why your Lachman test isn't positive, but this is a full thickness ACL tear. In fact, it's a surefire full thickness ACL tear. Okay. So empty gap, so gap sign, empty notch sign, all these are signs described. Buckling of the PCL. I don't write any signs in my report. I just write what is important. So it's important to remember that old ACL tears can show this kind of scarring, okay? And the scarring can afford some stability to the knee. So this is what that will look like. Sometimes the ACL can disappear. So you might see open a knee joint and there is no ACL. There's no fiber only of the ACL. There's a fat. That means that it has torn chronically and that's okay. Here in this case you can see some ACL, and this ACL is perfectly parallel to the Blemmensan's line. But there is some scarring. So you might say it is scarred but intact and irregular. The surgeon will go in and say, he says the Latchman test is freely positive and there's a grade 3 pivot. That's okay. You cannot talk about laxity of the ligament on a static MR, and that is something you need to tell your surgeon. Sometimes these ganglion cysts are interpreted as ACL strain, and a lot of times you use this term ACL strain. Don't use it. It's not a term. There's nothing like ACL strain. It's either torn or not. And if it's torn, you write if it's high grade partial or low grade partial. These can be diffuse kind of ganglion cysts, which will look like the celery stalk appearance, and this is a diffuse ACL ganglion. This can cause laxity of the ACL. The surgeon will say there's a loose joint. The patient will say, when I go down the stairs, I feel the knee will give way. And this is the only thing the patient tell you. When they're going down the stairs, they feel the knee is going to give way. That is an unstable knee, okay? As I said, if the ACL tears from the tibial attachment, it is an ACL bony avulsion. If you don't see the fragments because they are too small, so be it. But you still have to remember that it is a ACL bony avulsion. Sometimes the fragments are so large that it can entrap the root of the meniscus. Those kind of fragments should be mentioned. So in this case, you see that there is an ACL avulsion and there's slight distraction. So this surgeon can easily go in and repair that. Then we come to the PCL injuries. Okay, so this is posterior translation. This is what happens in a PCL injury. That's fine. Remember that any cruciate ligament injuries, you're going to first look at the popliteal artery and vein. Okay, and in the PCL also, there are two bundles. There is an AL bundle, anterolateral, and there is a PM bundle, which is posteromedial. You may not see these bundles separately. Sometimes you can if there is mucoid degeneration or edema in the PCL. And remember that PCL is very dark. It's not bright like the ACL is, because ACL has that synovial scaffolding. It has that fibrofatty tissue. PCL does not have that fibrofatty tissue, so it's nice and dark. If you see an intermediate looking ACL, it's normal. If you look at an intermediate signal in the PCL, it's abnormal. Okay? So one thing to remember is these are not loose bodies. Sometimes you can have a very hypertrophic kind of a meniscofemoral ligament of Humphrey or Risberg. And remember that these are not loose bodies and these are the meniscofemoral ligaments. So here is a patient in which the PCL has torn. Again, PCL tears also either occur at mid-course or they occur at the femoral margin. If they occur at the tibial margin, then there is a bony avulsion. Okay, the rule is the same. In this patient, there is a thickened meniscofemoral ligament of Humphrey, and if you look at the PCL, the ghost of the PCL almost here is there, but this is definitely abnormal, so we'll give this as a tear. In the same patient, you'll see that the ghost of the PCL is preserved. And you may be tempted to think it's a partial tear, but this is a full tear. Because in PCL, nothing but a perfectly dark signal is acceptable. Okay. In the ACL, if you had seen the signal, you can give it as a partial tear. This turned out to be a full thickness tear. So here's that PCL. Now you see a PCL like this. It's quite buckled, it's quite horizontal, and it's gone from the tibial end. So there is a bony avulsion. There has to be a bony avulsion. If you can't see it, that's fine, because this fragment may be edematous. Along with that, you may see a posterolateral tibial injury, and very often PCL injuries are associated with either a posterolateral corner injury or a posteromedial corner injury. So here there's a proximal MCL tear in this patient, and also there is a degenerative tear of the medial meniscus. Now you look at this PCL. That was the PCL. The bone fragments are very, very small. They are distracted from here, but this is a bony avulsion. Do not give this as a full thickness tibial sided PCL tear. It's a PCL avulsion injury. This is a patient who had a bike injury. Again, the PCL looks intact, but it's not dark. It should be this dark. It's not dark. This is a full thickness PCL tear. This was given as a normal PCL. Why? Because PCL is a rope. These two bundles are roped together. Even if they tear, they stay there. So the ghost of the PCL is there. So this is ghosting, and this was actually a full thickness PCL tear. Even if you don't write it as a full thickness tear, write it as a high grade partial PCL tear. So this was that torn PCL. And sometimes you can see PCL and ACLs very well on the coronal images. So rely on that more than the sagittal. Because the way the technician has oriented the sagittal images, sometimes that can look very iffy. So this is another patient. And this is something that you will see in your lifetime often. This is the PCL. That's the ACL. And you see the PCL. And then you see the PCL. This was reported as normal. And this was a full thickness PCL tear. Why? Because chronic PCL tears usually scar. They look the same as the PCL. The ghost of the PCL helps the PCL to stay exactly where it is. The surgeon is seeing a completely posterior translating knee. We have reported as normal. It's very, very, very common. Look at this PCL. It's too thin here. It's very thin. There's some attenuation here. And then you see a normal PCL. This PCL was torn. And in such a case, it might be difficult, even when you go back to the MR, to say that I don't think I could have confidently written a full thickness PCL tear even on day one. That's okay. When this happens is when you should always look at the prescription. If the patient comes with a prescription saying posterior draw test positive and your PCL is normal, start looking at the T1 or T2 or Q images which are not fat suppressed to look at scarring in the intercondylar notch. And we do this simple test. It's a posterior stress test. Okay, this is a kneeling down stress test. So we hold the patient with one knee here, and he has a handle bar to grab, and he flexes one knee at the edge of the table, and he puts his weight on it. Okay, we draw a line from the posterior tibia. Okay, this line should be at least. We need some batteries. So this line should be at least 5 centimeters into the tibia, and you shoot that line across. Wherever the line meets the intercondylar notch of the femur, from top of it you measure the sag. All right. If there is a difference between the two knees of 3 to 4 mm, it's okay. If it's more than 4 mm, the PCL is torn. If it's more than 8 mm, there is also a posterolateral corner injury. So PCL and PLC injury. This is a simple X-ray. You can do it in your department and you will get the answer. Okay, so this is a kneeling down view. You can check it out on the internet. It's a simple X-ray. More than 4 mm, definitely it's a PCL tear. More than 8 mm, it's a PCL and a PLC tear. Even PCL injuries, if they occur at the bony footprint, at the tibial footprint, then there is a bone involved. Okay, so like in this case was reported initially as a bony contusion, but this is a PCL tear. Okay, so look at it And it's good because if this is such a large bone piece, then the surgeon can easily put a cancellous screw through it. So nowadays the cancellous screws they use or the suture anchors they use can be about 8 mm, and that's all they need. The thinner suture anchors through which they just do a pull through to the anterior tibia, that may be only 4 mm. So if you can identify the bone fragment, you measure it and you give it to him. If you're not sure of the bone fragment or there's comminution, you say ask for a CT and measure that bone fragment. So here's another patient with a similar PCL injury, but this is more distracted. Now let's go to meniscal tears. All of you who are reporting grades in your impression, stop doing it today. It makes no difference. How does a surgeon care if it's grade 1 or grade 2 meniscus? He wants to know whether he wants to do an arthroscopy. Okay? So, and the mistake that you can do here is to write a grade 2 tear. First of all, these are just signals. They are not tears. Grade 1 is a signal, grade 2 is a signal, grade 3 is a signal. They are all signals. They are not tears. When a tear, can we have that pointer? Just give me a battery. So if you have a tear which extends to the capsular surface like this 2A, it's not going to the free edge of the meniscus. लगाओ इसमें AC होगा. You need a type C adapter. But this presentation doesn't say. Okay. So if you have something that goes to the free edge of the meniscus, inside, it's a tear. If you have a signal that goes to the superior articular margin of the meniscus or the inferior articular margin of the meniscus, it's a tear. Anything that goes only to the capsule is not a tear. Anything that is a signal inside the meniscus is not a tear. So if you want to describe this as a grade 2 signal only, not a tear. If you want to write grade 2 signal, write it in the body of your report and please don't write it in the impression. First of all, never write grade 2 and then tear with it. That does not make sense. Second thing, don't write it only. So what I do is I write some signal is there in the body of the report, and in the impression I write what kind of a tear is present in the meniscus. If there is, otherwise I don't write it at all. Menisci, you know that the collagen fibers are in the C-shaped structure. Okay, so tears usually try to occur in that direction. When there is axial loading on the meniscus, the tear will be vertical, right? When there is shearing force, the tear will be radial. Now, if you will look at these roots, see that the lateral meniscus, anterior and posterior roots are very central, and the medial meniscal roots are a little more outside, isn't it? But either ways, these roots are very important. If one of these roots is avulsed, okay, when there is axial loading or bone on bone, the meniscus will just come out. Even if it's completely intact, even if the rest of the meniscus is healthy, if that root attachment is avulsed, the whole meniscus, because of the hoop stress, will just come out. Bone on bone disease will start and you will start to have cartilage damage. I attended a lecture by Donald Resnick in Calcutta. I think it was in 2017. He said, if there is only one sequence I can do in an MRI knee, I will do a coronal PDFS. If there's only one image that can be provided to me in an MRI knee, I will see the last image where I can see the meniscal root. He says everything else in the knee joint, I'm okay to miss. But if I miss a root tear, the patient will have arthritis in 6 months. Grade 4 changes in 6 months. That's it. So never in your life should you miss a root tear. If you want to take anything away from this talk, take this. Don't miss a root tear. So you know how these tears are arranged. You can have a long axis tear with the length of the meniscus. You can have a horizontal tear going in the middle of the meniscus. You can just have a horizontal flap. You can have radial tears that are perpendicular to the meniscal axis, or you can have radial which starts to become vertical, which is a parrot beak tear. Okay. Radial tears are the worst ones to have because you can't repair them. Okay, they will just keep on splitting the meniscus. So you have to cut that part of the meniscus completely. Parrot beak tears are even worse because they can be there and every time the patient flexes and extends, it can grind some cartilage with it. If you see in this image on the left hand side, if the longitudinal tear is quite large, the long axis tear, it can flip internally. And so you have a bucket handle flip tear. And these kind of horizontal cleavage tears which occur in the substance of the meniscus between these bundles is because there is mucoid degeneration within the meniscus, and then the horizontal tear occurs. When these horizontal tear occurs, these can open out into the free edge and they can be associations with parameniscal cysts. Okay? So this is what a horizontal tear would look like. First it will look like a grade 2 signal in the meniscus, and then after that it's going to open out into the inner free edge of the meniscus, and that is when you will report it as a tear. Long axis tears, we've seen that large long axis tears can start to flip. Remember that the meniscus, can you get that pointer please? So remember that when we look at long axis tears, it's important to tell the surgeon where it has occurred. Why? Because the periphery of the meniscus is a red zone. Red zone is where there is enough vascularity. So if the bucket handle tear has occurred and it is in the periphery of the meniscus, that's a great place to be, because all the surgeon has to do is he's got to reposit it back, suture it, and it will heal. Right, so these are long axis tears, and again you want to tell the surgeon, is it in the periphery, is it in the middle, or is it in the inner side? The inner thirds don't heal. Even if you tie them up, they don't heal and they cause patient pain. So what they do is they will do a saucering of the meniscus there. But the mid ones may heal and the peripheral ones can heal completely. One thing to remember is when you are reporting long axis tears of the lateral meniscus, you can have a pseudo tear, which is the takeoff of the meniscofemoral ligament. So don't write that. Every time you see a vertical tear of the lateral meniscus, first look at the sulcus. Is it there? In spite of this also, do you have another vertical tear? Only then write a vertical tear of the lateral meniscus. So these are all the signs described, but that's okay. Look at this. Is this an oblique tear or a vertical tear? No. In the lateral meniscus, there's always going to be this signal, okay? And the root is okay. There is a double PCL sign. Here's the PCL, double PCL. ACL is torn, and we see this meniscal material in the center, and anteriorly it is flipped, and you see that this is a bucket handle meniscus tear. In this bucket handle meniscus tear, you want to tell the surgeon that what is left behind is a very small part of the meniscus, which is good because the tear has occurred from the peripheral thirds. So he's going to go inside and he is going to repair it. In fact, if the patient has an ACL tear and a bucket handle medial meniscus tear, he will go in early. If the patient only has an ACL tear, he can do the repair after 6 months. But if the patient has a medial meniscus tear, he wants to go in a little early so that he can preserve the meniscus. And today, all arthroscopic surgeons talk about preserving the meniscus. Save the meniscus, that is the logo. So you can check that out, save the meniscus logo. Radial tears, as I said, they're the most nasty ones to have because they don't repair. If you see a partial radial tear, but if you see a parameniscal cyst right there on the outside, that means this radial tear is not just partial. It's gone all the way through. Only then you will have a parameniscal tear, right? So if you are in this setting where you cannot see the entire radial tear, which is okay, remember that it's important to see if there's a parameniscal tear, then this radial tear is complete. So you want to say that to the surgeon. Here, in this case, there's a small radial tear. I can't see it all the way through, but I can see a parameniscal cyst, which means that it has transected the entire width of the meniscus. And sometimes radial tears can be very small to look at, and you should be sensitive towards them. Parrot beak tears, so there's a parrot beak and a flap. Okay, this is just like a parrot beak. Here you will see some, again, truncation of the meniscus, and you may even see that flap. So just remember that anything is occurring in the inner free edge of the meniscus. It's either going to be a radial tear or it's going to be a parrot beak tear. Complex tears, I think it's all over the place, so all you have to do is just write it's a complex tear. And sometimes the complex tears are such that the entire meniscal tissue can flip posteriorly. So you can have intra-articular flips of meniscal tissue, and you can also have extra-articular flips of meniscal tissue, all right? Again, as I said, root tears are extremely important. So here you see the meniscus. You go here, and it's absent. This is the meniscal ghost sign. So there is no root here of the medial meniscus, and there is an ACL tear. The meniscus is extruded, and that root here has been severed. When the root is severed and when there is axial loading, this meniscus will start coming out. The moment it comes out, you're going to have arthritic changes. So the one thing you don't want to miss is a root tear. Also, in this hockey player, for example, you have a meniscal tear. You can see that. And this tear is actually bunched up on the meniscus. And the meniscal tissue, instead of going intra-articularly, has gone extra-articular. It's gone in the meniscofemoral recess. Very important to report this. This is the comma sign. This is the apostrophe sign. Why is this important? Surgeon will go in through the anteromedial portal. He will see the meniscus, he will bring it out, he will see what kind of a tear is it, he'll repair it or he'll saucerize it. Some tissue in the meniscal recess is still there. He has not brought it all out. So, when the patient goes back and starts playing, that tissue in that meniscofemoral recess is going to come inside and act like a loose body. This is very important to write extra-articular meniscal displacements. So this is that patient. This is the apostrophe sign. Here's a basketball player, and now you are seeing an inferior meniscotibial recess, extrusion of the meniscus. Again important, the surgeon will go and clean up this meniscus, and this will stay here. Okay, so this is the comma sign. You must write that there's some flip of meniscal tissue in the meniscotibial recess, and this can occur if there's a meniscotibial tear. And this patient, even though he has a parameniscal cyst and an ACL and a complex tear and everything, that's okay. But what is most important to write is that there is some flip of tissue inferiorly, which the surgeon should go look for, bring it inside and clean it up. So these are the small things that you must report meaningfully to the surgeon when you are reporting an MRI knee. Just writing that there's a meniscal tear is not enough. So this is a footballer who got tackled, and you'll see that I'm just going to run through this tag and try and make out what kind of tear this is. Lateral meniscus, they are impaction injuries. Extra meniscal tissue anteriorly, breaching of meniscal tissue posteriorly. So in this case, there is a flip tear of both the menisci. So long axis tears of the medial meniscus, long axis tears of the lateral meniscus, and the tissue has flipped antero-internally. But there's also a root tear. That root tear is important. So if you look at this here, lateral meniscus, root not well visualized. Then you have a double PCL sign, you have the PCL, you have the torn ACL, root of the medial meniscus not visualized. So this is एक battery ले आओ ना कहीं से. So this is actually bilateral bucket handle. So when you say bilateral, I mean medial and lateral sided bucket handle tears. And these are associated with root tears. Remember that the impact of trauma is such that the posterior roots of the lateral and medial meniscus can get avulsed. If the lateral meniscus root gets avulsed, it's okay, because it's not the weight-bearing part of the knee joint. But if the medial meniscus root gets avulsed, then that is the weight-bearing portion of the joint. Root tears are not repaired and sutured like normal tears are. Root tears have to be sutured and they have to be pulled through to the anterior tibia. So the root repairs are different. That is why you must tell the surgeon that there's also a root tear. That takes them another half an hour, because they have to drill a tunnel through the tibia. So this is called the quadruple sign. Also be mindful for menisco, at the lateral meniscus, be mindful at these meniscopopliteal ligaments. They can also be torn. So there's a lateral meniscus which looks normal and the meniscopopliteal ligament has torn. And so this patient starts to have an unstable lateral meniscus. Okay, and this patient had a hypermobile lateral meniscus. So hypermobile lateral meniscus is a condition where the patient will say, I can feel that the meniscus is moving out, I can hear a sound, and he doesn't have a discoid meniscus. That happens in discoid meniscus. If he has this condition, then he probably had an old injury to the meniscopopliteal fasciculi. Similarly, you can have these kind of meniscocapsular injuries on the medial side also, something which we call the ramp lesion. Okay, so you can have these meniscofemoral and meniscotibial tiny ligaments at the posteromedial capsule, which otherwise should be sitting snug with the meniscus, and you will see this lamellated sort of appearance which you can see there, and you will also see that there is a semimembranosus tendon tear right there. So this is a telltale sign to tell you that this is a ramp tear. Ramp tears also cause instability at the posteromedial capsule. And if that ramp tear is not repaired, the surgeon goes to repair the ACL, eventually the patient will still have instability and that ACL will fail. So one of the causes for bad surgical outcomes after an ACL or a PCL reconstruction is a missed ramp tear. This is gaining a lot of importance everywhere else, so we should be reporting these. So you'll see a patient with a impaction injury, there's an ACL tear, and then you look at this posteromedial capsule, which is quite thickened, and that thickness is not normal. So there's a ramp tear. And look at the semimembranosus tendon that is attaching to the tibia behind, that oblique tendon. There'll be some edema in it. So these are not diagnosed. Again, if the surgeon goes through the anteromedial portal to repair the ACL, this is a arthroscopic blind spot. He will not see that behind the meniscus there is a capsular rupture. So unless you tell them, they will not be able to go in that area and they will not be able to repair the ramp. So this is what that looks like. Semimembranosus tendon tear, ramp lesion, and there is a meniscal contusion in this case. So you can see the signal inside the meniscus. Now, ramp tears can be classified. If you want to classify them, yes, but up to tear type 3 is stable and after type 3 is unstable. So just be careful not to miss a type 3 and onwards kind of a tear. So these are, you can read this up. This is what a ramp tear would look in the arthroscopy. Behind the perfectly normal meniscus, there will be a big rent in that ramp, okay? So type 1 is when there is, so this is the normal anatomy. Type 1 is when there is only a meniscofemoral ligament tear. This is stable. Type 2 is when the actually meniscus is avulsed from the tissue. So you'll see a small sliver tear of the supero-posterior meniscus as well. Type 3A is when you see a posterior-inferior avulsion of the meniscus because of the meniscotibial ligament avulsion. Type 3B is a pure ligamentous avulsion with a normal meniscus, but you will see some buckling at that posterior-inferior corner, so be sensitive towards it. Type 4A is when there is a complete meniscal disjunction, but there is a small sliver of meniscal tissue that has gone with it. In the type 4B, you will only see that there is a disjunction of the ligaments, but the meniscus is absolutely normal. But this is a large ramp tear and this should be corrected, otherwise this will offer instability to the patient. And type 5 is when everything becomes complex. Now these peripheral sliver tears, you can report them as peripheral long axis tears also. But remember that this peripheral sliver of meniscus that tears will tear with the capsule. So report that as a ramp tear. In the posteromedial injuries and the medial collateral ligament injuries, I want to show you only two things. The proximal MCL, when it tears, I've told you that it can scar beautifully. But the distal MCL, when it tears, is where you need to use your radiological knowledge. If the distal MCL tears and it becomes superficial to the pes anserinus, so the first layer is bone, on top of bone is MCL, on top of that is the pes anserine tendon. If the distal MCL tears and it's in its position, it's okay. If the distal MCL tears but it becomes superficial to the pes anserinus, that MCL will never heal because there is an interposition of new tissue now to the bone. This MCL will never heal. So when you tell the surgeon there's an ACL tear and a proximal MCL tear, he won't repair the MCL because he knows the MCL will heal. But when you tell him there's a distal MCL tear and there's a Stenner lesion, he will repair it. He has to repair it, okay? So these are the kind of tears you should not miss. Here's another patient, MCL proximally is intact. Distally you are seeing that there's something going on and there is no way to now know if it's a Stenner or non-Stenner. What will help you in this setting is always going in for even though you can see a retraction, but you don't know whether it's Stenner or non-Stenner, so you go for an axial. Now try and look at the left margin, the medial margin. You can see that MCL that is edematous proximally. You can see a bone bruise. Now you see that thickened MCL. Then you see that thinner but still you can see that large MCL. Note the pes anserine tendons, these 3-4 tendons that are behind. At some point of time they are coming anterior and that linear MCL, I hope everybody can see it. I'm so sorry I don't have a pointer. Can you give me a pointer? So, if you see this, this one now, that MCL has become superficial, right? And the pes anserinus has become deeper to it. So this is a Stenner lesion. This is important. Please write Stenner or non-Stenner distal MCL avulsions. It is important to the surgeon, okay? And also you gain a lot of brownie points when you start reporting like that. So this is another MCL, okay, that is distally torn. And sometimes you can have a distal MCL tear here and a deep MCL tear proximally. So deep MCL tears proximally and superficial MCL tears distally. This is quite common. We see it commonly. Also something that surgeons don't believe is that they say the POL or the posterior oblique ligament won't tear if the MCL is intact, but that's not true. In this case, the MCL was intact here and the POL was torn. Okay, so you want to report isolated POL or posterior oblique ligament tears as well. Lateral corner injuries, I think all you need to see the popliteal tendon, lateral collateral ligament and the biceps. In this case where both these are torn at mid segment, this is a grade 3 PLC injury. And here this is another where proximally there is a tear. So this is a mid segment tear, this is a proximal tear, anterolateral ligament has torn, the popliteal tendon has torn, the FCL or the lateral collateral ligament has torn. And you want to see if there's a bone fragment that has torn with it, but in this case we couldn't see one. There's an ACL tear, but you watch that there's also a biceps tear in this patient, and you will see that the entire complex is stripped of the bone. So everything is stripped. So this is a grade 3 injury. Anterolateral ligament is debatable. Some surgeons says it's such a thin ligament, it offers nothing to the knee joint. Why do you even report it? Some surgeons say that it is important and they might want to do a lateral extraarticular tenodesis. Either ways, we should be sensitive to anterolateral ligaments. When they tear from the femoral attachment, it is usually a soft tear. And when it tears from the tibial attachment, it's a Segond fracture. So here's what that looks like. This is a Segond fracture. You should also be able to report it on the X-ray. The rest of the lateral ligament complex in this patient was normal, but he had trouble on the medial side as well. This is a Segond fracture. A case of multiligamentous injury. This was a weird case because the MCL had completely torn and it had got entrapped. Okay. So there's an MPR, MPFL, there's lateral sided, everything is torn basically in this patient. But what is important to write is that if there is any entrapment of the MCL, because the surgeon needs to remove that MCL and then do a gracilis grafting, okay? Otherwise, normally they don't touch the torn MCL, they just put a graft. In this case, he'll have to remove that MCL. So there's an MCL that is torn and the entire complex has gone inside. Okay. Apart from that, you also have a complete rip-off of the lateral collateral structures from the femoral condyle. Here's the same. You can see this is the lateral side and this is the medial side. So this is completely stripped and the MCL had gone in and this is the lateral side. But on the axial, you won't see this entrapment very well. The same can be seen on the GRE, but you can also see that there are some bone bruises and there was a bone fracture here in this patient as well. sometimes when there are ruptures of the PCL, there can be root ruptures, okay? So this patient has a reverse C-gond fracture, so medial sided tibial tear. He has an arcuate sign, so lateral sided avulsion as well. Look at the lateral meniscus. Here's the meniscus, there's the meniscus, then the root is avulsed, and the PCL has torn and it's become extracapsular. So here's the root, it is completely avulsed from the bone. The PCL has gone in and swung backside. The ACL has also stripped from its tibial attachment completely, okay? And that's the PCL going out. And you're also seeing that there is no medial meniscal root as well. So in this case, even though the menisci were normal, but the posterior roots were completely avulsed, and there was an extracapsular rupture of the PCL, and there was a reverse C-gond sign, and there was ACL avulsion, and there was an arcuate sign. So what's important to always report is the root of the meniscus, where it is. It's always important to report any flaps, any fragments, anything that can come inside the joint and grind down the cartilage for the patient. And it's very important to be sensitive towards the posteromedial ramp lesions, okay? The meniscus is normal, this is an arthroscopic blind spot, the surgeon wants to go inside and he wants to repair the ramp. Sometimes these ramp, it's the periphery, so it's very vascular. You might report it as a 4A kind of a ramp tear. When the surgeon goes in, there is nothing. The ramp has healed. That's also okay. Either ways, you should not run the risk of missing a ramp tear in a patient who is going for an ACL reconstruction. So this is what we have seen, and what I've tried to walk you through are the smaller, finer nuances of good MRI knee reporting, right? Thank you.
Inspiring and knowledgeable talk with us. So now we will start the inaugural. Jai Jagannath, esteemed dignitaries, respected members of Odisha Radiological Imaging Association, revered teachers, seniors, collegians and juniors, I, Dr. Shivani Panda, PG resident, MKCG MCH Barampur,
and I, Dr. Lippi Pushpa Mahapatra, PG second year, MKCG Barampur, welcome you all to the inauguration function of 49th Annual State Conference, Oria.
Now, I would like to invite the dignitaries to the dais. Dr. Vijay Kumar Samal Sir, President, Oria. Dr. Sachidananda Mahanti Sir, DMET Orissa, a chief guest. Dr. Sesdev Panigrahi Sir, Secretary Oria. Dr. MVK Rao Sir, Chief Advisor, Oria. Presentation of bouquet. Now I
Now I would like to request Dr. BK Samal Sir to present the bouquet and shawl to DMET Odisha, Dr. Sachidananda Mahanti Sir. Now I would like to request Dr. BK Samal Sir again to present the bouquet to our Chief Advisor, Dr. MVK Rao Sir. MVK Rao Sir. Now I would like Dr. MVK Rao Sir to present the bouquet to President Dr. BK Samal Sir. Now I would like to request Dr. BK Samal Sir to present bouquet to Secretary Oria, Dr. Sesdev Panigrahi Sir.
Nothing is more auspicious than lighting a diya in front of our Mahaprabhu Lord Jagannath. So, I request the dignitaries to light the lamp and grace the occasion.
गुरुत्वं कल्याणम् आरोग्यं धनसम्पदा शुभं गुरुत्वं कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिः
Now, I would request the dignitaries to unfold the souvenirs.
Now, I request President Dr. Vijay Kumar Samal sir to address the members.
Good morning to all. Respected Professor Dr. Sachidanand Mahanti, Director Medical Education Training Odisha. Respected Professor M.B.K. Rao, so my dear Sesdev Panirai. Ladies and gentlemen, so I am honored and privileged to stand before you today as you gather for the 49th Annual State Conference of IRIA Odisha Chapter. It is indeed a momentous occasion, and I extend my heartfelt gratitude to each and every one of you for your kind presence here today. I would also like to express my sincere appreciation to our Director of Medical Education and Training, Professor Dr. Sachidanand Mahanti, for gracing this event as our chief guest. Your presence, sir, adds great value to our conference, and we are grateful for your unwavering support in advancing medical education, healthcare in our state of Odisha. I also appreciate the AIMS Bhubaneswar team, for which, for them, we could conduct 2 academics in a span of 2-3 months, and I also appreciate the IMS SOM team. They also have conducted 1 academics in this year. So totally, including this conference, we have 4 academic sessions. So this is probably a record for this year. So as you stand in the cusp of New Year, it is time for reflection, collaboration and advancement in the field of radiology. Our profession plays a pivotal role in the healthcare ecosystem, enabling accurate diagnosis, guiding effective treatment, and ultimately improving patient outcomes. I encourage each of you to actively participate in the various sessions and discussions that have been meticulously organized for this conference. Share your knowledge, experience, and insights with your peers, as this is collectively exchange of information, and undoubtedly this will contribute to the growth and progress of our profession. So let us use this platform to discuss and address the challenges faced by our community, whether they be related to technology, healthcare policies, or professional developments. By fostering an open dialogue, we can work towards solutions that will not only benefit us as professionals, but more importantly, improve the quality of healthcare services for our patients. So in conclusion, I would like to once again express my gratitude to all of you, and especially to our DMD sir for his presence and for your dedication to the field of radiology. Together we can build a future where advancement in medical imaging lead to the better patient outcomes and improved healthcare delivery. Thank you very much. Long live ORIA. I wish you all a fruitful, insightful conference. Thank you. Thank you. Thank you.
Thank you sir, for your words. Now I would request DMET, Dr. Sachidananda Mahanti, sir, to say a few words and grace the occasion. Sir.
Thank you, Madam Ji. Good morning, all. Respected members on the dais, the students, faculties, the guests. Thank you very much, Oria, for calling me to this occasion. I was listening to your speech. I was thinking of my knee injury also. I had it in 2017. I had ACL tear. It was repaired by Anant Joshi in Sports Med. You know, that is one of the best center, and Dr. Joshi, to get him is very difficult also. He has done a lot of work on sports medicine, especially repaired Saurav Ganguly's case, Sachin Tendulkar, Mary Kom and other. So this part of the thing is important as far as the orthopedics is concerned, but then the role of radiology cannot be ignored. It is gaining momentum. In our time, only X-ray was there, then ultrasound, then of course the CT, MRI, you know, so many things. And the department as such is getting importance. We hardly get anyone. We are offering the amount, whatever negotiable amount also. We have now 13 medical colleges. Once I told, whatever amount the radiologists they want to take, let them take, please come and join. But nobody is willing to come. Corporate is the obstacle to us. But I am glad that we have PG students in 3 of the old medical colleges. We are planning to open up the rest of the medical colleges, but it's very tough, very difficult. It is gaining importance because they are now after the surgeons, the radiologist. Interventional radiology is most important thing. Probably they are, you know, going into the bread and butter of surgeons, orthopedicians, gastroenterology, you know, all the departments they are entering. Like, you know, the cardiologists, they have taken up 50% of the work of CTVS, the same thing they are going to take up. But then it is far, far better than your the classical surgery work. I would say the interventional radiology is upcoming, you know, it is one of the best thing one has to think of. And that is the pride of radiologists today. See, I am basically from forensic medicine. We have a group in Orissa. So I would advise, I don't know whether you have or not, especially for the postgraduates, they should involve the faculty and they should come up with a WhatsApp group. Whenever you have any issue relating to, you know, you are unable to diagnose, you can post that and get the answer from the seniors. Oh, you must be having it. If not, please go with this. Even you can include the top radiologist of the country also. Nobody will hesitate to give you advice if you are asking for it. That would be my advice to you all. I wish all the best for this state conference. But I also say to Sukhdev, you don't waste time for all this. It kills actually. Unnecessary timing, giving guests 5-10 minutes each, 1 hour is a waste for inauguration. 5-10 minutes is okay. So the students and the faculties, those who are here, I wish them all the very best, and they must talk to the seniors, clear your doubts. My best wishes, and God bless you all. Thank you very much.
Thank you, sir. Now, I request Dr. Sesdev Panigrahi, sir, Secretary Oria, to say a few words. Sir, please.
Ladies and gentlemen, esteemed colleagues and distinguished chief guests,
Professor Dr. Sachidananda Mahanti. A very good morning. Today I stand before you as a Secretary of Oria filled with gratitude and excitement to welcome you to our annual state conference. This gathering is a testament to the collective dedication and passion we share for advancing the field of radiology and imaging in our great state. As we embark on this journey over 1.5 days, let us embrace the opportunity to exchange knowledge, discuss cutting-edge advancement, and foster collaboration among our diverse community of professionals. Throughout the conference, we have created a series of insightful sessions, live demo, discussion led by renowned experts in the field. Nafisa ma'am and Dr. Srinivas sir is available for all the live demo and interaction. These interactions aim to deepen our understanding of emerging trends, encourage interdisciplinary dialogues, and empower us to provide the highest quality of care in our state. In addition to the academic agenda, I encourage you to engage in networking opportunity, building connection with fellow radiologists and industry partners can spark collaboration that drives innovation and elevate the standard of healthcare delivery in our state. Let us also take a moment to recognize the dedication of our members and express gratitude to the sponsors who have supported this event. Their commitment underscores the importance of our shared mission to advance healthcare through excellence in radiology and imaging. As we navigate the ever-loving and landscape of our profession, let this conference serve as a platform for inspiration, education, and unity. Together, we can shape the future of radiology in Odisha, contribute to the well-being of our communities. Thank you for your presence. I look forward to a rewarding and enriching conference. Thank you.
Now, I request the dignitaries to unfold the souvenirs. Now, I request Dr. Jay Samal sir to felicitate Dr. Sachidananda Mahanti sir. Dr. Nafisa Sakir Batta ma'am, kindly come up to the stage. Now I request Dr. Sachidananda Mahanti sir, kindly felicitate Nasifa ma'am. Now I request Dr. Srinivas S. sir, kindly come to the stage, and Dr. Sachidananda Mahanti sir, kindly to facilitate him. Now, I request Organizing Secretary Dr. Sasdev Panigrahi sir, kindly come to the stage and felicitate Dr. Manoj Naik sir. Dr. Manoj Naik sir, kindly come up onto the stage. Now Dr. Tara Prasad Tripathi sir, kindly come up onto the stage, and Dr. Sesdev Panigrahi sir, kindly felicitate him. Now I request Dr. MBK Rao sir, kindly felicitate Dr. Sesdev Panigrahi sir. Dr. Tara Prasad Tripathi sir to give the vote of thanks.
Good morning. I'd like to thank all the organizing team, scientific committee, our president and secretary Oria, scientific committee led by Dr. Adya Panda sir, and all the delegates and our invited faculties who have given beautiful lectures, and all the local speakers also who have contributed nicely. And we'll have few more lectures following this, so I'll keep it short. Thank you. Inauguration ceremony, we will continue with our academic programs. To take his presentation on IUGR. So we'll have the IUGR talk now. Thereafter we'll go to the live demo for fetal ultrasound.
Okay. Right. So good morning, everybody. Very nice to be back in Odisha. Very nice people, very nice place. I really enjoy coming back as a third visit here. And ignore that small squiggle which I made on the screen. I was just checking whether the pen is working or not. Right. So a very, very important topic, IUGR, long neglected. Strictly speaking, it is the most important topic in fetal ultrasound because it is 5 times more common than anomalies. We have been concentrating on anomalies for decades. And we forgot something which is 5 times more common. Not a small number. Anomalies. Major anomalies 1%, together with minor anomalies total 2%. Growth abnormalities 10%. And what we have been concentrating on? On 2%. Not correct, isn't it? So it's high time. And in the last 7-8 years, lot of work has gone in. There has been enormous understanding. Our whole concept of what is fetal growth and and its abnormalities and how to evaluate, how to manage has completely changed. And we should remember one very important thing here. The entire diagnosis and how to manage growth abnormalities is based on one thing: ultrasound. There is no alternative. The only other test which has some role to play is probably a CTG, tomography. Other than that CTG, there is hardly anything. So first thing, let us see how we can go about understanding growth. Now, to understand IUGR, we have to first understand something that has not been taught in MD. These things are totally not taught at all. We are completely skipped. What our senior tells us is what we learn in ultrasound, right? Other than that, there is hardly any systematic teaching at all during our post-graduation. Then we have to understand what is, now to understand anything abnormal, first thing is to know what is normal. Then we come to this, and here we are going to concentrate only on this. We are not going to go into macrosomia at all, the other end of the spectrum. Then we will be looking at how to identify. Okay? So let us first define what is fetal growth. So growth is what? Increase in size, independent of development. Development is separate, growth is separate. So it is increase in size or the weight, and it is best viewed as a velocity. We should not think as one point. It is not a point measurement. To know anything about growth, it has to be over a period of time. You should have 2 readings. That is when you can talk about growth. Single reading, you will have size. Only when you have a second one, you have assessment of growth. So it is over time, size over time. So what's the conventional definition? You have a reference range, there is a 50th percentile, then you say, okay, 90th percentile, 10th percentile, above that is macrosomia, below 10th is small. But how are these charts made? We need to understand how this chart was made. All these dots are data collected from the study from which the nomogram was prepared. All normal. It's not that any of this, even this is normal, this also is normal. And the nomogram was prepared with majority of them. You have this. So even the nomogram does include things which are outside these ranges. So unless we think of growth as a trajectory, we are going to miss a lot of things. A trajectory which is reducing like this is worrying. A trajectory which is following this, even if it is below, is reassuring. So over a period of time. So let us look at the definitions. Small for gestational age. For that particular age, that fetus size is small, is the meaning, as estimated by the scan. Or even if after birth, if you estimate at birth, they also have a small for gestational age. In ultrasound, for that particular gestational age, we would expect the fetus to be of a certain range of sizes, certain range of weight. If it is less than that, we are going to call it small for gestational age. Now we should understand that small for gestational age can be normal or can be growth restricted. Both possibilities exist, and it does not imply that a small for gestational age baby is abnormal. No. It just says size is small. Both perfectly normal babies. At birth, they are not going to be of equal size. No two fetuses are of exactly same size. Correct? So at any point in gestation, they are not going to be of equal size. So how to define growth restriction? A fetus that has failed to reach its growth potential. The growth potential is genetic. Some families have large babies, some families have small babies, based on parent size, grandparent size, etc. Right? They are not going to be equal size. So that is where the whole problem starts in assessing normal versus abnormal. So if it is free from pathology and adverse events, where would it expect it to reach? So basic problem, what is the growth potential for any given fetus? In a population we can tell. In India, okay, this is the range, yeah, fine, no problem. In Karnataka, in North India it will this, in South India will be a little smaller, fine. Punjabi sides, okay, they tend to be a little larger, wonderful. But in a given patient, how are you going to? That is the problem. Just like that, just think of it like this. All are of the same class. Are they the same size? All are healthy. So their age is same, but their size is different. This would be a constitutional smallness, not that they have any ill health. Whereas FGR, growth restriction, is a pathologically small fetus. Now this is pathologically small. Normal of the same age. Right? So size by itself is not an indicator of ill health, but it can be a sign of ill health. So there is a wide range of normal weight by term. So what do? We classify all fetuses below one defined weight and call it as small for gestational age. Right? So some fetuses outside this normal range would be the constitutionally small fetuses, and pathological ones would be the growth restricted ones. Right? So size is what? So small for gestational age is what? Constitutionally small plus FGR. So weight by itself does not differentiate between the two. What do we need? We need other parameters. Correct? If one thing cannot tell us, then we need other parameters to differentiate between the two. So what is then growth restriction? So the two are not synonymous. This is not synonymous. SGA is not synonymous with growth restriction. Some small for gestational age are growth restricted, about 50%. Yes, in India we have a very high incidence. Actually it is little shameful that India has the highest number of intrauterine demise and FGR related deaths and maternal deaths, highest in the world. Our awareness about this and what we are doing about it is very low. That is why IRA has come out with this program called Samrakshan program to create awareness among radiologists to start doing Dopplers routinely and understand growth properly. Please join it. You will be saving far more lives by doing Samrakshan than by trying to detect anomalies. You will do at least 5 times better work, minimum, guaranteed. So some SGA babies are FGR. So our job is what? To try to differentiate SGA from FGR, constitutionally small from growth restricted ones. Large number of constitutionally small fetuses or small fetuses are constitutionally small, half of them. Now, what about large for gestational age? This also is becoming a problem. So know how to assess that also. 90th, 95th percentile, okay, 4 kgs, there is no consensus. We can take EFW of 90th percentile as macrosomia, because maternal diabetes is becoming very, very common nowadays. We are seeing more and more maternal diabetes. I am seeing an average of at least 1 to 2 maternal diabetes every week. I am sure many of you are not seeing, because many radiologists don't even take the history. It is not that they are not coming, it is that you are not aware of it, right? So this is the awareness that with Samrakshan program we are trying to create. Take a history. Ultrasound is different from CT, MR, from all other X-ray, everything. It is unique. Patient is there the whole time. Please talk to the patient. A short history may be the difference between you diagnosing something or not diagnosing something. And look at the patient. I've been telling all my residents, all my students, please look at the patient, observe. Why did you do MBBS if you're not even going to look at the patient? We were taught, what were you taught? First thing what you taught? Inspection. I'm not even telling do palpation and percussion. Auscultation we will do using Doppler, right? We are high funda, we don't want steth and all. For us, steth is outdated. Palpation is also possible. Probe pressure, yes, it can reveal quite a bit. Even in the while doing abdomen ultrasound. Rigidity, easy to make out when you're doing ultrasound if you're trying to give pressure. Just be alert. Take a history. So small baby, normal size baby, long. Any of these can be normal or abnormal, right? So please stop using these terms. Interval growth, normal, less, increased, more. Please stop using this weeks ahead or behind of dates. Wrong. Growth now is measured with percentiles. So please use percentiles. What we have to do? We have to switch over to appropriate for gestational age, small for gestational age, growth restriction, large for gestational age. These are the terms to be used for growth assessment. Appropriate for gestational age, very simple. 10th to 90th percentile of two parameters, AC and EFW. Simple. Instead of looking at absolute numbers, instead of looking at weeks, days, just look at percentile. That's all. Small for gestational age, between 3 and 10. Parameters, same. One or both. Growth restriction, based only on size, less than 3rd percentile. AC or EFW or both. Large, more than 90th percentile. Over, simple. So just by looking at size, there is a classification that we have to do. Why? Anything other than this, we have to start asking why and start investigating further. That is why. It's very simple. So appropriate for gestational age, AC and EFW between 10th and 90th percentile. Small for gestational age between 3rd and 10th percentile. Large more than 90th percentile. Single parameter, EFW or AC go below 3rd percentile, you are still going to call it as growth restriction. But that is not going to be a 100% guaranteed diagnosis. Because even the small for gestational age, few of them are going to get included in this. We cannot help it. You cannot do it based only on looking at biometry. We have to do Doppler to differentiate. So, growth restriction, fetus which has not achieved its genetically determined potential size due to genetic or environmental factors. Since you cannot determine this, we cannot be sure before birth based only on size. So let's look, what is the postnatal diagnosis? How will a pediatrician say growth restricted or small baby, constitutionally small? It should be a fetus which is born with features of malnutrition, and they use ponderal index subcutaneous fat deposition. Right? So can we use? Why don't we use? We will also do ponderal index before birth. That's a small problem. Formula has for ponderal index as fetal length. How are you going to measure the fetal length before birth? Not possible. Except in first trimester when it is useless. And this varies with gestational age also. So prenatal diagnosis and postnatal definitions, both the definitions themselves are different. So obviously there are going to be mismatch between what we call as IUGR and what pediatricians are going to call as IUGR. That will be there. We cannot help it. Moreover, there is also a problem. Our EFW estimation itself has a plus or minus error. Correct? Right now, is it 100% accurate? Is it exactly what we give? No. Plus or minus 20% is there. 15 to 20%. According to what is given in research papers. It can be reduced drastically. You can become much more accurate. We have been in our center getting consistently very good results below 10%. Less than 10% in more than 95% of cases. We have been following up. How? Very simple. By following protocols exactly. The measurement protocols are totally ignored by majority of radiologists. Something that looks like cranium, one small, some CSP is seen, do one BPDHC. No. Zoom properly, use the correct. And especially abdomen circumference. All sorts of oblique planes are used to do abdomen circumference. If you don't do that, if you follow protocols exactly, it is possible to achieve plus or minus 10%. Practically it is possible. Major problem comes when there is oligohydramnios. When you want it to be very accurate, that is when it will be least accurate. Because the fetal knee will go, the thigh will go and abut the abdomen. Abdomen is no longer oval. It becomes an irregular shape. And AC is the major contributor to weight estimation. Right? So it will give us problems when we want it to be most accurate. So what are the causes? Heterogeneous. Many of them are there. Fetal, maternal, environmental, placental. So you have non-placental and placental. Vast majority are placental. Non-placental are much, much less. And we should keep one very important thing in mind. Genetic causes and infective causes. When you have something like this, very early, patient has come for anomaly scan. At that time, already it is an IUGR. Where third percentile is not even first percentile. And this is based on, not on LMP, this is based on an accurate dating which was done in the first trimester. With a corrected DDD, we have done it with that. So we know dating is correct. Very early, please investigate, because it could be due to a cause or a genetic cause. Second, much more common group is what? Preeclampsia, chronic hypertension, gestational hypertension, diabetes. So diabetes, maternal diabetes can cause macrosomia. It can also cause IUGR. Both ways. So let us try to understand the pathology here in the placental part, which is the most important because it is the commonest. Basically what is happening? Because of a placental problem, it's an undernourished fetus. Later goes on to become hypoxic. Why? Because the fetus only supply is coming through what? It's coming through placenta, which is not allowing enough nutrition, enough oxygen to come in. That's all. We understand this basic thing, you understand the pathophysiology. So it is a starving fetus to begin with, which later on becomes suffocated in utero. Now there's a very important concept that we should understand. Now there's still a lot of radiologists who are still writing this old time asymmetrical IUGR, symmetrical IUGR. Please stop. There is nothing like asymmetrical, symmetrical. It does not make it. It may be asymmetrical, it may be symmetrical. It has nothing to do with the cause. It has nothing to do with the prognosis. It has nothing to do with the management. Whether it is asymmetrical or symmetrical makes zero difference. So those terms have been stopped, and this was stopped 7-8 years ago, not now. And we still continue to use it here, where in the country with the largest number of growth restricted fetuses. So this symmetrical, asymmetrical has no meaning. It is absolutely useless. What we have to differentiate is this, something that was properly understood only about 10 years ago, that there is a early and late. So the most common cause is a placental disease in which there can be early and late. These concepts should be very clear. Now early onset FGR associated with reduced villus cross-sectional. So the vascular area in the placenta is reduced. So there is a perfusion problem. Once there is a perfusion problem, the vessel supplying the placenta will show an increased pulsatility index. That's all, because the resistance is higher, correct? Umbilical. So placenta has two supplies. What? Uterine, umbilical. Correct? So these are the two in which the PI can go up, either from the mother side or from the fetal side, depending on where the defect is. This typically develops in mid-trimester. So the fetus becomes small with a uterine or umbilical artery Doppler abnormality, increased PI. Whereas late, it is actually more common but unrecognized. Usually develops after 32 weeks. It is a villus immaturity and placental damage is less than what you would get in early FGR. So because the placental damage is less, there is a diffusion problem. And because the damage is less, it does not show up with uterine or umbilical artery problems. They will be normal. The PI is normal. Fetal size is normal, but still there is a late onset of FGR that is happening. So they do not present in the same way. And the Doppler changes, which we are going to discuss in the next talk, are not going to be same. Early onset is about 20 to 30%, but there is a very high incidence of preeclampsia. Hypertensity is much less common in late onset. So what is happening? What is the difference? Early onset, the damage is more. So the supply to the fetus is less right from the beginning. So what happens? Now, like any organism, after birth, before birth also, there is an adaptation that happens. We adapt to our environment provided there is enough time to adapt. Correct? Any organism will adapt. Even the developing fetus adapts. Because the damage is more already from the beginning, nutrition is less. So what does the fetus do? It adapts by becoming smaller. It doesn't grow as much as what its genetic potential actually allows. So that's the adaptation that happens. It's not that it can't. Genetically it can become larger, but it will adapt. It will say, okay, I am not getting enough food. I will become a little thinner. I won't grow as much as what I can actually can. So this adaptation is what happens. So it becomes small right from mid-trimester. So lesser nutrients, smaller fetus, less demand for oxygen and nutrients even later in pregnancy. So there is a slow progression which is very predictable. Late onset, what is happening? There has been sufficient food what is required in the early stages. So growth velocity is there, right? Velocity is already, it is going at a certain speed. It has already started off. It can't suddenly apply a brake. Yeah? It doesn't have hydraulic brakes like all your modern cars. Okay, the old-fashioned brake. It takes time for it to, it cannot suddenly slow down that velocity. And it cannot become smaller. It is already grown big. So it grows normally till third trimester. Then what happens? Suddenly there is an oxygen and nutrients is less. So there is a sudden deterioration. There is no time to adapt. So the deterioration is sudden. So what happens? Early, slow, predictably, it will keep on going less. It will not grow in this fashion. Here what happens? Growing, then suddenly, but it will still remain within your normal range. If you measure here, it will still be within normal range, though it has already gone into growth restriction. So sudden demise will occur. That is where Doppler comes in, and we will not be going into in this talk itself. It will be after with the next talk because of time. There is a time, right? There is a time limit. I can't talk indefinitely. It's not correct. Not that I can't, but I should not. I've been known to speak for 4 hours continuously, and how on earth people sat and listened, I don't know. An award should be given to them. So please remember, early onset, there will be a predictable path with lot of Doppler changes happening in between. That will not happen with late onset. Sudden deterioration late in pregnancy. Because this is the foundation for the next talk. So can you predict this, and how useful is ultrasound? One thing you have to remember, which most people don't do, history. There are a lot of, if you don't take a history, you won't know. If you don't take a history, you won't know. There are pointers. You don't ask the patient, don't even talk to them, you will not know. You don't even look at the patient, you will not know. But majority of radiologists will somehow realize BMI increase when they look at the poor quality of the image. Right? And will still be thinking only about quality of the image. They will not think, okay, this is high BMI, maybe it will go for IUGR. That next thought is what has to come next. Okay. So other things like placental size, perfusion, APH is another one. If there has been a hemorrhage early in pregnancy, right? Detection has been very low. We are in this stage. But with systematically, if you low because of low level of suspicion, because we don't suspect. Even in UK they had that. Then they went in for a systematic training program with customized charts. Jumped from 15% to 48%. How much is the jump? 3-fold increase in detection. Same thing in Australia. They did the same process, same thing in Australia. High time we did it in India. So start suspecting, first be alert. Your pickup rate will triple. It should actually go to 5 times ideally. But at least if it triples, it is good enough. So growth charts should be used to track over time. Don't look at individual number in growth of only today. Growth velocity is what is important. This is a trend. This is how we should be looking at it, not looking at only size. So this is the screening for small for gestational age. After that, use Doppler to see whether it is FGR or not. So the best tool to differentiate Doppler, which we will be talking about next.
Thank you, sir. Now I would like to request Dr. Tara Prasad Tripathi, sir, to present his topic, contrast enhanced ultrasound.
So by the time our live demonstration gets ready, I'll just finish the contrast enhanced ultrasound topic. So how many have done a contrast enhanced ultrasound in their regular practice? So it's quite easy to do, not much technically as well as to interpret. So I'll take you through the basics so that you can easily do a contrast enhanced ultrasound later on. Okay. So our learning objectives will be to get through the principle of contrast enhanced ultrasound, the types of contrast agents that are available, the technique of contrast enhanced ultrasound, the diagnostic and intervention applications, safety profile of contrast agents, and some upcoming applications. So what are the types of contrast agents? You already know there are first generation and second generation agents, and the first generation agents were initially developed for doing contrast enhanced echo, and second generation are Sonoview and Sonazoid. So what is available in India is Sonoview. Sonoview is sulfur hexafluoride with phospholipid, and Sonazoid is the one that has additional Kupffer phase imaging. So what a ultrasound contrast agent or bubble is composed of is an active compound, that is gas or sulfur hexafluoride, and it has a monolayer of phospholipid. So these microbubbles or the ultrasound contrast agents, these are pure blood pool agents. So that is the most important characteristic. They stay entirely within the lumen of vessels. They do not go to extravascular space, and that is how the imaging is different from CT or MR contrast agent. We'll come to it later on. So this is how ultrasound looks on ultrasound contrast agent looks on a electron microscope. So when the ultrasound agent interacts with energy beam, that is low mechanical index beam, it remains stable. With higher mechanical index, that means our routine ultrasound, it disrupts, bubble gets destroyed. So with very low MI, there is symmetric behavior. We don't need this symmetric behavior. We need non-linear behavior of ultrasound agent. I'll show you why we need non-linear response, and this non-linear response is achieved at low mechanical index. So with non-linear response, there will be generation of subharmonics. As you already know, with subharmonics, our image quality will be better. With very low MI, what happens here is at very low MI there is less subharmonics and the image quality is not good. So what is mechanical index? It is the peak ratio between the peak rarefactional pressure to square root of frequency. Basically low MI, at low MI, that is below 0.2, the microbubbles are stimulated into harmonic motion and real-time imaging is possible. So if you see on your ultrasound screen, you will have the MI written on it. Routinely it is above 1 or more than 1 or 2. With color Doppler ultrasound, you need low MI. The MI will be less than 0.2, where the bubbles can stay in those imaging plane for longer time. So you can see here, this y-axis is the MI. With increase in mechanical index, there is more destruction of the microbubbles. So you need somewhere in this range, that is low MI, where there can be oscillation and generation of second order harmonic frequency for good quality ultrasound images. Okay, so there are specific pulse sequences that is required. So if you image without a dedicated pulse sequence, you cannot make out the difference between the background tissue and the vessel within which microbubbles are present. Whereas with dedicated contrast pulse sequences, you can see easily you can see the microbubbles better with suppressed background tissue. Okay, so whatever we have read here, I'll summarize. So ultrasound contrast agents are microbubbles with surrounding lipid cells. On interaction with a low power ultrasound image, that is low mechanical index, there is non-linear generation of harmonic signals, which is imaged using a dedicated pulse sequence for contrast specific image. And the most important characteristic of these microbubbles are they are entirely intravascular, pure intravascular agents. Okay, so this bubble specific imaging, this most important is the excretion. In this slide, I'll just go to the last line. Phospholipid is excreted by the liver and the gas is excreted by the lungs. So it is a safe agent for patients having renal dysfunction. Okay, so we have two agents presently available in the country. One is Sonoview, which is sulfur hexafluoride with phospholipid cell, marketed by Bracco. This is available here. And this Sonoview consists of a single vial with 25 milligram of lyophilized powder. And for IV use, maximum dose can use is 2.4 milliliter. And for renal and pancreatic evaluation, 1 milliliter is enough. Besides this, you require 10 ml of 0.9% normal saline that should be flushed after administration of contrast agent. I'll go into it. So Sonazoid has a dedicated Kupffer phase imaging. So usually this with Sonoview you can image up to maximum 5 minutes, but with Sonazoid your imaging time will be increased, that is up to 10 to 15 minutes. I will show you an example what is the advantage of this Kupffer phase. And this is for dedicated liver imaging, and it's also available in India. So the technique is important. You need to know how to perform it. So you need to have high quality cine images and still ultrasound images. Standard biplane, grayscale and color Doppler ultrasound images of the lesion prior to contrast enhanced ultrasound should be obtained. So you need to see the lesion on grayscale, thereafter proceed for your color Doppler evaluation. So the minimum size of liver lesion that has been that is required to be evaluated is 1 centimeter. So below 1 centimeter your characterization will be not enough. So you have to explain the patient to breathe normally, shallow breathe, because full suspended inspiration will be difficult to image. An attempt should be made to have the lesion centrally placed in our ultrasound image, and probe frequency is as per the depth of the lesion. So for deeper lesion you need a smaller frequency. So again, these are techniques that you need to know. Dual screen display is required. In one screen there will be routine grayscale image, other screen there will be color Doppler image, and dual calipers for correct localization of the lesion. Clearly visible timer is required because timing is very, very important for your lesion characterization. I'll come to it. And mechanical index is usually less than 0.3. The injection speed is not important. However, for the bubbles not to get destroyed, you need to inject it slowly, and the recommended needle gauge size is 20. 22 is also adequate. So the enhancement features are defined in time units relative to injection. I'll show the examples, then you can easily follow it. The precise timing is very important. So timing and then intensity of the washout, those things will come later on. So time 0, how you define it? You first give the contrast agent, then you give 10 ml of 0.9% normal saline. So once you start injecting the normal saline, your timing starts at that point. Your timing does not start at the injection of contrast agent. Okay, that is the important point to note. And at the arrival of first bubbles within the field of view, a continuous cine loop needs to be saved. So first 60 seconds, you need to save the cine loops or the video clips, 30 seconds. Thereafter, at every interval of 30 seconds, up to 5 minutes, you have to keep still images for evaluation, for easy interpretation later on. Okay, so what is important is a 60-second mark. So at 60-second mark, you need to keep the images, because that is very important to differentiate a non-hepatocellular malignancy from a hepatocellular malignancy. I'll come with examples. So the procedure is done on as you do a normal ultrasound. You make the patient lie supine, and you prepare the ultrasound contrast agent. So how do you prepare? So this is the box of SonoView. You can see that box that is available in the Bracco. So this has sulfur hexafluoride powder, and it comes with one vial and a spike. So this is a mini spike. So you insert this vial into this mini spike. Okay, prior to that, you connect it with a 6 ml of normal saline. Okay, this is the normal saline, routine 0.9% normal saline, 6 ml. You connect it first and insert this vial. This vial has your sulfur hexafluoride and phospholipid, and you insert into the spike and inject this 6 ml into the vial and sec it for 20 seconds. After you have second for 20 seconds, you aspirate the contents into this syringe, and you have 6 ml. So in single evaluation, you have 6 ml of contrast agent available. So 2.4 ml is required for a liver lesion evaluation. So you can do 2 studies, or 2 times in a single patient you can do a study with a single vial. Okay, so once you have prepared it, you have to use it within 15 minutes. So beyond 15 minutes, the bubbles gets disrupted. So once you prepare it, use it within 15 minutes. Okay, so what are the applications? So currently approved diagnostic applications are for lesion characterization and detection, particularly liver, as an adjunct tool to solve lesions that are not characterized with CT or MR, and for IR applications, we use it in several other TACE and ablation follow-up, response assessment, or for procedure guidance, and for further vascular applications, I will show you by examples. Okay, so these are the approved uses. SonoView is approved for use for liver lesion characterization in adult and pediatric patients, and also for suspected VUR. Like you do voiding cystoscopograms using ionic contrast agents, you can perform a sono VUR, sono vesiculator, sono cystogram for VUR assessment. Okay, so I'll come to the most important slide in my presentation. This is how to identify or characterize liver lesions. So this algorithm is very important. So the first question that needs to be asked is there a portal venous or late phase washout? So once you start doing ultrasound, you will acquire the arterial phase first, then you will acquire the portal vein first, thereafter. But the arterial phase is not the one that you are going to see. You are going to see the portal venous phase or late phase first. I will show you examples, then you will follow it better. Just for priming you, I am showing this algorithm. So first is portal venous phase or late phase washout, if it is there. So what do you mean by washout? As compared to background parenchyma, the lesion will be darker or hypo-enhancing. So if there is washout, that means it is stamped as malignant. If there is sustained enhancement or no washout, you will stamp it as benign. Okay, then we'll go to further characterization. So once you have identified the lesion and it is showing washout, that means it is malignant, then you can go ahead to differentiate between non-hepatocellular malignancy and hepatocellular malignancy. As I have told you earlier, the 60-second image is very important. So that is important to differentiate non-hepatocellular from a hepatocellular malignancy. So the first is timing, 60 seconds, second is intensity. I will show you with examples, then you will understand. Just to follow, if the washout is slow, that means beyond 60 seconds, and you are still able to see low level internal echoes within. So there is washout, the washout is late, and there is low level internal echoes present within. That is mild washout. It suggests it is a hepatocellular carcinoma. However, if the washout is early and the washout is very intense, that means a punched or dark appearance, it suggests as a non-hepatocellular malignancy. So non-hepatocellular malignancy can be cholangio, METS or lymphoma. You cannot differentiate these three, but you can write it as a non-hepatocellular malignancy. Okay, so this part is covered. Now coming to the benign part, that means where you will tell benign, when there is no washout or there is sustained enhancement, it is benign. So for benign, you already know how a hemangioma looks on CT, similar appearance, that is peripheral nodular with gradual centripetal filling. When the enhancement will be from center to periphery, that is centrifugal, that indicates it's as a FNH, and adenoma will show centripetal from periphery to center, enhancement. So it becomes difficult sometimes to differentiate adenoma from hepatocellular malignancy on CT and MR, but on contrast ultrasound you can clearly tell that it is a adenoma. So from periphery to center enhancement is adenoma, from center to periphery is FNH, peripheral nodular with centripetal fill-in is hemangioma. So we'll come up with examples, then we can understand it better. So again, I'll just revise you. Washout of liver lesion in the portovenous phase is highly predictive of what? Malignant tumor, benign tumor, lesion of hepatocyte origin, lesion of non-hepatocyte origin, or liver abscess. What is the answer? Washout in the portovenous phase is highly predictive of a malignant tumor. Okay, that should be always in your mind. Okay, so what is washout? So when I say washout means it depends on vascular characteristics of the lesion and hemodynamics of the liver. So in previous studies it has been seen that washout occurs in 97% of malignant lesions and 37% of benign lesions also show washout. And of the benign lesions that show washout, many exhibit characteristics of arterial phase enhancement that is very characteristic to them, like a hemangioma or a FNH or a adenoma. Okay, so again I'll revise the algorithm. Portovenous phase or late phase is the first step that you need to see, and the second is timing and intensity of washout of malignant lesions. So you ignore these first two phases, you see this image. This image is portovenous phase at 34 seconds and this image is portovenous phase at 4 minutes. Okay, so at 34 seconds there is washout, so that means you are able to see there is, as compared to background parenchyma, there is washout of the lesion, and the lesion is washing out before 60 seconds and the washout is very dark. So you are not able to see any low level internal echoes. As you can able to see some low level internal echoes in this image, here you cannot see any low level internal echoes, rather it is a punched out appearance, a hole. So how you label it? You see the portovenous phase, so you label it as a malignant lesion, and you are able to see washout that is early and very dark, so this is a non-hepatocellular malignancy. Okay, as compared to this, if you see the portovenous phase image at 4 minutes as compared to the background parenchyma, you are able to see homogeneous enhancement of this lesion. So there is no washout or there is sustained enhancement, so you label it as benign. So it is a benign lesion. Okay, so this corresponding arterial phase is not so much contributing. You need to see the portovenous phase. Okay, then I'll come to a routine case, that is arterial enhancing lesion well encapsulated in arterial phase showing washout in the portovenous phase. So this is a classic HCC. This is also similar in contrast enhanced ultrasound, but what is important is the washout is mild. Why I am calling it mild? Because there is some low level internal echo still seen within, as opposed to a non-hepatocellular malignancy which is showing complete dark punched out appearance. So at 3 minutes, this is the portal venous phase image. So as compared to the background parenchyma, there is washout. So I label it as malignant, and the washout that has occurred is mild, first point, that is intensity. And timing is, it has washed out at around 2 minutes. So as per our algorithm, this will be a HCC. Okay. Okay. Then next case. So this is a young patient, 33 years, with a exophytic liver lesion. Okay. So CT, you can easily identify there is arterial enhancement with no washout, and there is a scar. So if you see on contrast enhanced ultrasound, you have performed the contrast enhanced ultrasound, and this is the portovenous phase image at 2 minutes. So as compared to the background parenchyma, there is sustained enhancement. So it is a benign or a malignant lesion? It's a benign lesion. So it's a benign lesion, and in arterial phase it is showing homogeneous enhancement, and there is a central scar. Okay, so this is a FNH. I'll show you how FNH, centripetal enhancement of FNH in subsequent slides. So again, I'll come to the next question. Timing of washout of a liver lesion helps to differentiate what? Sarcoma from hemangioendothelioma, peripheral cholangio versus metastasis, hyper versus hypovascular metastasis, non-hepatocyte versus HCC. Yes, the answer is D. That is non-hepatocyte malignancy from a hepatocellular carcinoma. Okay, so timing of washout is very important. Timing and intensity. I'll again repeat. Okay, so what is timing? So when the lesion begins to fade compared to the enhancement of the background liver parenchyma, you have already seen. And what is intensity? Relative difference in enhancement between a lesion and adjacent background parenchyma. So your washout can be weak washout, that is low level echos, which occurs in hepatocellular carcinoma, or marked washout, that is black or punched out whole appearance, that occurs in non-hepatocellular malignancy. Okay, so non-hepatocellular malignancy will show rapid and strong washout, that is dark punched out appearance, whereas hepatocellular malignancies will show weak, less intense washout, that is a faded appearance. Okay, so washout intensity may change with time. Okay, so beginning initially as weak washout and then gradually becoming more marked. So if this change is quite rapid, within 1 to 2 minutes after injection, you are seeing a marked washout beyond 1 minute, up to 2 minutes is the cutoff. Then you label it as non-hepatocellular malignancy. You can extend it to up to 2 minutes in some cases. However, if the change in intensity occurs slowly, for example at 3 or more minutes, then it will be classified as weak washout. So weak washout is in hepatocellular malignancy. I'll show you examples. So there are certain exceptions. Although HCC is typically slow and weak washout, some HCCs, particularly poorly differentiated, may show a washout before 1 minute, but this washout will be mild, definitely will be mild, never will be strong washout. Okay, hypervascular metastasis, particularly from neuroendocrine tumors, there are a non-hepatocellular malignancy that may show slower washout. Even if they show slower washout, but the washout will be strong. So both things you have to see, that is timing as well as intensity. Okay, so again it is very important to know the patient history, risk factors, oncologic history, and combine it with your ultrasound findings before giving a report. Okay, so you see what is the importance of timing and intensity I will show. So again this is a repetition, this is 40-second phase. What you are seeing is the background, as compared to the background parenchyma, there is dark appearance of the lesion, and it is showing strong washout and early washout. So what it indicates is non-hepatocellular malignancy. Whatever be the arterial phase, be it homogeneous enhancement, rim enhancement, or no enhancement, but this stamps it as a non-hepatocellular malignancy and a non-hepatocellular malignancy. Similarly, 83-year-old female patient with a liver lesion, at 3 minutes you are able to see a hypo-enhancing lesion as compared to the background parenchyma, and this washout is weak washout and slow washout. That is 3 minutes you are able to see this feature. So this indicates washout means malignancy, and weak washout means a hepatocellular malignancy. Okay. Then arterial phase enhancement patterns of malignant lesions. So I'll just remember that arterial phase enhancement patterns of malignant lesions doesn't matter at all in your reporting. So forget about arterial phase enhancement patterns of malignant lesions. This arterial enhancement can be homogeneous, can be basket weave in HCCs, but these are non-diagnostic. These are not contributory to your liver lesion characterization. Okay, so coming to non-hepatocellular malignancy, you cannot differentiate between metastasis, cholangio and lymphoma. So your report will be non-hepatocellular malignancy as per our algorithm. You cannot differentiate these three. Okay, again their arterial enhancement can be homogeneous, can be hypo or rim enhancement, but the characteristic feature is intense washout and early washout. Okay. Okay, so take home points from these slides are: washout means malignancy, late and weak means hepatocellular carcinoma, early and strong means non-hepatocellular malignancy. So this should be in your mind clearly. Coming to HCC, this case, this is a background liver, you see it's not quite cirrhotic. This is a focal liver lesion in a chronic hepatitis B patient. So in a chronic hepatitis B patient with this lesion, you will always have a suspicion of HCC. So you can see in the arterial phase it is showing homogeneous, means initial 10 to 20 seconds it is showing homogeneous enhancement. At 30 seconds, 40 seconds, it is still showing enhancement, no washout. So at around 2 minutes, you are able to see a washout. So our lesion evaluation should not start here. Our lesion evaluation will start from the last image. We'll go from back to front. So in this image, we are able to see washout, and the washout is at 3 minutes. So washout is also weak washout, so some low level internal echoes we are able to see. So then we can label it as a hepatocellular carcinoma. Okay. Then another patient with a hypoechoic liver lesion on grayscale. Again this is showing arterial enhancement, homogeneous arterial enhancement. At around 2 minutes there is still no washout. At around 3 minutes we are able to see there is washout, and the washout is weak. So what indicates washout, weak washout at 3 minutes, classical HCC. Okay, so this is again a 55-year-old patient with brain tumor with a partially exophatic liver lesion which is enhancing. Okay, so how to characterize this lesion? Then this patient, and why contrast enhanced ultrasound was done? So you don't want the patient to, so this is a single portovenous phase, single phase imaging was done. So you don't want to expose the patient again to radiation and contrast for characterizing. So you can easily take, ask for a sono, that is contrast enhanced ultrasound, where you can see there is peripheral nodular enhancement and there is gradual centripetal fill-in and there is incomplete fill-in later on. So what does this indicate? In your regular CT and MR, you are able to see this pattern, that is peripheral nodular flame-like enhancement with centripetal fill-in. So this indicates hemangioma. So this enhancement characteristic actually is representative of hemangioma. So hemangioma is easy to pick up. So arterial phase enhancement patterns of benign lesions are common benign hepatic lesions. These are typical and reproducible arterial enhancement patterns. Okay, these patterns are easily recognizable and highly suggestive of specific diagnosis. So for malignant lesions, arterial enhancement is not characteristic. For benign lesions, the arterial enhancement is characteristic. Okay, so coming to hemangioma. You already know regarding hemangioma, so I will not explain much. So what is bubble track imaging? So what bubble track imaging contributes most to the differentiation of is METS versus HCC, adenoma versus HCC, FNH versus adenoma, peripheral cholangio versus METS. So I'll explain this. So what is bubble track imaging? So bubble track imaging is basically you see how the bubbles are filling up from center to periphery, periphery to center. So you cannot image this quite well in CT and MR, but in contrast ultrasound you can easily image it. You can see the enhancement is from center to periphery, okay, from center to periphery. You see in this image also it's from center to periphery. So centrifugal. Okay, so this indicates it's a young asymptomatic female, hypervascular mass, FNH versus adenoma. So you identify the direction of filling and you identify the vessel morphology. So what it is, centrifugal FNH. So FNH is the second most benign tumor. I will not go into the details. So bubble track technique is important, how the pattern in bubble track stamps it as FNH. So adenoma as opposed, adenoma is uncommon benign hepatic tumor, most common in women and steroid users. You have several subtypes, inflammatory, HNF alpha mutated. So most common is this inflammatory adenoma, and the classic arterial phase enhancement patterns of hepatic adenomas begins peripherally with rapid filling from the periphery towards center. So this is the case of hepatic hemangioma, and the last one is hepatic adenoma from periphery to center. This fills up. I don't have a representative image, but adenoma fills up from periphery to center. Okay, so portal venous phase and late phase enhancement of benign lesion. You already know this sustained enhancement. So sustained enhancement means benign lesion. So we'll and again there are variations. You already know this. Hepatic hemangioma can have incomplete filling. This incomplete filling is because of internal thrombosis and hyalinization, and if if washout is shown after a classic arterial phase pattern for hemangioma, the washout is generally slow and weak. So if you know it's hemangioma and it's still showing slow and weak washout, it is acceptable. Beyond 3-4 minutes, it is acceptable. So I'll skip these slides. These are not important. So again, what is the difference between contrast ultrasound and CT and MR imaging? So contrast enhanced ultrasound is a dynamic real-time imaging technique that can demonstrate enhancement regardless of the timing or duration of enhancement. For example, a flash filling hemangioma. The one that you are calling a flash filling hemangioma on CT, you can clearly see the peripheral nodular enhancement on contrast enhanced ultrasound. Entirely intravascular nature of the microbubbles. That is the main difference between contrast enhanced ultrasound and contrast enhanced CT and MRI. So what will happen is in a cholangiocarcinoma case, where on CT you see progressive sustained enhancement, in contrast enhanced ultrasound you will see a punched out appearance, because in contrast enhanced ultrasound everything is purely intravascular. The bubbles are intravascular, they are not going or moving out into the extravascular space. However, because this is a tumor having fibrotic component, the contrast is extravasating out of the cells and is responsible for this sustained enhancement in the delayed phase. So this is the arterial phase. It is not enhancing. Subsequently, portal venous phase it is enhancing, and in delayed phase it is showing a sustained enhancement. This is a classic cholangiocarcinoma that you routinely report. However, as opposed, in contrast enhanced ultrasound, same image, same patient, same lesion will show sustained washout because of pure intravascular nature of the microbubble. Okay, so this is a flash filling hemangioma that you label it on CT and MR. However, you can see the peripheral nodular enhancement on contrast enhanced ultrasound because you are utilizing the bubble track. You are dynamically seeing from time 0, so you are able to see this peripheral nodular enhancement. Okay, so you can also see liver abscesses, not important. It is extended to pancreas, pancreatic lesion evaluation, cysts, renal cysts, but these are not established applications. So I've covered the diagnostic part. I will show some IR applications. So while doing guided procedures, so you usually target a necrotic lesion. So without a contrast ultrasound, what we do is we target a periphery of the lesion. So usually the periphery has viable tumors and the center has necrotic. So if you do a biopsy from this necrotic component, your biopsy may turn out to be negative. So usually on ultrasound, we do guess and target the periphery of the lesion. So what you can do is do a contrast enhanced ultrasound. You can clearly see the necrotic component of the tumor, and this is the viable tumor, and then you can target it. This viable component you can target. So your biopsy yield will be more successful. Okay. So for post-test evaluation also, we can use this application, that is contrast enhanced ultrasound. So this patient, this is a large 8 centimeter tumor that we performed tests. After performing tests, so you can see this is the regular grayscale image, and this is the contrast enhanced ultrasound image. So this image is not without any contrast injection. So you can see barely you are able to make out anything. So your image should have both these. So once you press the color Doppler ultrasound, both these images will come side by side. You don't have to do anything. So you focus using the grayscale and evaluate using the color Doppler screen. So once we have injected contrast in the, you can see this necrotic part of the tumor, that is because of the transarterial chemoembolization we have performed. This has got necrosed. However, this periphery of the lesion is showing some arterial enhancement. Okay, and as we go subsequently to the 3-minute time, we can see there is washout as compared to the background parenchyma. This part is showing some washout. So this is the residual lesion. So rather than doing a CT or MR to see the follow-up, you can do a contrast enhanced ultrasound. So contrast enhanced ultrasound saves the patient from radiation, from contrast, and it makes your evaluation also easier. Okay. So similarly, we also extend it for microwave ablation. So this is the arterial enhancing lesion showing washout. So this is a HCC that we have performed microwave ablation. So yesterday there was a talk on RFA. So we didn't perform a RFA here because this lesion is encased by vessels all around. So the RFA can have, and in such lesions we prefer to go for microwave which has less heat sink. So heat sink means the heat will get dissipated into the vessels, large diameter vessels, and the ablation in this area will be inadequate. So we performed microwave ablation. After performing microwave ablation, you can see this lesion appears echogenic. Then we did contrast ultrasound after 1 month. So you can see gradually the bubbles, the portal vein filling up. These are the micro bubbles and background lesion, and you can see the lesion now clearly. That there is no arterial enhancement or even washout. So this was complete response at 1 month. Okay. Even at 6 months, the lesion didn't show any arterial enhancement, so it was a complete response. Okay. So we extend our contrast enhanced ultrasound while doing interventions. Like I have told you, the first generation agent was agitated saline. That was the first agent that was used. So this was a case of prostatic arterial embolization that we were doing. So you have seen on ultrasound prostates, you can identify. So same way we do, what we do is we hook the internal iliac artery and go for the prostatic artery. So prostate is supplied by 2 arteries, paired arteries. This is the left hemiprostate. This is the prostate artery supplying it, and this is the right hemiprostate, and this is the right side prostatic artery supplying the right hemiprostate. So what happens is there are smaller arteries that also supply the rectum in this area. So very difficult to identify unless you have a cone beam CT. So what we did is we injected agitated saline. You can see this is the prostate, and this half is not echogenic and this half is echogenic. So that means the contrast, the agitated saline we had used here. So that means we are in the right place. Now we can start performing the embolization without the fear of embolizing the superior rectal artery. So this is the video, I think. So you see this half of the prostate is not echogenic, whereas the other half was echogenic. That means we have hooked the right prostatic artery, and now we are performing embolization. So this is a sonazoid contrast enhanced ultrasound. So you can see there are 3 phases. This pair is first phase, this pair is second phase, and this pair is the Kupfer phase. So in the initial arterial phase, you can see this lesion is showing arterial enhancement, and this is showing some low level washout. And in Kupfer phase also you are able to see washout. So what is the advantage of using sonazoid is because you are getting 10 to 15 minutes. Otherwise SonoView would have vanished in 4 to 5 minutes. So with sonazoid, you have 10 to 15 minutes in your time in your hand to perform the ablation. So since the arterial enhancing component was here, this is the microwave needle track that you are seeing. So microwave needle was placed in this portion of the tumor and ablation was done. Okay, so post ablation you can see there is no enhancement of the tumor. However, there was some peripheral nodular enhancement. That means there was some residual or recurrence that was left behind. So this is how sonazoid is used to assist us in better tumor ablation. Okay, so hope I have shown this, you are clear regarding sonazoid. So the 2 advantages with sonazoid, one is your timing of evaluation, you will get a longer time, 10 to 15 minutes, because Kupfer phase is at 10 to 15 minutes, and you can clearly say that it's a HCC with Kupfer phase imaging. Okay, so there are several other applications also, like I told you, like in voiding cystourethograms you can perform using sono voiding cystograms you can perform for VUR grading. Coming to safety profile, ultrasound contrast agents are excreted by lungs and after the destruction of bubbles. So, and it is completely renal safe. It doesn't have any iodine, so it doesn't affect the thyroid functions. And very rare hypersensitivity reactions is possible, 0.002%. And the contraindications are acute coronary syndrome, right to left shunt, severe pulmonary hypertension, uncontrolled systemic hypertension, ARDS. For pregnant patients, it is not recommended to use. However, in animal studies, it has been seen that it is completely safe. For children, it is allowed to use. It is recommended. Recommendation is there. You can use in children for voiding cystourethograms. Okay, and for breastfeeding mothers, 2 to 3 hours gap can be given. Thereafter, breastfeeding can be started because these agents are not excreted in breast milk. Okay, so there are certain other applications. I'll just finish. So contrast enhanced ultrasound is highly sensitive in detection of microvascularity. It's a real-time image, high temporal and spatial resolution. It has a better diagnostic performance than conventional grayscale ultrasound and an accuracy similar to CT and MR. And the advantages are no radiation exposure, no nephrotoxicity, and contrast enhanced ultrasound should be widely used as a first line or problem solving tool, particularly for patients with kidney disorders. Thank you. So we'll continue with our live demonstration of fetal TIFA.
That light, green light has come on. Green light has come on. Just clip it here. We can clip it also. Easier, I think, just to clip it to the belt. Okay, right, it's audible. Fine. So, good afternoon, everybody. Audible? Now audible, na? All right, fine. So, till they get the video going, we can start with the audio part, which is that TIFA is not just taking some few images. It is not just taking some extra measurements. TIFA is a completely different process of thinking. It involves starting with one, observing the patient characteristics so that you can compare with what the fetus has, taking a history. For example, today we have this 30-year-old, I already taken the history, gravida 1. At 30 gravida 1, then gestation was with ovulation induction, right? So already we have extra information. We have information that ovulation induction, any sort of assisted reproductive techniques any sort of assisted reproductive techniques, the incidence of anomalies, the incidence of growth restriction, everything goes up, right? So first thing is looking at the patient, second thing is having a basic history and whether there are, what is the gravida, para, were there any early abortions earlier, were there any ectopics, were there were any earlier pregnancies in which there were anomalies, whether there was growth restriction, earlier pregnancies with hypertension, diabetes. So all these things we have to know, right? So let us take a look at this fetus. So initially when starting, first thing we do is we do an overview, right? Start from the adnexa. Look at the uterine wall. What is the thickness? Where is the placenta? What is the placental grade? Where is the cord inserted? So all these things are very important things which are not normally noted by many people. How is the cord insertion, right? What is the Leica volume? Does it look okay? If it is increased, why we look at it in the beginning? If it is oligo, then our thinking is going to be along certain lines. If it is poly, then your thinking is going to be, you are going to search specifically for conditions. If there is a polyhydramnios, I will generally take a look at the second look at the spine. We will take a second look at facial anomalies, right? So there are a lot of things which we have to go through with these things. So the history right at the beginning followed by an overview becomes very, very important. So then the next thing that we can do is to take a Doppler, uterine artery. In TIFA, uterine artery Doppler, normally we would do 1 centimeter beyond the crossing, but here we are going to go a little early. You know why? There is already a branch here. Once there is a branch coming up, we have to go a little more proximal to that branch and then do the uterine artery Doppler there. So we increase the scale to adjust and bring the baseline down to adjust. This is the right side, then to the left side similarly. Again look at the uterine artery. It's very easy to do a uterine artery Doppler because even in first trimester, while doing the NT scan itself, you should do the uterine artery Doppler as a screening for PIH, small for gestational age. Uterine arteries can show pretty good results if it is combined with other paramaternal parameters. As an isolated finding, using only uterine artery for screening is not very good results wise. It is hardly about 40% pickup rate with a lot of false positives. So while doing, please use the Samrakshan methodology, which uses things like maternal BP, maternal height, weight, etc. So from there Once we had this overview and we have seen the placenta, we have looked at the uterines. Now the cervix is obscured, otherwise we would take a look at the cervix now. The cranium is obscuring the cervix. If this is the case, then the only option will be to do a TVS. Now, obviously we cannot be doing TVS now. So let us start with cranium. We have to go systematically. Right? First thing, let us look at the cranium. Cranium, what are the sections that we have to do? One is this, what has been called as the transthalamic section, the BPD, right? Now, is this correct? No. Why? You are seeing part of the cerebellum here. So this is not a correct section. So do not do the measurement here. For documentation, if you want, you can use that. But the correct section would be this, which does not include the cerebellum, right? Midline echo should be seen, and very, very important is to look at the CSP. The CSP length should be more than the width. If it is the other way around or it appears equal, start taking a closer look at the corpus callosum. That is the meaning. So it is not just looking at some sections. What to look for in those sections? We also have to check the calvarium. How is the ossification? If the near field is very beautifully seen, be very careful. Then probably ossification is not correct. There is an ossification issue. From there, one easy way is just to slide it a little up and look at the lateral ventricle, right? Seeing one lateral ventricle is not sufficient. We have to angle and see. Now, usually the proximal lateral ventricle will not be visualized until you angle it like this. So, what we have to do is, from the horizontal, you will not be able to see because of reverberation artifacts here. So what we have to do is, we have to go at an angle of say something like this, 20-30 degrees angle, right? Bring the transducer here posteriorly. Through this thin bone, you will be able to visualize the other lateral ventricle, because ventriculomegaly can be unilateral. There can be a bleed or a dilated unilateral ventriculomegaly, and other periventricular changes can be there unilaterally. So we cannot assume that looking at one will give us is sufficient. That assumption should not be made. We should look at both the sides. So again, from the transthalamic section, all we have to do is angle. Again the same problem. Now if you see shadowing. So again, for the cerebellum, going at a 15-20 degree angle off the mid from horizontal. Now for transthalamic section, horizontal. After transthalamic section, lateral ventricles. Then here again you should be able to see the CSP. The CSP should be seen, midline echo should be seen, and you should be able to see the cerebellar hemispheres. It is not just looking at only cerebellar hemispheres, right? The continuity, the posteriorly, this continuity should be maintained, the cerebellum. There should not be a gap here between this and the fourth ventricle. Plus, the central area, if you observe here, you will be able to see that this area is echogenic. This is the vermis. So the cerebellar hemispheres seen separately, and the vermis and the continuity of the posterior aspect of that cerebellum. See? And because this is a little more advanced gestational age, you are also able to see the cerebellar foliae. See these transverse lines? Cerebellar foliae are also seen. Both sides are equal in size, look of eye. There are no focal lesions, no hypoechoic, no cysts, nothing. In this section also we will be able to see this cisterna magna. So continuity is there, cisterna magna size is normal, nuchal fold can be assessed, but if you have done an NT scan, then the nuchal fold has no value. So from the cranium, rest of this CNS. While observing for the CN, for the spine, it is best to start from the occipit, not from spine itself. See what happens generally when you are doing, what are we doing? We are coming up to here, right? Longitudinally, if you look, your section would have gone somewhere here. If you start the spine from here, transverse section, then you are leaving one gap here which you are not examining. So I always tell all my students, start from occipit and then go down while looking at the spine. So slide down, axial view, look at the spine, entire spine, axial, all the way down to, no, not sacrum. Some people said sacrum. No, it's not sacrum. From sacrum, go further down, go right down to perineum. Okay? All your textbooks, everything say, go down to sacrum. That is not sufficient. I go beyond. Why? Okay, in a section here, now you are looking at the sacrum, right? Here is the sacrum. You have the sacrum nicely seen here. If you take a section only up to here, this area, then what you are doing is, you are leaving a gap here. This area is not visualized in any section. You have not done it in the axial, you have not done it in the longitudinal. So what happens if there is a lesion that points out from here and comes down, you can have meningocele coming down instead of going backwards. You will totally miss it. Whereas just by extending it for a couple of seconds, you are extending it on the axial section here down to perineum, you will never miss it. You will never miss anything. So after the axial sweep, you should look at the entire spine and be able to demonstrate this. We should be able to demonstrate that the sacrum is present. So the sacral tilt, this part becomes a little narrow, rest of the spine is all parallel. Here it becomes narrow and has a small up tilt. This degree of up tilt can vary from baby to baby, but some degree of up tilt will always be there and it will always be narrow. So this we know now for sure is sacrum. Very, very important. Sacral agenesis was completely missed by one radiologist in Karnataka, and there is a case now going against. There was actually a pointer there. If that doctor had taken, that radiologist had taken a history, he would have known that the patient was actually a diabetic. Okay? So that's a pointer, that one of the risk factors for sacral agenesis. So what are the things? We have demonstrated the entire spine, right? And if you observe, even the cord is seen. If you go right in between, so we should be able to demonstrate the skin continuity. But demonstrating this only in the sag is not sufficient, because there can be off-axis meningoceles coming out. That is why this axial sweep is very, very important. Here what happens? We are looking only at this narrow area, but there can be meningoceles that come out on the side. If you don't want to miss that, you have to do a axial like this. After the axial, mid-sag. From the mid-sag, the entire sweep from above to below. Now there is a way to save time. Combine multiple organs in one sweep. Now this sweep anyway you are doing. So immediately after that, go to the left, right? So you have the left kidney, and from there you have the right kidney. Just sweep to the right. Then come to the right again, come a little higher. You come a little higher, you are able to see the diaphragm. See the right diaphragm, liver, correct? Same way, just sweep over to the left and you will be able to see the left diaphragm and the stomach below the diaphragm. We have demonstrated that there is no diaphragmatic hernia here. It's all in one sweep, isn't it? Then come a little more higher up and angle medially, come to the mid-sag, slide to the left, angle towards midline, you will be able to see the arch of the aorta. In the same way, come to the regular mid-sag which you do for the spine, move to the right, slide to the right and angle medially, you will get the SVC and IVC, see the bicaval section, right? So all this you can get in just one section. Then come a little higher angle, you will be able to see the ear. At least one ear has to be demonstrated in a TIFA, right? Now see, you can see the ear. This is the right ear. So the right ear, go over furthermore, if the fetal position allows, you will be able to see the other ear. Now here what you are seeing is a lot of hair, but you are not seeing the hair, and you are seeing one cord there, right? This is a lot of hair at the occipital level. The other ear is probably around here, but you are not able to demonstrate properly. If you are not able to demonstrate, just note that you have seen right ear, and that right ear is normal. At least one ear to be demonstrated is the protocol for TIFA. So if you look at it, see the number of things that we have seen. One sweep, we have gone from here, you have seen the entire spine, right? You have seen the left kidney, you have seen the right kidney, you have seen the right diaphragm, you have seen the left diaphragm, you have seen the aortic arch, and you come back here and you have seen the SVC, IVC, and you have seen the ears. Lot of things we have covered. And while doing the chest, you should also observe not just the arches, but also the lungs. So this is a very good way to get a good overview of the lungs. Two things you can look at the lungs. Lungs are not specifically mentioned in most of the guidelines. That is why many of the lung lesions are missed. But if you use this technique, and also while studying the cardia, that is another opportunity to look at the lungs. You will not miss anything. So we have finished with this spine. We have looked at another group, which was the lungs. So next we move on. Take a look at the abdomen. In the abdomen, first of course is what? AC. You want a good AC, isn't it? Very, very important to get a good AC. Observe the umbilical vein. This should not go all the way to the anterior abdominal wall. Now if you are taking a section like this, where it has gone all the way, it means you are oblique. You will not be able to see the cord insertion if it is a correct transverse section. So here what will happen, if you take this as a AC, then you will be overestimating. And if you observe properly, because it is an oblique section, you will get a AC which is more than what it actually is. If you observe here, you are actually seeing the diaphragms. So this is lung. This is no longer the abdomen. So what you have to do is come at the level of suprarenals. Now you should not use kidney also. So this is suprarenal, right? So you have the suprarenal here. Take at that level, you will be fairly safe. You will get a good abdomen circumference. Very, very important for fetal weight estimation. So at this time, what all do we observe? We also look at the stomach. Not just looking at the, and which side is it curving to? It should curve away from the stomach. If it curves towards the stomach and is coming from the right side, persistent right curving. That's all. There's nothing much. It's all very simple. It's like arithmetic. Okay. The other thing that you can observe is, because for situs nowadays it's not just looking at the side of the stomach. You are also looking at the gallbladder, which is contracted here. Earlier we saw it once when we saw. You are seeing one small gallbladder here. Baby has probably had food. Along with that, you also have to look at aorta and IVC, the relative positions of the aorta and the IVC. Right? No need for Doppler actually, but you have any doubt whether is it really a vessel or not. You have any doubt, you can use that. Right? Aorta, IVC. IVC should be anterior and to right. Aorta will be just to the left of middle. Throughout its course, aorta is just to left of, right from thoracic region. It is slightly to the left of midline, as evidenced by its relationship with the vertebral body. Anterior and to right of that will be the IVC. So from there, sweep down, and though it's not necessary, it is very easy when you have the Doppler. Just switch on 3-vessel cord, done. Right? What is there? Nothing. Do we really require Doppler for this? The answer is no. You don't actually require present time machines. You can actually see the pulsations themselves directly. Okay, now if you zoom properly, see here, you can see the pulsations, umbilical artery pulsations. Of course, the easier way, quicker way, time saving way is look at Doppler, very easy. 1 second it's over. Anybody wanting to, you can go down and look at the perineal complex. See, you just come right down to the perineum, you will be able to see the rectum, right? You can see this very easily. So high anal anomalies are ruled out if you get this. Low anal anomalies are like ectopic insertion of anus and all are still not ruled out. See this, right? You can even do a longitudinal, it's very easy. If you practice, it's very easy. Just come to the bladder, slide a little posteriorly, you will actually able to trace it right to the skin. Now, even low anal anomalies are ruled out because you have a anus opening which you have demonstrated all the way down. This is the way. This may not be very easy but it's at around 18 weeks it's not all that easy. But after 20 weeks, if the liquor is okay, this is very easy. It just requires some sweep. There is nothing in that. All you have to do is what? Slide down. Anyway, you are looking at the bladder. You are anyway going to take a look at the umbilical cord. It hardly takes another few seconds. Slide down and make it a habit to look at this. And you ruled out one more anomaly. Not very common as an isolated abnormality, but still. And as you come up, in the same sweep, look at the cord insertion. Is there any omphalocele? So omphalocele, you have two ways to look at it. One is axial like this, the other is in the longitudinal. Okay, you can take a look in the longitudinal like this, correct? You have the cord insertion here, umbilical vein going up. Out of the two, axial versus longitudinal, this is a better view to demonstrate. The reason is small omphalocele are known to come superiorly only here in this region. So if you take a section lower down in the axial, you may totally miss a small omphalocele, but here you are not going to miss it. So longitudinal is better. So how to tell? Very easy. This should always be anechoic. Anything echogenic is there, call it omphalocele, finished, because there is nothing else that can come there. Very easy. Anything echogenic there, and it's just a sweep. It is not at all difficult. And now, recently we have been finding more and more ductus venosus abnormalities. So just switch on the Doppler, you will see the typical aliasing immediately. Very simple. Is it in its normal position? Yes, no, that's all. We are not even bothered whether there is a wave reversal or what for the normal liquor during TIFA. So all you need to do is switch on your Doppler here and demonstrate the aliasing, that's all. You don't have to do anything else, right? See, ductus venosus is there, short wave vein connecting. See this connection, very easy, very simple. Where it turns, take a look at it. It should be somewhere here. If it is too far posterior, take a second look. It may be going into the IVC. If it takes any other course, there is an abnormality. Start checking where it is going. So all this, how long does it take again? Let us see. Right? We are starting. Okay, AC. We have seen AC, right? We have gone down, right? Then we look at the 3 vessel cord, done. Switch off. Anus, yes, done. Cord insertion, done, yes. You come up, right? Switch on, and you have the, right? Finished. Now, how long did that sweep actually take? Hardly about a minute, correct? So it actually does not take as much time as people think it does. That is a myth that TIFA takes a long time. No, TIFA doesn't take a very long time. We have to be quick. We have to do things systematically. So immediately after that, we have to look at the limbs, right? The next one is what? Femur. While measurement, any doubt is there? Now, see, this common mistake that is made is in the measurement to include this. Spur artifact, do not include this. Shaft, you have to start from shaft, mid. It is not on the surface, it is not inferior, it has to be at the end. And this is where certain advantages are there. If you look at the left bottom of the screen, there is one zoom thing going on, right at the bottom. Very helpful. Samsung has patented this, and unfortunately they are not allowing other companies to use. Unfortunately for us, it has. Fortunately for them, there. Okay, because that's very useful, because you know exactly where you are placing, especially NT and measurements when you are doing. Now look at that. You are seeing the lower end of the bone. You know exactly where you are going. Otherwise, look at the big screen, bigger end. You don't know where you are exactly. Here we are perfectly sure where you are going. So your accuracy increases as far as measurements goes. Right? So FL should be mid shaft, end to end. Samsung people won't like. I am questioning why they have patented it. Right? See, also whenever you are looking at the limbs, just make it a habit to take a look at the soft tissue surrounding it. Right? So we have come down to the knee. From the knee, what? We are next looking at tibia, fibula, right? So we have finished the femur, and just one more point. If there is any doubt that you have, one thing you can do is you can switch off all this multi-vision. Yeah, you will get a better view of the bone. You still have a doubt. Other shortcut is usually go to the echo setting. That they would have removed all the things, and it becomes very easy to. Okay, see, now only bone is seen nicely. The contrast setting, this is a high contrast setting. There is a shortcut. If you have any problem with bones, one shortcut is to look at it in the high contrast setting, like in the fetal echo. Okay. So from this thing, you come next to the leg. In the leg, what? Tibia and fibula. So which is tibia, which is fibula? Very simple. Medial, lateral. Unlike in upper limb, we don't have a problem. This must be tibia, this must be fibula. There is no other choice. So from there, immediately after that, the things to demonstrate is the leg foot angle. Is the leg foot angle something like near 90 degrees? If the answer is yes, you can move on to other things. So leg foot angle nearing 90 degrees. And one more examination of the foot that has to be done is this one, the axial, right? Is it necessary to count toes? The answer is no. There is no protocol which says that you have to. If you want to, or if there are other abnormalities, like say there is some cardiac abnormality, or thinking of a syndrome, or there is skeletal abnormality, yes, then you can count toes and fingers, but otherwise, by and large, just a quick look like this is sufficient. See, great toe. Some amount of overlap is there, that is normal. So looking at the axial section of both sides. So once we have seen the lower limbs, overview, always take an overview and what is the position and how are the movements. Now, rule of thumb in movement of joints is suppose arthrogryphosis you are suspecting. The distal most joint, if it moves well, the proximal ones you need not evaluate. Everything proximal to that will always be normal. Right? So from there we move on to upper limb. Same thing as just like what you did for the lower limb. Look at the humerus, observe the soft tissues also. Measurement is exactly the same, and all long bones, if there is any doubt about the length, doing it at about 10 to 15 degrees off angle like this, rather than completely horizontal, you will give you more exact results many times. Those artifacts, spur artifacts are much less when you are doing at a 10-15 degree angle. And there are studies to support this. There are at least 2 studies that I know of which have shown that this is more accurate. So do the 2 sides, not just one. So after the humerus, move on to elbow and take a look at the radius and ulna. This becomes a little tricky. Why? Radius ulna, there is also an additional movement, that is supination and pronation. So many times what this baby is doing, same thing they will do. What? See, this is not a straight. It has rotated the hand. You look at start from the elbow going down, you can see the two crossing over here. They are at different planes. Once they are at different planes like that, it's very difficult to get a complete longitudinal section of both together. You have to go at a very steep angle. And then you have a doubt, which is radius, which is ulna. Very, very simple. Normally, very simple. When it is abnormal, we have other problems. But normally, since you can't make out medial lateral because of the supination and pronation problem, the distal ends are usually at the same level, but ulna extends more proximally. Very simple. Towards the elbow. What is more towards the elbow? That will be the ulna normally. Again, is it necessary to count fingers? The answer is no. But carpus should be demonstrated. Any scan, any TIFA, any anomaly scan, even not just TIFA, even for a routine anomaly scan, we have to demonstrate at least up to carpus. That is very, very important. So after looking at the upper limb, next we have to take a look at the face, isn't it? In the face, one is this, to look at the nasal bone. What has been stressed so much? Nasal bone, right? Now if you observe here, in the profile of the face, it is not just the nasal bone. See, we have the nose, you have the lips here, right? You have the hard palate, you have the chin. Chin should not be too far posterior or too far anterior. Prognathism, retrognathia, micrognathia, this is a very good section to study that. Continuity of the hard palate in the midline, nasal bone, plus this slope of the forehead. Is there a receding forehead? What is the angle at which the forehead is with the nose? Is this a flat face? Binder. This is the best view to look. It will go vertically down. This nasal bone will start going vertically downwards. In which case you start suspecting, is this a binder? And what I was telling you earlier, now if you observe here, in this fetus, can anybody tell me what is one of the features of the face here? There is one very distinctive feature of the face here. If you can see here, see this nose, see? The lips are prominent. Normally the nose will be a little to the front. Lips will be little more posterior. Here this is more anterior. Why? So is it an abnormality? Are we looking for an anomaly here? The answer is no. Why? It is very simple. If you look at the maternal face, mother has exactly similar features. Right? Correct. So are we surprised? You know, mother is happy. Baby looks like a... So from this mid sag, see that upper lip, correct? You will see even better now. Once that hand goes out of the way, so this should have a rectangular anterior end, and in second trimester you will see it as two lines, not just one. Vomer and hard palate won't have fused, so you will get and this will look like a V pointing backwards. Chin, so the chin is in correct position. Upper lip with very distinctive feature, familial. From there, do a 90-degree rotation. Rotate your transducer 90 degree and you will get this. This is another thing that we have to demonstrate. Looking at the orbit's lengths. Are the lengths clear? Size of the orbits. Can you fit one more orbit in between? That is the rule of thumb. Hypertelorism, hypotelorism, very easy. If you can fit one more orbit in between, then it is normal. All the ratios, everything will be normal. If it is too close together, you cannot fit another orbit in between, start measuring. If it is too far out, again start measuring. Otherwise, generally look of thumb is, just a rule of thumb is sufficient for anomaly scan, but if you are doing a TIFA, you have to measure. So come a little down, from here come a little down, you will be able to see, right? So what is this? Nasal septum. So you have two nostrils. Can you see two nostrils? Yes? No. And can you see the deviated nasal septum? So fetal DNS. So start reporting this. Yes? No. No, of course you are not going to go start reporting. Then ENT people will start asking, every fetus, 13 weeks they will start asking, is there DNS? From there, come a little down, you have the lips. Very important that you look at the lips thoroughly. See, clefts can be in multiple positions. They can be more medial, they can be median, they can be more medial, they can be more lateral. So for documentation, okay, you are taking one section like this and storing, fine. It is demonstrating this part of the lip, upper lip. But we should remember that the lip extends even more here also. Okay? So the entire thing should always be, you should take a sweep. Then if you want to, you can also take an axial view and look at the primary hard palate. Hard palate lesions isolated are almost always missed. But primary is easy to rule out. Now if you take an axial from the nose, now what we have done, look at this, you have the nostrils, you are coming a little down, right? Come a little down, look at this, the incisor teeth, central. So this is intact. You can say that the primary hard palate is intact. You can see the skin on top of that intact. Secondary hard palate is a totally different cup of tea. It is extremely difficult to rule out. Worldwide on screening, the pickup rate is around 0 to 1% for isolated hard palate clefts, right? Detection rate is 0 to 1%. Only higher rates that you will see is from some research papers which have been done in some research institutes where they focus on that and do a special study for that. Other than that, most places isolated hard palate you will not see many detection rates being high. Very nice. See, then in between fetus opens the hand, then we have this, right? You will be able to see the fingers properly. That is, if the fetus obliges us by giving an open hand like this, very nice, very good baby. You see, so cooperative. Everybody please clap and give a big hand to the baby now. He's clapping so. Such a nice, very good baby only. Otherwise, demos are very difficult here. Live demos are on fetus. So what all? We have covered what? Cranium, spine, abdomen, lower limb, upper limb, face, everything over except cardia. Yes. Now cardia again. Is it possible in this section, in this position? Yes or no? Yes or no? No. There is one way, but it's not 100% foolproof. There is a way, but you have to go, instead of apical fourth chamber, you have to go basal fourth chamber. So it makes life very difficult for the operator. Now let us just attempt to see if we can, because, hey, don't want chroma, don't remove the chroma, yeah. Let us see. So if you can get a good basal 4 chamber, this just for demo, okay. Otherwise normally we will wait for the fetus to turn. But if you do get a good basal 4 chamber, almost all the features you can demonstrate. What do you have to demonstrate? 4 chamber. Ninja 4 chamber, it is not just looking at 4 chambers. You also have to offset, has to be demonstrated. Right? There should be an offset and you should be able to see smooth left ventricle, moderator band in the right ventricle. Offset very difficult to demonstrate in any view except the apical 4 chamber. But you come a little higher, we should be able to demonstrate the LVOT. If you angle a bit, right? In this angle it's not all that easy, but sometimes possible, right? Aortoseptal continuity should be seen. Apical is much better than all the other views. We will get the mitral aortic continuity as well as the aortoseptal continuity. So this becomes the LVOT. And I would always encourage all of you, while looking at the cardia, please make it a habit to look at the color. Very, very useful. So many lesions you will be able to pick up only by looking at the color flow. See, you have the 2 inflows. Everything is in reverse because you are looking at 4 chamber instead of apical 4 chamber. This should have been red, but it is blue here. Okay, so mentally correct for that. And what should have been yellow is actually red here, or what should have been blue is actually red here, because LVOT is now facing upwards. We are doing it reverse. From there, come a little higher, right? And you will be able to see the 3 vessel view, right? What is the importance of this 3 vessel view? See, you cannot normally document the crisscross of the LVOT and the RVOT, right? You cannot normally document it. So how, this is a documentation because you are seeing cross section, longitudinal section. If you see longitudinal section of one vessel with the adjacent vessel in cross section, it means they are at 90 degrees to each other. There is no other way you can get that section. So it's a documentation of that. So then come a little higher, you will get 3 vessel trachea. Now why this again is very important is, you are showing that the aorta is complete. There are so many lesions that you can miss if you don't do the 3 vessel and the 3 vessel trachea. Now we have the ductus arteriosus and this becomes the arch of the aorta. This is no longer ascending aorta. At this level, this is the arch of the aorta. So coarctation, if you are checking for, this is the easiest way to screen, but majority of them you will miss anyway, don't worry. Very few are picked up. Coarctation is another one notorious to be missed. If you have seen all this, even this, always check with color also. So many subtle lesions are picked up. Make it a habit. Your eye should get used to this. There should not be any aliasing there. If you practice, it becomes very easy. One thing that is very easily missed is TAP, total anomalous pulmonary venous drainage, which actually while screening in the apical 4 chamber, you should look and see, observe for at least 2 pulmonary veins coming in, at least 2, right? Any 2. At least we should demonstrate. Then you do the biometry and assess and see. Oh, I think it's getting late, no? Yeah, it's getting very late. So let us not wait for other extra views. Tifa is anyway covered. Despite this thing, please give a very big hand to the baby. So very good baby. So thank you, ma. Tell very good to baby. Okay. Good afternoon, everybody. So now we come to the most difficult session for people sitting and listening and people speaking also. Because after very good lunch, everybody is drowsy, including speaker. Yeah, that's why I went to the room and had one strong coffee. Okay. You are from Bangalore. No, Bangalore you have to have coffee every now and then. So now we come to this very, very important topic. Peter, Doppler. Underused. So what do? We look at basics. Now see, going into all the details is not possible in a short time. 20-25 minutes, it's not possible. So what we'll be doing is, we'll, just like earlier, it is basics. Because foundation. No structure will stand without a good foundation. Even the TIFA which I showed you, foundation. The live demo was also foundation. There are a lot more things that you can see in the treatise. We didn't examine the heart palate, right? There are a lot of other things to observe. Want to learn? You come to Bangalore, I will teach you. Okay. So what do we look at? What vessels in the fetus? In a pregnancy, not just fetus. In a pregnancy, what vessels, what is normal? How to do, what protocols to follow? What is the interpretation? So this is all the basics that we are going to cover. More than that, not possible. It will take half a day to cover entire fetal Doppler. So in first trimester, so it starts with first trimester Doppler. Not very early scans at 5 weeks, 6 weeks, unless you're looking at the adnexa for ectopics. Otherwise, that's not a part that's covered. Otherwise, you're starting at the level of the 11 to 14, or 13 plus 6 scan. That is the NT scan. Should no longer be called NT scan. It should be the first trimester anomaly scan. I will speak about that some other day. First trimester anomaly, very much possible. You can do a wonderful job in first trimester. There, what do we do? Basically, uterine artery. Can be TS. Usually, it's TVS. You have a problem, you can go for TVS also, but you should remember that the nomograms are different. You cannot use the same chart for TAS and TVS. The values that you get will be different. Second trimester, same thing. Okay, first. Why are we doing uterine artery? Part of screening for what we spoke about. PIH associated problems. The Samrakshan program. Please start. Odisha needs. You know why? Very high perinatal mortality and maternal mortality in Odisha. Among the southern states, though Karnataka is better than Odisha statistics wise, we are way ahead. Even there, we are behind Kerala, Tamil Nadu. Telangana and Karnataka are the worst performers among the southern states. Among the northern states, worst performers are UP, Bihar, Uttarakhand and Odisha. And entire northeast is bad. Now that's probably because they don't have that many trained personnel. In the second trimester, MCA is done, but only for TAPS when you are doing monochorionic twins. Otherwise, in second trimester, routinely what is done is only uterine artery. Whereas in third trimester, we start looking not only uterine arteries, umbilical MCA. If required, that is, if these are normal, you need not do ductus. But I do routinely, all fetuses I do. It's not necessary, I know it will be normal, but I still do. You know why? Now I become so quick with this that it hardly takes me about 10-15 seconds to do it. For practice. The more you practice, the quicker you become, the lesser time it takes. You can start doing screening for every fetus. The entire Doppler, this whole thing will hardly take a minute or two. Possible only if you practice. There is no alternative to practice. So what are the parameters used? In the uterine artery, you do left, right, and you do the mean PI. Umbilical artery, PI. MCA, PI. Ductus venosus, PI. And you also look for A wave reversal. So it's very simple. However, if you are suspecting fetal anemia, then MCA has another value which you have to look at. The peak systolic velocity, PSV. So in the first trimester, uterine artery, how are we done? Mid-sagittal section, very easy. Empty maternal bladder preferable. Where is the cervical canal? Laterally you move it into paracervical vascular plexus. Switch on color. Immediately you will see on uterine artery, it will be pulsating there, very easy to identify. Where do you see it? Where it turns cranially along the uterine body. This is at the level of the internal os. Identify. You have seen the cervix, you know where the internal os already is. Just go laterally along the same plane, you look at in the eye, you will see where you see the uterine artery, where it's going vertically upwards. At that point, take a pulse Doppler. Over. Before it branches, if there are branches already coming out, go proximally. Every patient is not the same. Why? Because all nomograms are from main uterine artery, not from the branches. Even in second trimester, there are patients where even in third trimester, sometimes you can see. Morning I went to this thing, there was early branching, right? Demonstrate that. Uterine artery, early branching. So what do? We don't go to the usual place. You go proximal to that branch. Same thing on the other side, over. Simple. Transvaginally what? Place in anterior fornix. Same like that. Move it to the paracervical vascular plexus. Same thing. You are already seeing where is the cervix. You have seen where the internal os is. At the same level, wherever you see, do it. That's all. Switch on color Doppler. Place your pulse sample there. Take a Doppler over. So velocities, peak systolic velocity should be more than 60. Why? Otherwise it may be arcuate arteries. So we should not mistake some other artery for, applies for both transabdominal, transvaginal. Second trimester, what do? Longitudinal section in the lower lateral quadrant. Then I just angle it medially. You will be able to identify the uterine artery where it is crossing the external iliac artery. What we saw in the morning. We saw the external iliac, we saw the crossing, but I took it more proximally on one side because of the early branching. Otherwise, normally you place it 1 centimeter downstream from this crossover point after the crossing. So that is that. If it branches before that, then before that bifurcation. Same thing on the other side. Now, as gestational age advances, uterus usually undergoes a little dextrorotation. So what happens? The left uterine artery does not run as lateral as the right. So right will be a little more lateral, left will be a little more medial. It will not be in exactly the same position as on the two sides. That is because of the rotation of the uterus. That's all. So don't expect it to be on the same level. Transvaginal, same thing. Right? Transabdominal, we do it. Now what about umbilical artery? We should know that umbilical waveforms change very early, first trimester, if you want to do, which we should not do, but you still want to do, absent end diastolic velocity is normal. Early second trimester, you start getting a diastolic velocity, but it's still very low, normal. As pregnancy progresses, it goes on increasing, the diastolic flow goes on increasing. So the PI keeps falling throughout pregnancy. It is not uniform. Same thing with uterine artery also. Notching in first trimester is normal. Notching has no value. Even if it persists into second trimester, there is no known value for uterine artery notching. If it notches, fine, no problem. You want to mention, you mention. You don't want to mention, I don't even mention. Because there is no point. You are looking at only one value. One value is what? What? PI. Then why are you bothered? Notching, no notching. Why mention? One more point about umbilical artery is impedance is higher at the fetal side as compared to the placental side. So the reference ranges, majority of those which we use actually use a free chord loop. So whatever reference range you use, you should know where they have done it. If the reference range has been done with the Doppler sample at fetal end, the nomogram is different. If it is at uterine end, it's different. If it is free loop of cord, it's different. So we should know what we are doing. So angle doesn't really matter much for PI as it's angle independent. But anyway, try to make sure that it's in the center. See, whenever you're doing a Doppler, place the sample at the center. Placing it at an edge will give you a wrong high. Why? Because flow is parabolic inside the vessel. Because of the friction of the vessel walls, RBCs here move a little slowly as compared to this. All nomograms have been done with placed here. If you do it here, you will end up getting a wrong value. False positives you will start getting. That is why we insist so much on, unless you zoom your images, radiologists have this tremendous resistance to zoom. I don't know why. Morning I did, what could you see? All the parts which I did, almost entire screen would be what? Only the part that you are studying. Correct? That's a habit for me. Once you do an overview, the overview you did was without zoom, right? I did the overview. Look at the adnexa, you looked at this thing till we came to uterine artery and did that. There was no zoom. The moment uterine artery came, you start zooming. Then each individual part you have to see with zoom. Your pickup rate will rise dramatically if you zoom. Your accuracy of your biometry will increase dramatically if you zoom. Don't keep useless information on the screen. Diastolic flow is not seen. Be careful. Check the angle. At steep angles, you may not see. If the artery is running at a steep angle and you are placing your sample, you may get false positives again. Right? You go at this angle, it becomes quite a steep angle. In multiple pregnancies, sometimes it's difficult. That free loop, you are not sure it belongs to which fetus. In which case, you can do at the abdominal side, no problem, but the nomogram is different, that's all. So there is one thing that we have to remember. What about 2SL cord? No, PI and flow and all depend on what? Depend on the diameter of the vessel. In a 2-vessel cord, that single vessel is bigger. That we know. It has to carry a larger volume, no. So obviously it will become larger. So impedance will be lower. But there is no separate nomogram available at present for a 2-vessel cord. So we can't do anything about it. Just note that the reliability is a little lower with umbilical artery Doppler once it is 2-vessel cord. And unfortunately, 2-vessel cords, there is a higher incidence of IUGR. Exactly when you want it to work, it will work less accurately. So, MCA Doppler, what to do? Again, zoom, accepted, nothing should be seen. Even make it bigger, no problem. Don't make it very small. So, axial section, include thalami, sphenoid bone wings, right? Then, color as usual. Our guide. Like we have guide to go to Puri, Sun Temple and all, we have guides, no? Like that, this is a guide for us. It will tell us where to go, what to do, when to do. They will tell us, no, everything. Otherwise, we don't know. Proximal. M1 segment. And if you are doing a peak systolic velocity to check for anemia, from the origin within 2 centimeters you have to place it, and you have to place it perfectly in the center, right? Zoom. So look at the difference, what you saw earlier and what you saw now. What is the difference? The only difference is I have zoomed. With this, obviously you are going to be more confident where you are placing, right? Correct? Yes or no? Yes. So accuracy will go up drastically. So please zoom. So proximal third, close to the origin from the internal carotid within 2 centimeters. Systolic velocity decreases with distance. That is why with MCA, when you are doing for anemia, that becomes important. You go too far off, you start getting false slow values. Can you do in first trimester? Yes. It is possible. Only thing is, why do you want to do it? We don't want to do it first trimester. Just for sake of, is it possible? Somebody asked, so that's why next talk I put it up. I said, okay, well, you can definitely do. Only thing is, we don't want to do, there is no point in doing in first trimester. Second trimester onwards, monochorionic twins, we are going to start doing. Otherwise, third trimester. As close to 0 as possible when you are measuring PSV. Otherwise, for PI, it doesn't really matter. 20, 30 degrees, that side, this side doesn't really matter. And very important, now see what happens. Many times for visualization, we have this habit of pressing down. Gives us very good visualization. But here, if you do it, again, PI will go up artificially because of our pressure. So you should consciously reduce the pressure while doing this on the transducer. You should not press the fetal head too much. The head should not deform. That is all. Very simple. If the cranium is deforming a little, you are applying too much pressure to measure the MCA-PI. At least 3 times you have to repeat if you are doing PSV. Can be with manual or auto trace. So now majority of the nomograms are also in auto trace, has become pretty good. Computers have improved, but be careful. Auto trace, right? Oh, auto trace, great. It has taken a great measurement, right? It looks very good, very nice. But you should be aware about what your machine is doing. Otherwise, again, you will end up with lot of false positives, false negatives. See what is happening here. It is taking all these it has marked out everything correctly. Here what has happened? It has traced right down. Correct? This is the same one. Exactly the same. Only thing is I have told the machine measure only from here to here. Limited. So what happened to your PI? How much is it? You can see? You can see, right? PI 3.51. Same trace. What is the PI? Huge difference. 35% difference between the two readings. So this also you have to observe for. Now ductus venosus, everybody knows what it is, so let us not go through it again. How do we visualize? First trimester, what do you do? Take the mid sage, move to right of midline, you will see it. Aliasing will be there. Zoom properly, place it properly in the center, you will get a nice ductus venosus trace. You can even in second and third trimester do the longitudinal, but it is easier to do this one, the oblique. You are anyway doing the axial, just turn it a bit, and like I showed you in the morning, just turn it a bit, you start seeing. Very easy. Where it curves, you are anyway doing the AC, where the umbilical vein becomes the portal vein, where the portal sinus there. Where it turns, you just take an oblique, little oblique you take, it will start showing up. Oh, that is supposed to be a video, that is not, okay, fine, okay, all right. No need for video, we saw live anyway, morning. Especially early pregnancy, be very careful about sample size. You make it wide, it will pick up signals from all the surrounding vessels also. As it is space, there are a lot of vessels there. Correct? A lot of vessels are there, surrounding areas. It will start picking up from other vessels also and overlapping. Usually it is triphasic, biphasic, even non-pulsatile, hardly any pulsations also may be there in third trimester. That is normal. Feet are still doing very well. It is when that A wave starts going down that we start worrying. A wave coming well up, we are happy. It's a happy fetus, happy mother, happy gynecologist, happy radiologist. Velocities are high, especially in third trimester. Though it's low in early pregnancy, it becomes higher and higher. So because of that, one very important tip that you can take is, if you have a problem identifying from other vessels, even for the ductus, you can go for a cardiac setting. Go to cardiac preset. If you have a problem identifying from majority of the other vessels will disappear. Because they are all much lower velocities. So it becomes very easy to see. Not always useful, not always required. But if we have a problem, then that's a quick shortcut. So longitudinal, transverse, oblique, all fine, no problem. Now if you see in the cardiac setting, you get excellent waveforms. Can you do in coronal, second, third? Yes, you can. It's more difficult to do. Sometimes position doesn't allow, then anything is okay. We want the waveform, that's it. And we want it from the correct place, that's all. Now, what we have to understand about all this fetal Doppler is, what does it mean? If we understand the meaning and you know the pathophysiology, everything else is automatic. What does high PI mean? It means less flow during diastole. High PI is less flow during diastole. That's all that's meaning, isn't it? It needs pulsating more. Low, unlike this, here you have much higher diastolic flow. What does it mean? PI is low. Look of eye itself you can tell what is normal, what is abnormal. Do 100 cases, by that time you will be able to tell by look of eye whether it is normal or abnormal. Except the borderline cases. So normally, what should you see? Normally, uterine artery, umbilical artery, ductus venosus, they carry more blood. They need to carry more blood normally, right? Uterine artery, it has to carry more blood to the fetus. Again, umbilical artery, more blood required for fetus. Ductus venosus has to carry higher blood, so it will have a low PI normally. MCA doesn't have to carry that much blood, so it will have a higher PI. So pathology is what? Is reverse. If there is an increase in PI in these arteries, it is uterine, umbilical, ductus. If the PI increases, it is abnormal. MCA opposite. Normally it should carry less. It starts increasing, diastolic flow, abnormal. So it's very, very simple. So why do we use Doppler? To study blood flow to the uterus or the placenta actually. Blood flow to the fetal brain and in the ductus to check whether acidemia is there or not. So what exactly happens in IUGR? Early versus late. Now we spoke about the changes, right? Compensated early stages, what happens? Uterine artery and or umbilical artery start becoming abnormal. Abnormal means in their case what? PI increases, diastolic flow starts decreasing. That is abnormal. Then comes hypoxia. In hypoxia what happens? Fetus adapts. I don't mind sacrificing other organs, but I want to protect brain, I want to protect heart, I want to protect adrenals. So those vessels will start having more flow as compared to going to vasoconstriction for the other organs and vasodilatation for brain, heart and adrenals. And has anybody done adrenal artery Doppler study? Yes. And in the fetus in IUGR, when there is hypoxia, will it dilate? Yes. Only thing is, when you have MCA, why do you want to go searching for adrenal artery? Correct? And don't think that is the end of it. There are studies showing that right coronary artery PI they have done. There is a nomogram for right coronary artery PI, and it has been demonstrated that in hypoxia of IUGR, there will be vasodilatation of the coronary arteries also. No, right coronary is not all that difficult. After reading that, I also tried. It's not all that difficult. You can do. So hypoxia. After hypoxia comes what? Acidemia. That is when your ductus A wave starts reversing. If it reverses, acidemia is there. After that comes abnormal BPP. Now we have to observe one very important thing here. Even in late onset, your umbilical end, this thing is always completely normal. Fetus size also can be normal or lower limits of normal. But MCA will have changes of hypoxia. So key to late onset IUGR, the commoner one is middle cerebral artery PI. First CPR will change because cerebroplacental ratio is more sensitive. That will change. After that MCA, because it uses middle cerebral as well as umbilical ratio. Unlike early onset, it does not go through this process, these steps. Late onset, it will just have middle cerebral artery, abnormal BP, stillbirth. Abnormal BPP to stillbirth is just 24 to 48 hours, that's it. So as a screening tool, how useful is abnormal BPP. Everybody asks. There are people asking abnormal BPP at 24 weeks, 26 weeks. BPP? There are people doing also. I was shocked to see reports. What abnormal BPP? BPP? Why on earth are you doing BPP at 23, 24 weeks? One of the important components is what? Breathing movement. Breathing movements happens only occasionally. It starts in first trimester. It occurs once in a few hours in first trimester. Gradually goes on increasing till third trimester. In second trimester, it hardly happens once in an hour or once in... Are you really going to sit for 1 hour to see whether breathing movement is there or not? And okay, let us say it is abnormal. Do what? Deliver 23 weeks. No. Then why on earth do radiologists give BPP in second trimester? There is no point. It has never been validated in second trimester. There are no studies done anywhere in the world for BPP in second trimester. So before 26 weeks, there is no point doing. Viability. Without viability, no point. So please do not give BPP early pregnancy at any time. So what are the aims in IUGR? Give the best possible outcome, live fetus with least risk of neurological damage. See, earlier we didn't know that Doppler could do so much, right? So we used to do only BPP. Why? At that point in time, 15 years ago, we did not know Doppler was so powerful. There were no studies, we didn't know. At that time, the aim of the whole process of doing fetal ultrasound was to deliver a live baby. That is it, full stop. No longer. Now the aim has changed. With Doppler, the whole thing has changed. Now the aim is to deliver a live fetus with the least risk of neurological damage, because this is as bad as death many times. Correct? See, neurological damage, only a person who has somebody in the family who is having a lot, my cousin's son is autistic, so we know what it is. To really understand, there must be somebody in the family. How much it drains the rest of the family. So early FGR, IUGR, what? It's a small fetus, it's easy to detect. Small fetus, Doppler changes, the Doppler changes predictably occur over a period of time. Maybe little early, little late in some fetuses, but path is, no, you know. This is going to happen, this is going to happen next, this is going to happen next. If it worsens, if it doesn't worsen, it is going to continue along the same line. So stage based. So good recommendations. So problem is management. You have to balance survival versus neurological damage. This is the problem. When to deliver is the difficult thing. Detection is not the problem. Late IUGR, the problem is it's difficult to detect. Fetus is not small. It occurs later in gestation. And there can be rapid deterioration. That is the problem. So management is very easy. It is already late in pregnancy. What? Deliver. Over, no. See, IUGR basically as such, there is no specific treatment possible for IUGR. The only possible treatment is delivery. There is no other treatment. But here, that problem is solved. Management easy. 37 to 38 weeks, tell them to deliver. Not too early, not necessary. After 38, it's risky. So, difference between the two in management is this. When you are going to deliver. Here it is very simple, 37 weeks. After 34, definitely not before 34 for late IUGR. There is no point delivering too early. Here we have stages. In early IUGR, in stage 1, what does it actually mean? It means that there is a placental problem, but the fetus is compensated. It is adapted in early IUGR. That's what it means. The PI or umbilical artery or both are high, yes. MCA PI may drop. Just because MCA PI goes below does not mean you have to deliver. People have this wrong idea. MCA PI, oh, what? Cerebral vasodilatation, hypoxia, deliver. No. You ask any neonatologist, they are not much bothered about hypoxia. They don't want acidemia. You give them a hypoxic baby, they are okay with it. Wait, you are able to improve, they are very happy. You give them one with a respiratory, this thing, you are steroided and you have made sure that the respiratory system is good, they will be thrilled. You give them an acidotic baby, they will be very unhappy with you. So don't intervene, stage 1. Stage 1 is for identification and follow-up only. At any stage, for stage 1, there is no need to deliver in early IUGR. Stage 2, okay, now fetus is becoming hypoxic. Absent end diastolic flow in the umbilical artery. That is the criteria. Earlier, we also had aortic isthmus. We are no longer using it. It has not been found to be useful. You can still do it, no problem, but no need to place too much weightage on aortic isthmus. Absent end diastolic flow in umbilical artery. If it is 34 weeks or more, deliver. Simple. Yes or no? It's just yes or no. Stage 3, high suspicion of visceral acidemia. There is a reverse ductus venosus flow. 30 weeks or more, you can still deliver. Because after that, waiting is very risky. Stage 4, high suspicion of fetal acidemia. Reversed end diastolic flow in umbilical artery or ductus venosus. 26 weeks or more, deliver. Because after that, acidosis, already acidosis is there, IUD is imminent. So, fetus has more chance of surviving outside the uterus than inside the uterus. And risk of neurological damage increases. So, no choice. Steroid and deliver. And one very important thing, all these recommendations are based on one fact, especially if you are at 26 to 32, 34 weeks. It's all based on the assumption that there is good neonatal care unit backing you up. If it is in a place without good neonatal care and it is very early, please advise the patient go to higher center. Otherwise, again, it's a death sentence. With a poor neonatal backup, severe early IUGR, mortality rate very high. Neurological deficits become much more common. Now, what about MCA PSV? For anemia. When anemia? Rh negative. If there is high drops, if it is, we are going to suspect all these things. These technical things are extremely important. 1, repeat 3 times. When the fetus is not moving, it has just stopped moving and you immediately do, there can be a false positive with the MCA as well as umbilical. Please be very careful. Wait for at least 5-10 seconds for the fetus to settle down. Breathing movement. 2 mm from origin of MCA, 1 mm sample with adequate zoom. So MCA PSV more than 1.5 times multiple of median indicative of fetal anemia needing chordosynthesis. and maybe transfusion. The calculator is available. How to do it? Very simple. Go to perinatalogy.com. They have for anemia, they have one thing, click on that, put the gestational age. And many people make this mistake of putting gestational age as what the machine gives based on fetal size, which is not correct. You are measuring fetal size. Ultrasound measures size. Ultrasound cannot measure time. Can you measure time with ultrasound? Seconds? No, it doesn't. So that is why this weeks, days thing should be avoided. Weeks, days is only one time, that is a time of dating. Because very early in pregnancy, all fetuses same size. After that, it is fetal size. It is not weeks, days. Weeks, days afterwards should always come from your corrected EDD. From your ultrasound EDD, if you have corrected it, from the first one, no repeat EDDs later in that pregnancy. One pregnancy, one EDD is the rule. So put the corrected EDD according to that. What is the gestational age? Put your value. It will automatically, it will tell you, and it will even tell you moderate anemia, severe anemia, it will tell you. So you don't have to worry. Very easy. So thank you all for a very patient hearing. Anything, anytime, please feel free to contact me. My WhatsApp number is the same as my phone number. I may not reply immediately. Or you can email me also if there are any doubts. Because unlike present generation, I have not actually married my phone. so I may reply even next day, so don't feel bad. Many times I don't even switch on my internet for a full day, which is very shocking for present generation.
Thank you, sir, for the very informative presentation and sir's talk. Specifically, the image portion, all the tables, and the management portions. Thank you, sir, for this informative talk. Next topic is a technical presentation by Pradyut Kumar Saha, Deputy General Manager, Siemens Healthcare Private Limited.
Category, the first prize goes to Naga Sumanta Bola from Som Hospital. The second prize goes to Dr. Bimal from AIIMS Bhubaneswar and Dr. Swati from KIMS Bhubaneswar. And third prize goes to Dr. Seri from Som Hospital and Dr. Abhib Shah from SCB Medical College. Now coming to e-poster category, the third prize goes to Dr. Ria from KIMS and Dr. Sumedha from KIMS. Dr. Ria from Kalinga and Dr. Sumedha from KIMS. Second prize goes to Dr. Shruti from AIIMS Bhubaneswar and Dr. Lipi Puspa from MKCG Medical College. And the first prize goes to Dr. Amrit Das from Som Hospital. Congratulations to the all winners. Now we'll proceed to the next session. Submit their phone number so that the prize will be directly paid to their accounts through digital payment. Thank you.
Good afternoon everyone. First of all, thank you so much for giving us this opportunity. And it's a privilege and honor to be here. I am Pradyut Kumar Saha from Siemens Healthcare, and many congratulations to the winners as well, who did really well for securing the prizes. Just to give you, I will talk about a very very innovative breakthrough technology that Siemens has come up with. Start with, I will give you a little bit brief about the company. where we are now as Siemens, and then the technology I will talk about. It's a technology in MR, dry cool technology, and how it is making huge changes in terms of bridging the gap in MRI imaging. So as Siemens, we are like now a 13.4 billion euro company, having our head office in Erlangen, Germany. So we are touching around 2.4 billion lives every hour and touching around 1.3 billion people throughout the world. We have a very rich history as a innovation company, as a technical company in healthcare, right from 1896, and we have many things, and mainly because the association of two great minds, Dr. Ranjan and Dr. Verang, who basically were the Nobel Prize owners of 1901 for their contribution in healthcare. Few first things I will just like to mention here, like you were the first to make MR, commercially available MR in the world, and we are the first company to come up with many breakthrough technologies like dual source CT, which is like, walk-in, walk-out cardiac imaging you can do in that. Apart from that, right now, just 3 years back, we came up with something very innovative in CT, that is photon counting CT. And we are the first company to come up with 7 Tesla MRI in the world, which is commercially available now. And the technology that I am talking about, it is also very innovative, which is, like dry cool technology in MRI. So the main reason behind the innovation is, this is just a little bit the growth story that we have in India. Very good news is that in 2020, the global head came in India and announced a 1,300 crore rupees of investment in India. So we are having the second largest factory in the world after Germany, in India, in Bangalore. So we are manufacturing MR also there. We started with Siam, then CT, and now we are manufacturing MR as well in Bangalore. So just the product lines that we have in imaging, we are in advanced therapy with our imaging. We have all these radio imaging systems, right from X-ray, CT, MR. In advanced therapy, we have cath lab as well as SIAMs. Diagnostic laboratory, we have equipments, and with Varian, acquisition of Varian 2 years back, we are into oncology radiation therapy. So this is the entire MR portfolio. You can see, like as usual, 7T, 1.5T, and 3T. The very unique product portfolio that we have is the high-V MRI that I'm going to talk about today. So MR for all, that's the main idea behind this system. We believe everyone deserves access to MRI. Why? Because of you all. That the main diseases, the most happening diseases now, like cancer, like neurological disorder and orthopedic conditions, like people living years with orthopedic conditions now require MRI to be done. So that's why we feel MRI, everyone should have access to MRI, but very unfortunate that even today the MRI access is less than 50%. Even though the places where we have got MRI, the waiting time is huge, as long as 11 weeks in the world. So what is the reason behind? The main reason behind is, first is the cost, and second is the complexity. Complexity in terms of like weight of MRI. The most critical is that helium, which is like managing that becomes a huge issue. Like we have to have 24 hours power backup, and having it in places where there are frequent breakdowns of power is really difficult. In terms of siting also, like having a MRI is heavy, so putting it in various floors or apart from the ground floor becomes a challenge. So taking all these consideration, we really look forward to bring up MRI, which is absolutely new breed, what he say, that we can afford, that fits your location. So that's where high-V MRI came in. I just take you through one short video to give you a brief of the technology that is there.
Access to MRI is still limited around the world. We specifically designed Magnetom Freestar to redefine affordability and provide better access to high-value care. As a result, Magnetom Freestar dramatically reduces cost and complexity of conventional solutions. Let's take a closer look, starting right at the beginning of its life cycle with the infrastructure costs. Magnetom Freestar sets a new benchmark with its lightweight and compact system design. It significantly reduces siting requirements and can be brought in through existing hallways and doors. Thanks to this unique design, it can even be delivered as a turnkey solution that eliminates the need for a dedicated building infrastructure, truly a plug-and-play solution. But that's not all. With its dry-cool technology, Magnetom Freestar has a sealed-for-life magnet that eliminates the immediate costs of the complex quench pipe installation and the life cycle costs of a traditional helium infrastructure. The result? Magnetom Freestar significantly reduces both infrastructure and installation costs. It also reduces the capital investment for the MRI system itself. With its groundbreaking high-V MRI approach, Magnetom Freestar is a very cost-effective system that keeps life cycle costs down. When it comes to operational costs, Magnetom Freestar deploys our innovations in the field of AI-based scan automation to support the user. My Exam Companion is a highly automated push-button workflow, and to give even more people access to MRI, Siemens Healthineers can assist the entire diagnostic workflow from scanning to diagnostic reading with tailored service solutions. And finally, our innovative and intelligent service offerings set a new standard in maximizing productivity throughout the life cycle. With our connected scanner approach, we can continuously and efficiently monitor key components and performance parameters remotely. The result is optimal scanner uptime and a very cost-effective service. Over the course of its life cycle, Magnetom Freestar offers holistic cost innovations that enable a future of affordable MRI for all. Redefine MRI affordability with Magnetom Freestar.
Low strength system in terms of, but I will show you the technologies, how it is like. I think, I was expecting this actually. So, rather, let us get into the latest, the technology that has been implemented. So like now with this system, I'll just show you some images, how it, like as we talked about neurological disorders. So this is the kind of neuroimaging that you can expect it from. So like orthopedic conditions that so these are the kind of quality that you can expect from. And also the cancer cases, like body cases that you can, do it here. So I was just, along with the images, I was just showing the time. And because it becomes very important in terms of MRI, as you know, that the more time you give, the better the image quality will be. So here we have very unique, acceleration techniques that we have implemented in this system, which are absolutely standard. We supply with the system. One of the most unique technologies is the deep resolve technology, which is basically first one is the artificial intelligence denoising, and the second one is the neural network plus artificial intelligence. Deep resolve gain and depth resolve sharp. So together the impact is this. This is how it is. Like you are having a image of the same image quality with lesser time acquisition, with deep resolve gain. With deep resolve sharp, you can have the same like in fact the better image quality with the same timing. So that the impact of depth resolve sharp. So these are few images that I'm going to show you the acquisition time that it takes. A few more cases. These are the kind of sequences with this kind of timing you can have with IV MRI. So I reached in almost 14 minutes. So there are few things which are very new in terms of imaging. There are three things. One is better susceptibility, challenges that you have. It is less here, and also a very unique thing. Additional is the chest MRI, which most of you have not heard in high field MRIs, and the better implant, metal implant imaging. So this is the difference that you see in this MRI. So like pulmonary, like COVID patches, you can see in MRI as well. That is the way you see in CT. Nodule detection happening. CT, and this is the kind of metal artifact reduction. So very high resolution metal artifact reduction. The challenge, one more challenge, that is easy to operate. It has to be, because so that is why you made everything automatic. One click, in autopilot mode. So one click positioning, one click imaging. That is the kind of automation that you are talking about. So overall, these are system highlights. So that's how we are now making this MRI accessible to the world. Already, good news is that we have already sold more than 50 plus systems in India, having 10 to 11 system in East region and only. Fortunate that we have already one installation in Odisha. So that's from my side. Thank you so much. Thank you once again for giving me this opportunity to present before you this innovative technology. Thank you. Thank you so much. Definitely.
Now I would like to call upon stage Dr. K. Chinmay Deepak sir, interventional radiologist, KIMS, and he will speak on the topic vessel wall imaging.
Good afternoon, everyone. So last talk of the session. So we are going to discuss about vessel wall imaging. So in the present radiological investigations, we have so many modalities to investigate the vessel, like DSF, CT angiography, MR angiography. So why vessel wall imaging is the new model technique to do it? Because the incidence of stroke have increased in young patients. We have 4 categories of etiology for ischemic strokes: large vessel atherosclerosis, small vessel occlusion, cardioembolism, and cryptogenic. Cryptogenic are those strokes whose etiology has not been diagnosed. So it is very important to subclassify the cause of the ischemic strokes for further management. So why vessel wall imaging? It is to differentiate different diseases of intracranial vessel, to be able to see that is not so obvious, to assess disease activity, to assess response to the treatment. So the techniques in vessel wall imaging, one is high spatial resolution, multiplanar 2D and 3D acquisitions, multiple tissue weightings, and suppression of CSF as well as intraluminal blood. So we know the intracranial vessel wall is very thin in caliber. It measures around 0.3 to 0.5 mm. So a 3 Tesla MRI is ideal for the imaging for increased signal to noise ratio. So the voxel should cover at least the wall of the vessel. After that, we take a short axis and long axis along the pathological area. So in this case, we are seeing a stenosis in the petrous ICA. So we can take a axial view and as well as a longitudinal view where we can see a plaque. So next is the 3D imaging. So for this we have DNT image. So advantage is we can both suppress the surrounding CSF as well as the blood within the lumen. So CSF pulsations are usually misdiagnosed as atherosclerotic plaque. So in this case, we can see there is hyperintensity surrounding the vessel wall, which is actually the CSF pulsation artifact. So coming to the clinical application, as we have discussed earlier, in younger strokes, there are numerous unknown etiologies. So this is how the normal artery appears. We know the layers intima, media and externa. So in moyamoya disease, there is hypertrophy of the intima and atrophy of the media. In vasculitis, there is diffuse inflammation of the vessel wall involving all the 3 layers. In RCVS, there is thickened media and no inflammation. In atherosclerosis, the lumen is variable and the plaque is usually eccentric, and there is inflammation of the plaque. So this is the MRI dogma for vessel wall imaging. This is the normal vessel. In vasculitis, there is transmural inflammation of the vessel. So on post contrast, there is uniform enhancement of the wall of the vessel. In RCVS, there is hypertrophy of the media, but there is no inflammation. So in gadolinium study, there is no enhancement of the wall. In dissection, the blood will appear hyperintense on T1. So in T1, it will appear hyperintense and eccentric, and on post contrast, usually no enhancement, or it will appear similar to the pre-contrast. In ICAT, that is intracranial atherosclerosis, the plaque is eccentric, and on post contrast, there will be enhancement of the plaque. So this is a normal vessel, normal MRI of a vessel. So here we are not seeing any intraluminal plaque or inflammation. So coming to vasculitis, as we have discussed, there is inflammation of the vessel. So the pathology can be primary or it can be secondary due to autoimmune or infections. So in vasculitis, there is complete involvement of the vessel, transmural. So there is uniform enhancement of the vessel wall. So in this case, we can see there is stenosis in the basilar artery and PCA. So on post-contrast study, there is uniform enhancement of the basilar artery as well as the PCA. So next is the reversible cerebral vasoconstriction syndrome, or RCVS. So this is hypertrophy of the media of the vessel wall. So the common risk factors include smoking, alcohol consumption, or some other etiologies. It is very important to differentiate vasculitis from RCVS because the treatment is entirely different. In vasculitis, we use immunosuppressant medications, but in case of RCVS, calcium channel blockers are used. Steroids may worsen RCVS. Even on DSA, it is very difficult to differentiate RCVS and vasculitis because on DSA also there is areas of stenosis within the vasculature in both RCVS and vasculitis. So this is a middle-aged female who are presented with strokes. So MR angiography showed multiple areas of strictures, and this is the MR vessel wall imaging where we can see there is no enhancement. If there is vasculitis, there will be uniform enhancement, but in RCVS, since there is no inflammation, there will be no enhancement of the wall. So this is post-treatment image which is resolved. So in dissection, there is in pre-contrast there is hyperintensity along the wall of the vessel, and in post-contrast also it will appear hyperintense. In atherosclerotic plaque, there will be eccentric plaque in the blood vessel, and on post-contrast there will be enhancement. In this case, we can see there is acute stenosis at the mid-basilar level. On MR imaging, there is 3 layers we can see: fibrous cap, lipid core, and adventitia. Usually the fibrous cap will show enhancement on post-contrast study. So this is the pathology of intracranial atherosclerosis disease. Initially there will be an etiology like hypertension, aging, or diabetes mellitus. So there will be vasa vasorum formation in the tunica adventitia, which will lead to atherosclerosis and plaque formation. And gradually there will be rupture of the plaque and formation of intraplaque hemorrhage and further embolic strokes. So 2 types of atherosclerotic disease are seen. One is positive remodeling and negative remodeling. So in positive remodeling, there is atherosclerotic plaque in the adventitia, but the lumen is not significantly narrowed. It is just at the wall of the vessel. Whereas in the negative remodeling, the atherosclerotic plaque is within the lumen of the vessel and it causes significant compromise of the lumen. So this is a case of negative remodeling where we can see the atherosclerotic plaque is within the lumen of the vessel causing stenosis. So this is the axial sections where we can see the lumen of the vessel is significantly compromised. This is a positive remodeling case. Here we can see the MR angiography appears normal. When we do the vessel wall imaging, there is an atherosclerotic plaque in the wall of the vessel without any compromise of the lumen. So this is a positive remodeling atherosclerotic plaque. So another use of vessel wall imaging is to identify non-stenotic disease. So usually we find this routine MRI cases in our daily practice, and MR angiography is usually normal. We give as normal MR angiography report. But if we do vessel wall imaging, if we do a vessel wall imaging in this area, so we find an eccentric plaque in the superior surface of the M1 MCA. So this is the zoomed image. So here you can see there is a plaque in the superior surface of the M1 MCA. Usually the lenticular striate vessels arises from this superior surface. So we can identify if the plaque is in the inferior surface, the chances of stroke are less. If the plaque is in the superior surface, the chances of stroke are more. MR vessel wall imaging is also used to determine whether the aneurysm has ruptured. So in delayed SH cases where the SH has resolved, it is very difficult to know whether the aneurysm has ruptured or not. In that case, when we do the vessel wall imaging, we can see the enhancement of the aneurysm wall, which suggests that there was a rupture or there is chance of re-rupture of the aneurysm. So I will show some cases. So this is a 22-year-old female who presented with deep watershed territory infarcts. So we did a angiography which showed an abnormal aortic arch. We can see the CCA is arising directly from the arch of aorta. And in the intracranial vasculature, we can see an area of stenosis in the terminal ICA. So this patient, we did an MR angiography, MR vessel wall imaging. So we can see an eccentric enhancement of the wall. So we were a little confused whether it is atherosclerotic or vasculitis, because atherosclerotic is relatively rare in such a young patient. So eventually she had repeat stroke after 10 weeks. So we did an repeat MR vessel wall imaging. Now we can see there is diffuse concentric vessel wall enhancement. The stenosis has also a little bit increased. So now we were sure that it was case of vasculitis and treatment was done accordingly. So such cases of vasculitis, we cannot do stenting. So only medical management. So this is second case. This is again a 37-year-old patient, was a doctor also. So she presented with acute stroke, and MR angiography was done, which showed an filling defect in the left M1 MCA. We did an DSA which showed a plaque in the left M1 MCA. She was subsequently underwent stenting and clinically asymptomatic. This is a case of atherosclerosis. Yeah, we did the vessel wall imaging which showed an eccentric plaque, and it was diagnosed as atherosclerotic disease, and she went for stenting. This is third case. Patient also presented with stroke, and we can see multiple areas of stenosis in the terminal ICA, left A1, AC and MCA, and vessel wall imaging was done which showed diffuse enhancement of left M1, MCA, and it was diagnosed as vasculitis and further medical management. So this is one interesting case. This is 23-year-old male patient who initially presented with stroke. We can see in the CT was done outside, and there was an infarct in the right caudate head nucleus. He again had a repeat stroke which in the different area in the left basal ganglia, and subsequently had another stroke. So in the SW images there were multiple areas of blooming. So usually we give it as a hemorrhagic transformation of infarcts, but we did an DSA which was surprising because there were multiple tiny aneurysms arising from the lenticulostriate branches, which is very unusual. So this is the 3D imaging of the DSA where we can see multiple aneurysms, small aneurysms arising from the lenticulostriate vessels. So we did the MR vessel wall imaging. In MR vessel wall imaging we can see there is diffuse enhancement of lenticulostriate vessels in bilateral basal ganglia region. So subsequently the diagnosis was made as vasculitis, and there was medical management was done rather than coiling or other stuffs. So with medical management we did a repeat DSA after a 1 month course. So you can see there is complete resolution of the lenticulostriate vessel aneurysms. So that is why vessel wall imaging has an important role in such cases where the diagnosis is very uncertain. So there are some challenges and pitfalls in vessel wall imaging. So this is a case where we can see there is an enhancement near the M1 MCA. Usually it can be confused as an atherosclerotic plaque, but this is a vein adjacent to the artery which can be easily mistaken as atherosclerotic plaque. So we have to compare with pre-contrast study and subsequently give a diagnosis. So second case, the patient presented with right cerebellar infarct. So in T1 pre-contrast, we can see an eccentric T1 hyperintensity in the lumen. So diagnosis of either dissection or atherosclerotic plaque was given. But on post-contrast study, there was no filling defects. So it was completely normal lumen. So slow turbulent flow can mimic vessel wall abnormality. So these are some pitfalls of vessel wall imaging. So this is a acute stroke case. So MR TOF imaging showed an filling defect, and pre-contrast showed an T1 bright in the left MCA bifurcation. So acute thrombosis can also appear, can mimic like an plaque. So last case. So this is an 81-year-old patient with cerebellar infarct. So on vessel wall imaging there was diffuse circumferential enhancement of the vertebral artery. So it was diagnosed as vasculitis initially, but it is not an vasculitis, it is vasa vasosurum. So with aging and other process, the vasa vasosurum develop within the wall of the vessel, which mimics like vasculitis. So to conclude, vessel wall imaging has a very important role in diagnosing the etiology of acute strokes and further management of the patients. Thank you.
Now we would start the postgraduate quiz for postgraduate students. Kindly requesting all the residents to join the group in which the link will be shared, and the quiz will be conducted by Ranjan sir.
Now we'll start the most interesting session of the conference, I think, for the resident, the quiz. Basically, the rules that I have already shared, this will be a MCQ based question. We have 40 question, 30 carries 1 mark each, and 10 question have 2 points. So the total of 50 points will be there for 40 questions, and there will be no negative marking, and you must attend all the question to submit the Google form. If you leave any question, then it won't be submitted. Please come forward. There will be no negative marking, and in case of tie breaking, remember those PGs who have more correct answer for the more weightage bearing question, that is question having 2 points, who will correct more 2-point carrying question, those will have a higher rank at the final. And the Google form will be like this. You have to enter your name, institution name, and your affiliation. In the affiliation, please write only JR or SR. Don't write the complete name, because it will be easier for us to evaluate later on. And any question will 2 points will be marked like here. If question has a 1 point, then on the right upper corner that will be 1 point, and if this question carries 2 points, that will be 2 point carrying. And at the end you have to submit it by clicking this button. So now you can scan this QR code to this will go to the answer module. काम करूँ आशीष जी not working. Okay, then I'll share the link. I'll share the link. লিঙ্কটা পঠাচ্ছি। I have shared the link in ORIA PG quiz group and ORIA group also. Once you are done with your name, institution and the affiliation, we can start the quiz. Shall we start?
No, anyone who is not done with filling up the form and all. Everyone is facing problem. Please stand up. Is anyone facing problem? Everybody is done?
Okay. चलेगा सर. Now this is the first question. Each question will have a time of 25 seconds. You have to mark the answer in your Google Sheet. A case of ALL on chemotherapy with altered sensorium for 1 day. You have the NCCT and CECT images. The options are traumatic bleed, tumor-related bleed, dural venous sinus thrombosis with venous impact, acute arterial thrombosis. This is the second question. It's a spot diagnosis. This is the third one. The lower image is the insight image that has been zoomed. The pathology has been zoomed in the lower image. This is a contrast agent. You have to write the amount of biliary excretion. 2 to 4%, 8 to 10%, 15 to 20%, and 50%. This is also a spot diagnosis. It's a patient of hemiplegia, bedridden patient, 61 year male, and the pathology has been highlighted. This is also a no-brainer. I have given the Dotanoc FAT and FDG PAT image. We have to identify the correct option. A patient with right-sided proptosis. The options are here. Non-contrast and contrast MR images are given. Name the agent, reversal agent for the agent shown here, heparin. Name the reversal agent of heparin. A patient presented with acute onset left iliac fossa pain. These are the CECT images to rule out the causes of acute pain abdomen. A 14-year male with right-sided limping. Spot the diagnosis. Patient having visual complaint and non-contrast and contrast MR images are given. The options are retinal hemorrhage, orbital pseudotumor, Graves' ophthalmopathy, optic neuritis. This is also a very easy question. Just spot the diagnosis. A 40-year male patient with backache. Identify the pathology in the X-ray given and name the sign. This is a patient having multiple complaints and multiple imaging manifestation. Mark the correct diagnosis. This is also a very easy question. Identify the midline pathology and mark the correct answer. Spot the diagnosis. This patient also having multiple imaging findings. You have to add all the imaging findings and mark the correct syndromic association. A patient after trauma developed focal neurological deficit. These are the MR non-contrast and top angiographic images. Mark the diagnosis. This is an embolizing agent, easily available and very cheaper. Mark the wrong option given.
Now this is VC-Pack or iodixanol. What is the osmolality of this agent shown here? I have to choose from the option, name the radiological sign. to choose from the option, the correct option about the agent shown here, sonazoid, that we had discussed through the day. Now, case of cholangiocarcinoma with right lobe lesion on CT. Now, choose from the option regarding the correct diagnosis. Now, 32-year-old pancreatitis patient with upper GI bleed. Name the embolization technique preferred for the pathology seen on this CT image. What is the preferred embolization technique for this case? Now, right shoulder swelling. Shoulder X-ray is given along with CTs. You have to find out the diagnosis from the options. Most appropriate diagnosis in this 51-year-old male with chest wall swelling. A 23-year-old female with left-sided lumbar pain for 1 week. What is the diagnosis from the options? Now, this patient complained of persistent upper abdominal pain after ERCP. Which is the most likely diagnosis made from the image shown? ERCP is the procedure. Now, this is pretty straightforward. Name the fracture. Which is the most common artery traversing through the ligamentum venosum, which is shown here in this MIP image. Now, a constellation of findings for a syndrome with history of pelvic pain. Diagnosis. It's MRI of pelvis as well as MRI of abdomen. Now, this is a biopsy proven case of breast carcinoma. What should be the assigned BIRADS category for the above lesion? Name the appearance of this lesion. which is not true for the imaging pathology shown in this CT image. Name the USG artifact which is shown in the accompanying image of a gallbladder that is shown. Name the fracture from this coronally reformatted CT image. No talking among yourselves, please. Now the last question, diagnosis. What is your diagnosis from the NCCT image?
You have to submit your option within 15 seconds, otherwise it will be closed for all.
It's like the time bomb.
Yeah. ଏଥିରେ ଆସିଯିବ ଭାଇ ପୁରା ଏଇଟା ମାର୍କଟା ହେଲା ଆଉ ଏଥିରେ ଲାଷ୍ଟ ପୁରା ନା ଥିବ ଫଟୋ ଉଠେଇଦେଲେ ଆଉ ନାଁଟା ଯେ ଅଛନ୍ତି ଏଇଟା ମାର୍କଟା এই দুইটা কলমକୁ ଏଠିକି ଆଣି ଆସିଛି ରହନ୍ତୁ ଗୋଟେ ଗୋଟେ କରିକି ନେବାକୁ ପଡ଼ିବ ଲାଗୁଛି କପି ଆଉ ଗୋଟେ ରହନ୍ତୁ ଇନଷ୍ଟିଚ୍ୟୁଟ୍ ନାମଟା ବି ଆସିଯିବ ଏଥିରେ ଏଇଟା ରହନ୍ତୁ ଏଥିରେ ଜଣାପଡ଼ିଯିବ ନେବେ କି ଏଇଟା ଏଇଟା ଫାଷ୍ଟରୁ ଆସିଛି ଏତିକି ଗୋଟେ ଅଛି ଫାଷ୍ଟରୁ ଏତିକି ଗୋଟେ ନେଇଯାଆନ୍ତୁ ଧୀରେନ୍ଦ୍ର ମହାନ୍ତି ପରେ ଆଉ ଥରେ ମୁଁ ନେଇ ଆସିଛି ଏଇଟା ଲାଷ୍ଟ ମୁଁ ଡିସ୍କସ୍ କରିଦେଉଛି ଟିକେ ଆଉ Now we'll just discuss the queries. Connect करें ये connect हो रहा है गोटा में राउंड a hemorrhagic infarct in the left parieto-occipital region. So this is basically dural sinus thrombosis with venous infarct. empty delta sign, and most sensitive MR sequence is SWI, and most sensitive and specific sequence is contrast enhanced MRI, MPRH sequence. This is basically accumulation of calcium within the renal medulla. So it is medullary nephrocalcinosis. If you look at this image, this is basically left upper lobe pathology, and if you see carefully that I showed in the image, it's a opacity with a thin rim of crescent of air around it. So it's a air crescent sign, and the most common cause is fungal ball or aspergilloma. This is multi-ans that we have hepatobiliary contrast agent. The excretion, biliary excretion is 2 to 4% for multi-ans, and for gadoxetic acid it is 50%. So answer is 2 to 4%. This is a case of post-hemiplegic myositis ossificans. If you have a query of myositis ossificans versus a directly bone growth, then you can see, you can see this is a thin line that is separating between the parent bone and the pathology. This is called string sign. That is quite specific for myositis ossificans, and also in myositis ossificans the calcification start from the periphery, whereas in case of its close mimic, that is parosteal osteosarcoma, the calcification start from the center. So this is a myositis ossificans that developed after prolonged bedridden. Dotanoc fat is basically done to identify and to look for the dissemination of the neuroendocrine tumor. So it's pancreatic neuroendocrine tumor with hepatic metastasis. Remember, well differentiated pancreatic neuroendocrine tumor will be Dotanoc avid, whereas poorly differentiated tumor will be PET avid but Dotanoc negative. So this is a well differentiated pancreatic neuroendocrine tumor. This is also a right-sided avidly enhancing mass. The two closest differential are either it's a optic nerve glioma or it's a optic nerve meningioma. In case of optic nerve glioma, you won't be able to see the optic nerve separately, whereas in this case you can see the optic nerve separately, and around the optic nerve there is an enhancing mass. So it's optic nerve with meningioma. Protamine sulfate is used to reverse the action of heparin. Basically, protamine sulfate is a cation that binds with the heparin to make a complex, and that will be catabolized by the copper cells. This is basically important when you are planning for an intervention in a patient who is already on heparin and you are planning an urgent intervention. So you have to reverse by giving protamine sulfate. This is a patient presented with left-sided pain. So if you see carefully, this is the sigmoid bowel loops, and just anterior to the sigmoid bowel loops, a small fatty attenuation lesion with a slightly hyperattenuating rim that is adjacent to sigmoid colon. That means it's the epibloic appendicitis which has inflamed. So the close differential is the omental infarction, but usually omental infarction cause pain in the right side and upper abdominal pain, whereas epibloic appendicitis present with the left-sided lower abdominal pain. This is a straightforward case of Perthes disease. You can see there is irregularity, sclerosis, widening of the neck, and there is also deformity of the neck. So it's a 14-year male patient. The close differential is SCAP, slipped capital femoral epiphysis. In SCAP, there will be slippage of the femoral epiphysis medially and inferiorly. This patient presented with visual complaint. This is the T2 weighted coronal images. If you see the T2 images, there is normal loss of T2 hypointensity in the right sided optic nerve. This is the FLAIR images. If you see, there is slight hyperintense and thickening of the right optic nerve. And in the post-contrast images, there is enhancement of the right optic nerve. So this is a case of right-sided optic neuritis. This is straightforward case of hepatic hydrated cyst. This is basically a patient with ankylosing spondylitis with bamboo spine. There is bridging syndesmophyte causing stiffening of the spine. This is also called as bamboo spine. This is, if you see the first image, this is the NCCT images. Either this you can call it as a medullary nephrocalcinosis or renal calculi. The second images also show the medullary nephrocalcinosis and renal calculi. Along with there is a large, relatively hyper-enhancing pancreatic mass. And if you see the third images, these are the two hyper-enhancing nodule just inferior to the thyroid. So these are bilateral parathyroid adenoma. And because of the bilateral parathyroid adenoma, there will be hyperparathyroidism causing medullary nephrocalcinosis, renal calculi, bony lesions in form of lytic lesions, as well as diffuse osteoporosis. So hyperparathyroidism, pancreatic neuroendocrine tumor, and these all constitutes mostly of the Meniere's syndrome, which is also called as the Wermer syndrome. So Meniere's syndrome, basically 3P that we read in pathology, Robbins, pituitary adenoma, pituitary neuroendocrine, pancreatic neuroendocrine tumor, and parathyroid. Most common presentation is the bone pain and bone lesions that present with hyperparathyroidism, followed by pancreatic neuroendocrine tumor, the most common being the gastrinoma. This is also a spotter, but the close differential of it is a hemangioma of tongue. In post-contrast images, hemangioma will also look like the similar thing, but if you see the non-contrast images, that is the first image, hemangioma won't show enhancement in the non-contrast images, whereas thyroid has a high iodine content and this will appear hyperdense even in the non-contrast phase. So this, and there is absence of the thyroid in its normal place, so it's a lingual thyroid. This is again a spotter. If you see, there is a thin rim of bone around a bone. So this is basically the central is the sequestrum, followed by a sclerotic involucrum around it. This happens in case of chronic osteomyelitis of mandible. This is again, if you see, this is basically the internal auditory canal. This is the vestibule. Behind the vestibule there is a lytic lesions, and this appears hyperintense on T2 weighted MR images. And along with it, if you see this carefully, there are multiple pancreatic cysts, and there are left-sided renal cyst also, and right-sided enhancing renal lesions. So these are the RCC, pancreatic cyst, and a lesion just behind the IAC. So this is basically an endolymphatic sac tumor in a patient with VHL, von Hippel-Lindau syndrome. Endolymphatic sac tumor is a quite peculiar tumor that usually happen in patient with VHL. So BHL in case in renal, that in our cases also there are multiple RCC in the right kidney along with renal cyst, pancreatic cyst, pheochromocytoma, and in CNS hemangioblastoma and spinal hemangioblastoma usually happens. And in head and neck, endolymphatic sac tumor is a typical tumor that happens in these patients. This is also a straightforward case, post-traumatic focal neurological deficit. You can see there is infarct in the left centrum semiovale. This is the FLAIR image. If you see carefully, there is hyperintensity in the left-sided carotid canal. And these are the T1 weighted images. If you see carefully, this is the carotid artery, and there is a crescent separate T1 hyperintensity. So this is basically intramural hematoma because of the carotid artery dissection. This is the SWI image. Again, you can see there is blooming, crescent separate blooming in the carotid artery, and in the top images there is red tailing, there is thinning of the carotid artery. So these are typical features of carotid artery dissection. Carotid artery dissection is an important cause of stroke in the young patients. This is nothing but the gel foam that we use. Gel foam is basically the easiest and cheapest available embolizing agents. It's a temporary embolizing agents, usually work only for 4 to 6 weeks. It contains AR foci, that's why it increases the chances of infection also. And the most difficult agents to control while embolizing is the glue. So the first option, it is gel foam is not more difficult than glue to using it. Rather, glue is a very difficult agent to control it while using it. So the not true option will be the first one, and other three are the true option for gel foam. And gel foam is also used for the plugged liver biopsy that is usually done in patients with coagulopathy. And this is also a spotter. If you see, there is a talar beak sign, and there is a anterior extension of the calcaneum and with bridging along with the naviculus. So this is calcaneum coalition. This anterior extension of calcaneum is also called as anteater sign. This case, if you see, there is thin rim of enhancing soft tissue around the bilateral kidneys, which is causing hydronephrosis. The soft tissue is also extending along the retroperitoneum ureter till the pelvis. The bone, you can see there is symmetrical sclerotic lesions, typically involving the metaphysis of the bilateral femur and tibia. And in the coronal and sagittal images, there is also a thickening around the aorta. So there is aortic cuffing, there is perirenal soft tissue, there is metaphyseal sclerotic lesions. This typically happens in a type of non-Langerhans cell histiocytosis, that is Erdin-Chester disease. This is quite uncommon, but this can happen. Actually, this is a quiz, so you have to be oriented about this kind of atypical findings also. The most common kind of histiocytosis is Langerhans cell histiocytosis, whereas this is a non-Langerhans cell histiocytosis. The perirenal soft tissue that you saw in this case, that is also alternatively called as hairy kidney sign, and in aorta you will find a circumferential thickening of the aortic wall, that is called as coated aortic sign. This is also a spotter. If you see the left temporal area, there is prominence of the temporal horn, atrophy of the hippocampus, and then in the FLAIR images also hyperintensity. So this is typical for mesial temporal lobe sclerosis. This is BZ-Pack iodixanol and isoosmolar agents. It is isoosmolar to blood, so the osmolality will be 290. Whereas the normal iohexol that we use, that has osmolality of 600 to 800. And ionic contrast usually have a osmolality of 1400. This iodixanol is basically GE company has developed it because to use it in patient with renal issue, so that post contrast nephropathy incidence will be reduced using iodixanol. This is also a clear-cut answer, that red tail sign you see in patients with achalasia cardia. Sonazoid, Tara already taught you in the morning. This is a second ultrasound contrast agent available in India. This, along with the SonoView, this has an additional advantage of Kupffer cell imaging, which will allow you to image even after 10 minutes of contrast administration. So, with a limited amount of contrast, Sonazoid will provide you a wider window period for imaging. This is typically uptaken by the Kupffer cells, so the contrast remains for a longer period in the hepatic parenchyma as compared to SonoView. This patient recently came to our department. This patient is a case of hilar cholangiocarcinoma with obstructive biliopathy, and someone outside reported it as a right sided hepatic metastasis. So these are the scan was done outside only. This is a multiphagic CT scan. You can see non-contrast. There is nothing. In arterial phase also you won't see anything. Whereas in the portal venous phase you can see a hyper-enhancing lesion, and again in the venous or delayed phases it remains iso-enhancing. The non-contrast MRI, if you see, this is a markedly hypo-intense lesion mimicking the signal intensity of the hepatic vein or IVC or aorta. So it almost confirm it's a vascular lesion. And if you see the MIP CT images, there is also communication with the portal vein, and it is shunting into the hepatic vein. So it's a portosystemic shunting with a aneurysmal dilatation, which mimicking like a hypervascular liver tumor in patient with hilar cholangiocarcinoma. And this patient's this lesion was cystic on ultrasound, and it was showing turbulent flow. I have the ultrasound image, but I haven't kept here. This is also a straightforward case, pancreatitis with a mid splenic artery pseudoaneurysm. The typical embolizing method that we use in case of splenic artery pseudoaneurysm is the sandwich technique. We block both anterior and the posterior, that means the front door and back door of the aneurysm, to prevent the refilling through the collaterals. So the sandwich technique is used to embolize the splenic artery pseudoaneurysm. This patient had a right shoulder swelling. If you see carefully the images, there is no bony abnormality. Every calcification which is you are seeing here is around the joints, and if you see carefully the images in the first and third images, there are multiple cystic spaces and you can see fluid calcium level. These are quite characteristic. This is also called as sedimentation sign. No bony abnormality, amorphous calcification around the joint with fluid calcium level is characteristic of tumoral calcinosis. It's a benign condition, nothing to do with malignant transformation. So the diagnosis will be tumoral calcinosis. The close differential will be a chondrosarcoma, but in chondrosarcoma there will be involvement of bone and you won't get the fluid calcium level. This is also a spotter that typically involve the costochondral junction, a soft tissue with chondroid pattern of calcification, and lobulated soft tissue typically involve the costochondral junction in an elderly male. The diagnosis will be chondrosarcoma of the anterior rib. This patient also recently presented to the emergency, 23-year female with left-sided lumbar pain. CT was done in our department. If you see carefully, there is gross splenomegaly. The entire of the spleen is almost gone except from the few remaining enhancing parenchyma. And if you see carefully, this is a rounded type of soft tissue, somehow showing swirling, which is called also as whirlpool sign. So this is a case of wandering spleen with splenic volvulus causing near complete splenic infarction. So the answer will be splenic volvulus with splenic infarction. And this is the whirlpool sign. In such cases, the treatment will be straight away splenectomy because spleen has almost gone. Even if with splenic torsion, splenic parenchyma is relatively healthy, then you can go for splenopexy. So this is the post-op images. You can see there is torsion around the splenic pedicle and there is infarcted and enlarged spleen. And this is also a straightforward case, post ERCP cases, and you can see there is pneumoretroperitoneum. Because of pneumoretroperitoneum most oftenly happen with rupture of the retroperitoneal structure, and in ERCP, the gastroenterologist poke around the D2 segment to cannulate the biliary tree. So it's basically retropneumoperitoneum due to duodenal perforation secondary to ERCP. This is Monteggia fracture. This is basically ligamentum venosus. This is IVC. This is caudate. In some patients, artery goes through the ligamentum venosum. So when you are doing a caudate lobe drainage, you have to see whether any artery is traversing through the ligamentum venosum or not. Usually either accessory left hepatic artery or replaced left hepatic artery, both can go through the ligamentum flavum. But the incidence wise, the most common artery that traverses through the ligamentum flavum is the replaced left hepatic artery. So the answer here will be replaced left hepatic artery. And this artery that goes through the ligamentum venosum is also called as vessel through straight sign. And a study that included around 400 patients, they found the most artery that was traversing through the ligamentum venosum was the replaced left hepatic artery, and second was the accessory left hepatic artery. This case, you can see there is a right adnexal lesion, and in right adnexa, if you see few components are cystic, few components are tubular, means tubulocystic, and there is surrounding inflammation. So this is basically a complex tubo-ovarian abscess, and if you see in T1 weighted images, you can see there are thin rim of T1 hyperintensities. So what happen in case of inflammations? There will be granulation tissue formation, and because of the granulation tissue which are quite vascular, there will be microhemorrhages within the granulation tissue, and because of the microhemorrhages, usually in patients with abscess or abscess cavity in MR, you will find a slightly T1 hyperintense rim. This is also quite common for tubo-ovarian abscess. If you have a dilemma of ovarian malignancy versus tubo-ovarian abscess, this T1 hyperintense rim sign also helps. This kind of T1 rim sign has also been described in the bone, which is also called as the penumbra sign. Apart from this finding, if you see, there is a uterine diadelphys. There is two separate uterine cavity, and if you see, the vaginal canal is distended with fluid. So because of the transverse vaginal septum, there will be accumulation of the blood products causing hematoculpus along with uterine diadelphys. And in the coronal images, left kidney is present but right kidney is absent. So it's basically a obstructed hemivagina with ipsilateral renal agenesis, and this is also called as the Oria syndrome. This is basically a Mullerian duct abnormality, and the contralateral part is Jenner syndrome. Jenner syndrome usually happens in male patients, and this patient presents also with the ipsilateral renal agenesis, but this patient has a seminal vesicle cyst with ejaculatory duct obstruction. This is if you see the mammogram, it's a hyperdense lesion with spiculated margin. So this is basically a BIRATS 5 lesion, but I have mentioned it's already a biopsy proven lesion, so it will be BIRATS 6, because anything which is biopsy proven, mammogram category has no roles. It straightforward goes into the BIRATS 6. So this will be a BIRATS 6 lesion, because it is a biopsy proven lesion. If it is not a biopsy proven lesion, upfront mammogram was done, then this would be a BIRATS 5 lesion. This is typical ice cream cone appearance of acoustic schwannoma. This is you can see there is a right lower lobe pathology, and there is a thick rim of consolidation around a ground glass opacity and also area of cavitation. So this is basically reverse of the halo sign, that is called as a reverse halo sign, and also called as the barred nest sign, because this looks like a barred nest. And this is quite if you find a reverse halo sign in a patient in a background of immunocompromised or uncontrolled diabetes, if you are seeing cavitation, if you are seeing a thick rind of consolidation around it, this is quite specific for pulmonary mucormycosis. Pulmonary mucormycosis, basically mucormycosis is an angioinvasive fungus. So because of the angioinvasion, this patient may present with torrential epistaxis, torrential hemorrhage, and this patient usually needs debridement. Usually medical therapy won't suffices, and if you want to start medical therapy, either voriconazole or amphotericin B should be started. This is straightforward cometal artifact. And come to the next. This is the avulsion of the lateral lateral tibial condyle, which is called as the second fracture. Whereas if there will be avulsion from the medial tibial condyle, there is the reverse second fracture. And if there will be calcification around the medial femoral condyle, that will be the Pellegrini stridal lesion. And ACL avulsion will be basically from the tibial spine, that will be separate from the tibial or femoral condyle. And this is the last quarter, that you can see their kidneys are replaced with cyst. Few of them are hyperdense because of hemorrhage, and there are also multiple cysts in the liver. So this is a straightforward case of autosomal dominant polycystic kidney disease. Thank you. We have the winners for the quiz. The third prize goes to Shruti from AIIMS Bhubaneswar and Bimal from AIIMS Bhubaneswar. The second prize goes to Aryaman Mukherjee from AIIMS Bhubaneswar, and Sumedha Sirohi from KIMS Bhubaneswar. The first prize goes to Aksha R from KIMS Bhubaneswar. Aksha has scored 44 out of 50 points. So a huge round of applause for all of the winners. Now all the winners please come to the dais for a group photograph. Poster, paper and quiz competition. Please all the winners come forward. Poster winner, e-poster winners please come forward.